Welcome to Chicago. I hear we have a few people from Canada here and other places around, so we're so excited to have you today. My name is Linda Ostosky. I am president of the Judy Nicholson Kidney Cancer Foundation, and today we are honoring you. You are the heroes that have showed strength, courage, and love. Today is all about celebrating hope, sharing, and caring with each other. We have a full day with fabulous presenters to give you the latest information on kidney cancer and to share their stories with you. We ask you to be involved, ask questions, and get to know your neighbors and get new connections. That's what it's all about. We have other board members that are here today. Linda Anderson, who I'm sure most of you know her through connecting with her in registration. We have Rachel Rusma, Megan Kelly, and Joel Stern. Please visit our vendors, and we are here to help you. So if you have any questions throughout the day, please contact one of us. It should be a great day, and we're just so excited to have you here. So please be involved, ask questions, and get to know each other. And we'll be serving lunch later. You're allowed to bring your food in here. So anyway, let's start the day.
It's an old picture.
It gets better today, right?
Good morning, everybody. We'll put this over here. One of the bad things about having stage 4 cancer is you have salivatory problems. Anybody here besides me? Thank you. Yeah. So we'll go to the water every few minutes. I also have another confession to make. I've never given a presentation high and admitted it. I am on methadone and OxyContin. I'm having terrible spine pain right now. But we'll see how it goes. It's a little bit different. Welcome and thank you for being here today. First of all, thank you to the Judy Nicholson Kidney Cancer Foundation and Linda Ostosky and Linda Anderson for putting this together. It takes a lot of folks to put this together, and the amount of time and effort and energy and passion that they all put into this is something that's worthy of being recognized. I'd also like to thank our speakers, including doctors that take time out of their busy days. I don't know where they get the time to come here and spend time with us. They are absolutely incredible, and hopefully you'll get to know all of them today. If not, please look them up afterwards. They are helping to prolong our lives and give us quality lives, and I couldn't be happier for that, because when I was given this diagnosis 2.5 years ago, I never thought I'd be here today, and I thank Dr. Hammers and thank some of my other oncology team and urologists and nephrologists and radiology oncologists and psychotherapists and everybody else for helping me. I also want to welcome and thank all of you here, both our patients and our caregivers. Our first presentation is about the importance of caregiving, and I can't underestimate the importance that needs to be placed on what the caregiver role is and how important that is to us. And it's a role that nobody in their right mind would do for a lot of money. And ironically, they don't get any money to do this, and they do it in an unheralded way. And so I commend all of you. A little bit about my cancer story. I was introduced to cancer at the age of 5 when my mother was diagnosed with breast cancer that had mets all over her body. Years later, I looked at her records, and they said basically a 6 months prognosis. Fortunately, she was a fighter and didn't pay attention to records and prognoses, and she lived to the age of 20. And I got to see her fight, and I never appreciated it, but the lessons that she taught me there as a little kid, watching her fight with such courage and tenacity and passion and will to see her kids grow up, is something that I've learned now with this diagnosis, and hopefully I'm imparting on my 3 daughters and 3 grandchildren. In 2007, I was diagnosed with prostate cancer. In the scheme of things, that was relatively easy. I was cured 5 years later. That machine out there was the machine that, not the exact machine, but I had the Da Vinci robot that took that prostate out. PSA went down to less than 0.03, and it's been there ever since, and I thought I was done with cancer. In November 18th of 2020, I was diagnosed with stage 4 renal cell carcinoma. It was found incidental to any pain in my kidneys. The issue was I had a 9 centimeter tumor located on my iliac that was destroying my iliac and causing significant damage to my spine. When they did the CTs and MRIs, they found many lytic lesions up and down my spine from the base of my skull down to my hip. And then they found this little 4-centimeter kidney tumor that was causing absolutely no harm. Such little harm, they said, we're not going to worry about that right now. We're going to worry about the bones. I was immediately put on immunotherapy, Opdivo and Yervoy. They radiated my hip when the pain got too much to deal with, similar to what it feels like right now. I was put on Exgiva once a month to keep my bones strong. And then 18 months later, based on an excellent second opinion from my friend Dr. Hammers, we decided to take out the kidney because the kidney was starting to grow a little bit, but my bone cancer was stable, and it was really nice to get. I didn't realize the psychological advantages of getting rid of that cancer that was in your body that you learned to live with for so many months. It's a marathon and not a sprint. I've said that before. I'll say it again with tons of ups and downs. I've been lucky. I've had lots of ups. Right now I'm in the down stage, but I will sooner than later get back on the up stage. I'm not worried about that. Most recently, we found a new growth on my spine. We're looking to do proton radiation. I had an epidural Friday that really didn't do much. We're also looking at some other things right now, including cryoablation and other things. But I've had to shut down my tennis game, my golf game, and my Peloton game, and I'm one very unhappy camper. But in the scheme of things, I still get to see my grandchildren every week, and that brings me joy and happiness. So what I want to share a little bit today is lessons learned from my journey, that many of them will be similar to yours, and many of them will be different. First of all, it's critical to have the best medical team out there you can get, and folks with RCC expertise. There is, in my view, a correlation between the ability to live a prolonged and quality life and the medical care you get. I'm not happy about that. I don't think it's right. But the bigger cities, the bigger hospitals, the hospitals that do research, the reality is you're going to get a level of care that is different than you will in small town USA or small town Canada. Palliative care is a critical piece of the puzzle. And what's amazing to me is I still talk to people today who think palliative care is hospice. No. All hospice is palliative care, but not all palliative care is hospice. Doctors, like Dr. Hammers and the others we're going to hear today, are incredible at treating our disease. But no offense to them, they don't necessarily spend the same amount of time on nutrition and pain management and side effects and the financial toxicity of dealing with cancer that we need that we're not getting. And that's where palliative care comes into play. I've been taking advantage of palliative care since day one. Never in my life did I ever think I'd be taking anything for anxiety or depression. I am now on a boatload of meds. Never in my lifetime did I think that me as a strong man and caregiver of my family is going to get mental help on therapy. And I have, and it's been very helpful. So please take advantage of it. It's typically offered as part of the hospital care you have. If you want to learn more about it, I'm happy to educate you. Please ignore Dr. Google and the internet. We all go to the internet the first time we or a loved one gets this diagnosis. In 80 to 90% of what we see on there is wrong, misleading, or bad. And it doesn't contain the latest and greatest research out there that wasn't out there when these studies were done. And you know, if you keep reading the same thing over and over again, you're going to start to believe it, and that's going to lead you down a slippery slope that you don't want to have to deal with. Second opinions are good. Hi, Charisse. Hi. Charisse used to work for me at Nalmuff, and her husband is a kidney cancer survivor and winner. Thank you for being here. Second opinions are great. If you go to your doctor and they say, what do you mean you need a second opinion? Am I not good enough? Radar should be going up, guys. It is important. There are brilliant doctors out there, and brilliant doctors often disagree with each other. Unfortunately, this is not easy cookie cutter dealing of a disease. It is very, very complex. And the more opinions you can get from different perspectives, the better you're going to have. Be your own best advocate. Challenge, probe, ask, probe again, challenge, ask. Don't be intimidated by your medical team. You deserve to understand what they're doing the options, the pros and cons. And when they tell you it's not their choice what you do, ask them the question they hate to be asked, but they can't get around it. What would you do if I were your son? Or now I've changed it, what would you do if I were your father? Which tells you how old I'm getting, right? Don't ignore the mental aspects of this disease. It is harrowing. For me, I've always said the mental pain of dealing with this disease is harder than the physical pain. I'm reassessing that right now because of the physical pain I'm having, but seriously, the mental pain, which is invisible to many, but very visible to all of us, can take a toll, so please focus on that. Live and focus in the moment. Don't worry about where you're going to be 2-3 years from now. Focus on what you're going to do tomorrow and do the best to enjoy what's tomorrow. Adhere to the 30-minute a day rule that I created for anxiety. I would love to tell you not to spend time being anxious about this disease and wallowing in self-pity, but I'd be dishonest if I told you don't do that. But what I can tell you that works is every morning at 1 a.m. I wake up, or I have been up for an hour or two, and I put my alarm clock on, and from 1 to 1:30 I wallow in self-pity. Woe is me, why me? Couldn't it happen to somebody else, right? And at 1:30 the alarm clock goes off and I'm done for the day. And at 2 p.m. the next day I'm starting to feel bad or guilty. I say, not until 1 a.m. the next day. It's a really good technique that I promise you works. Anxiety for today just ruins tomorrow. Anxiety for tomorrow just ruins today. You spend so much time worrying about what tomorrow brings, you forget that you're feeling pretty good today and you have an opportunity to enjoy it. It's a badge of strength to get help and to have our caregivers get help. Our next speaker is going to be talking about the importance of caregiving. This is an area, every one of you who is a patient should be asking your caregiver, what can I do for you to make your life easier? And I need you strong so you can be strong for me. You need to stay physical as much as you can. That gets a little bit challenging when you can't do much, but it's important to push yourself to get that shower the next day and get up and walk 3 miles a day in California and take pictures and share with people in your community. Surviving isn't enough. We talk about survival. I would challenge everybody and suggest to you that we need to be thrivers, not just survivors. So I would aspire to be thrivers with this disease. It is possible. In order to do that, I recommend creating a bucket list, not because you're dying, but because you're alive. I have created the last 2.5 years a bucket list of things that I never, ever imagined that I would be doing. If you look at my left arm, you will see a giant warrior tattoo after I said to my 3 daughters, I will kill you if you ever get a tattoo. But I did it, and my wife has one on the back of her neck, and it says warrior. And every time we look at each other, we just laugh at the time we walked into the tattoo parlor, and they go, are you sure you're in the right place? You two don't fit here. But we did it. I was going to go skydiving this summer. That has been temporarily postponed, but we're going to do that. Focus on enhancing your legacy. You know, for me, it's writing. I love to write, as you guys know. Just read my Thankful Friday post or take a copy of the book out there. But that helps me. It's cathartic for me. Join boards of kidney cancer associations or triage cancer organizations. Help others. Don't waste a moment when you're feeling good. Become more spiritual and define that in any way that works for you. It could mean a lot of things to different people. Find hobbies. Find things that you can do that you can enjoy. Pay it forward. That's why many of us are here today. Be a mentor. Join Immerman's Angels. Join a board again. Join Facebook communities where you can make a difference and help people that are steps behind you in dealing with this disease, deal with this disease. Dream, hope, plan, implement, and enjoy. In addition, having a great network is critical. I have Team Stern, and I know many of you have seen Team Stern. That's my wife, my 3 incredible daughters that all live within 12 minutes of our house, and my 3 amazing grandsons that you probably are sick and tired of seeing pictures of. Tough luck. Develop friendships with people. There are so many people around this room that I consider friends, and my life is so much better because of the friendships that I've developed. Take care of your caregivers. Join Facebook communities. There's two that I would strongly recommend: the Judy Nicholson Kidney Cancer Foundation and the, the Stage 4 Journey with RCC. If you don't know about that, let me know. But it is incredible power of community in dealing with this disease. In closing, having renal cell carcinoma, whether it's stage 1, 2, 3, or 4, or all of the above, is not a death sentence any more than being born is. Unfortunately, we're all going to die. I have asked every doctor I've seen, can you stop me from dying? And I'll pay you whatever you want. I'll do whatever you say. And none of them have acknowledged that they can do that. It's not possible. But we don't know when we're going to die. I tell the story. 2 weeks ago, I was out having dinner with a friend, and I ate a piece of steak, and I swallowed it, and I couldn't breathe. And I'm thinking to myself, I'm going to die of choking on a piece of meat and not renal cell carcinoma? And we have no idea when our time is. Stop worrying about it. Live, love, life, enjoy. Yes, we have more challenges than the average person that's healthy, but that doesn't mean we can't be up to it. Stay hopeful, stay purposeful, stay optimistic, stay strong, stay courageous, and keep that sense of humor, even if it's a warped one like I have. I expect to see all of you here next year in whatever event we decide to do. And now I am honored to basically present our first speaker, Dr. Teresa Deshields from Rush University, who's going to talk about the challenges in cancer caregivers. Thank you very much.
So I'm Teresa Deshields. I'm a psychologist. I have spent my whole career working in cancer in medical centers. I want to thank the Judy Nicholson Foundation for having me here to join you all today. And as you heard, I'm going to be talking about caregivers because I feel like, as you see in the title here, these are our unsung heroes. And so how many people here in the room are caregivers? Okay. All right, got a few. And some of you who also have a cancer diagnosis may be caregivers as well. I understand there can be a lot of duality in that role. So let's just dive on in. So disclosure, I serve as a consultant for AstraZeneca. That's my only disclosure. And also just all of the images on this are available through Microsoft. So I don't have any proprietary images. I also have on my slides, it may be too small to see, but I have references. So if you're wanting to read further about anything on those slides, the references are at the bottom. The print gets a little small. If you can't see them and want to know what those references are, just feel free to ask, and I'll be happy to share the slides or share the reference. So who is the family caregiver? And I want to just spend a moment clarifying that because there are healthcare professionals who are professional caregivers. There's many levels of caregivers, and who I'm talking about today is, we sometimes call them family caregivers, informal caregivers, unpaid caregivers, just to try to distinguish them from people who do the paid work of caregiving. But it isn't necessarily always a family member, so that label can be a little misleading. But this is the person who's providing unpaid care and health-related assistance to someone with a medical illness. So that's who we're talking about. And because I'm an academic, I'm going to start out with a little bit of data, but I hope you find the data illuminating about what the realm of caregiving is actually like today. So this reference is fairly recent, from 2020. 53 million Americans served as caregivers in the previous 12 months. So that's a pretty sizable chunk of the population doing caregiving work. Here's a little more statistics. So 48 million caring for adults, so not caring for their children. 20% providing unpaid care to an adult with health problems. So there's other reasons why somebody might need care, but this is about health focus. 24% caring for more than one person, and 61% are trying to work in addition to caregiving. And that's been one of the, we might interwoven through this talk, one of the things we'll touch on is demographic changes in our society that have made it more complicated for caregivers. And one of them is that many caregivers are now trying to work and do caregiving. And it wasn't that way 50 years ago. So that's a big challenge. Who is the caregiving recipient? The most common recipient of care is a parent or in-law. The next most common is a spouse or partner. Next most common is a neighbor or friend, but you can see the top four are relatives, but also wanting to acknowledge that sometimes it's not a relative who's providing the care. I found this statistic at the very bottom, again, from 2020, very interesting. So 74% of caregivers over the age of 75 are caring for someone over the age of 75. And working in a hospital, I would see 90-year-old caregivers coming in with their 70-year-old adult child, or 80-year-old caregivers coming in with a spouse. So, as people are living longer, we have older caregivers caring for people, and sometimes younger than them, sometimes older. But so a lot of people who might be dealing with their own health issues who are trying to provide care as well. A little more data, then we'll get into the stuff that's more fun. So just as average in terms of what caregiving looks like. So the average number of hours per week that a caregiver is providing is 24 hours of care. Average is 4.5 years of caregiving, and with 29% of caregivers providing care for more than 5 years. 58% help with medical and nursing tasks, and we were talking at the beginning about how much medical care has moved into the home. In the time I've been working in healthcare, just to all that now happens on an outpatient basis that used to happen in the hospital. And so there are some complicated things, wound pumps, wound vacs, all kinds of things happening in the home that's made that more complicated. 23% of caregivers say that their health has adversely been affected by this. And the way I see that happening the most is just pushing off their own doctor's appointments. The caregivers sometimes get so focused on their loved one, they delay, put off, ignore their own symptoms, their own appointments, just to focus on their loved one. 18% report high financial strain, and you were talking about financial toxicity earlier, and so that's a very real thing. So in terms of cancer caregiving, I couldn't find data quite as recent. This is for 2019, but over almost 1 million adults in the U.S. care for someone with cancer as their sole health problem. And as you can see, the hours of caregiving in cancer caregiving is more. So the average is 33 hours a week, and 32% of caregivers provide more than 41 hours per week. And again, as I said a few moments ago, these are often people who are working, who are also providing this level of caregiving. It's a lot. It's a lot. Okay, this was a statistic that I ran across at some point. We talked about demographic changes in our society, right? So families are smaller. Families are more geographically dispersed than they used to be. So in 2010, there were 7 potential caregivers for everyone who needed care. As this was an estimate by the AARP Public Policy Institute. In 2050, it's projected that there's only going to be 3 potential caregivers for everyone who needs care. It's just a challenge of the way our society has evolved. There's going to be a pinch there, right? Just in terms of who's available to help people with their care needs at home. We're going to have to figure out something. I remember having a discussion one point with a speaker who was saying, talking about hospice care and how, we'd love to see hospice care happen at home. And it's like, well, one of the things we got to grapple with, if we've got all these caregivers working and hospice caregiving tends to be 24-hour, around-the-clock caregiving, how's that supposed to work? We've got kind of that'll be a challenge. So something for us to address. Tasks of caregiving, so 43% perform complex medical tasks. And when we talked about all the equipment that comes home, the care that comes home, the complicated medication regimens at home, there's a lot that caregivers are challenged with. 82% communicate with providers, and you know how hard that is. I remember having a conversation with a person who's like, I left a message. I waited all day. I was afraid to leave the phone because I was waiting for the call back. I just ran out to the mailbox. The call comes in while I'm at the mailbox. And the call doesn't answer, the message does not answer the question. Just like, sorry, we missed you. Give us a call back. Here we go, all over again. I mean, it's just, it's difficult. It's quite a job. 54% discuss what their loved one, the person with cancer, needed, not necessarily their own needs. You see only 29% discussed what they needed to help them to do caregiving. What caregivers do, so many things. Support for symptoms, maybe just helping dealing with feelings about what's going on. Just cooking meals, looking for infection and problems. I've talked with caregivers before who, even in the medical setting, when their loved one's getting chemo, but that worry about when the nurse might tell them, okay, this is what if you're having a reaction, this is what it'll look like, and the loved one feeling like, oh my gosh, this is on me, I've got to sit there and watch and make sure they're okay and nothing bad's happening. And so a lot of responsibility, feeling a lot of responsibility. Help with non-medical problems. Life goes on, right? There's not just the medical things to deal with, there's the rest of life, and sometimes that gets pushed more to the caregiver as their loved one's not feeling well. Dealing with insurance and bills. Oh my gosh, I don't need to say anything more about that, right? I mean, this is just kind of unfathomable sometimes. Helping with medications, which can be very complicated, and sometimes different schedules, and just trying to manage all that. Now, in honesty, caregivers vary quite a bit in just their own ability to deal with this, right? Some people roll with the people up for anything, some people aren't, so trying to deal with just what happens to fall in your path for caregiving. Also just really the tolerance for medical settings. My father, whenever my mother was in the hospital, my father all of a sudden had a whole lot to do. He hated being in the hospital. So it was up to us daughters to kind of be in the hospital and helping there. He hated medical settings. It was not something he could do easily. So, sometimes that's something a person's comfortable with, sometimes people aren't. And it can be a stressor for the person who's not comfortable with medical settings, who wants to be there, but just it's not their thing. It makes them anxious. It's they struggle with it. So here's what caregivers have told us they want help with: financial issues, communication with the medical setting, medical professionals, getting help at home. That can be so difficult, right? Just getting competent help, but also reliable help, trustworthy help. Learning care tasks, learning what to do. Some people feel like they come out of this caregiving episode and feel like they should have gotten a nursing degree. They should be granted a nursing degree for all that they learned to do. And then end of life issues, whether you're at the end of life or whether that's just something that you've become more attuned to because of this health problem dropping into your lap. And then dealing with family. I have a couple slides later about the long distance caregiver, which I was that for my parents. But I was talking to a friend who was the local caregiver for his family, and he was saying, that it's tough, the communication piece, not just doing the caregiving, but everybody wants me to update them all the time, and sometimes I'm just tired. And it helped me to appreciate that, my sister who was the local caregiver, maybe I should not be like, why didn't you tell me about that doctor's visit right away? All right. So this is an interesting phenomenon. So I talked about how caregivers are affected by this work. So initially, at the beginning of caregiving, caregivers look like the general population in terms of their own health. Over time, caregivers start to develop problems with fatigue, sleep difficulties, cognitive difficulties, feeling overwhelmed. Their brain just doesn't work quite as well as they would like. Here's a specific statistic that 40% of cancer patients have sleep problems. 42% of caregivers report sleep problems. So kind of comparable. Now, I once heard a sleep expert say that sleep problems are not exactly infectious, but if you share sleeping space with somebody, their sleep problem can become your sleep problem. But also, I've had many caregivers tell me that they feel like they need to be on alert. So their sleep difficulties sometimes come from the pressure to feel like I need to be listening for problems or alert to problems. So the difficulty of just shutting down and relaxing. In terms of emotional well-being, so this was actually from something I published last year. We compared the emotional well-being of cancer patients and caregivers. Now, these were not matched pairs. We just didn't have the ability to pull that together. So, and what we found is that in terms of answering the question, how distressed are you, which if you've been in a cancer setting, you may get that question with distress screening becoming a thing. We found that they were pretty comparable, the caregivers and the cancer patients, with a distress of 6.7 for caregivers, 6.4 for patients, so a little bit higher for caregivers. We also looked at resilience, and we're going to talk about that in a minute, is the ability to bounce back. So bad things happen, but resilience is your ability to bounce back afterwards, and they were pretty comparable in that regard too. Caregivers were 3.6 on resilience, patients were 3.8. Now, we also measured depression and anxiety, and what we found is that while patients were slightly higher in ratings of depression and anxiety, you can see from those numbers it's only slightly higher. So we tend to think of course, the person with the diagnosis is struggling, but caregivers can struggle too. Their lives have been upended by this as well. So you can see comparable depression, comparable anxiety. So a lot physically going on for caregivers as well as emotionally. Rates of depression and anxiety, this was other people's work. So studies of caregivers, a study of caregivers of lung cancer patients, and 16% of the caregivers were depressed, 42% were anxious. And what they found in that study, because they did have dyadic pairs, the caregiver and patients were related, is they found that one's anxiety or depression would affect the other, that they tended to be high together or low together, but they tended to impact each other. And then one study that looked at depression in advanced cancer, and you can see a flip where the caregivers have higher rates of depression in advanced cancer. Okay, so just a slide here about why caregivers are as distressed as patients. One, the same uncertainty about the illness, right? I mean, they're still dealing with that same question of where's this going, what's going to happen, we don't know what to expect. Some of it can be being unprepared for the caregiving role. Back when we used to live in multi-generational households, people participated in caregiving throughout their life. They got to see caregiving up close. And now that families are more geographically dispersed and we don't tend to have that multi-generation, people just aren't as exposed to caregiving and might feel really uncomfortable with it or like, I don't know what the heck I'm doing. This less support from others, we were talking about that also at the beginning. So people in social circles tend to get focused on the person with the diagnosis. I get that. And most caregivers tell me that's absolutely the way it should be. I want people to focus on my loved one. But and not that many people are asking the caregiver, how are you doing? How's it going? Everybody's asking them how their loved one is doing. So it's kind of a neglected group. And even in the healthcare setting, we tend to get focused on the person with the diagnosis and maybe not so much attention to the caregiver and how they're doing. So I think that it's a setup for caregivers feeling a bit neglected. And their lives have also been turned upside down, right? I mean, they're also maybe taking on more responsibilities, juggling medical appointments, juggling all those tasks that we talked about. So caregivers are also, their lives have been unsettled without perhaps the same degree of support. I said I think I've got like 2 slides about distant caregiving. So 7 million Americans are distant caregivers. And we've talked about already the demographic changes that have made that more common as families are more geographically dispersed. There are more people trying to do distant caregiving. There are higher costs, so financial toxicity, again, associated with distant caregiving. Most of that might be due to travel, but also having to pay for help in the home. So it's more expensive to be a distant caregiver. And there's some data that suggests that there's greater emotional distress the farther away you live. So 47% of caregivers who lived let's see, who lived far away. I didn't put all that in there, did I? So the 47% are the ones who lived the farthest away, and they were more distressed than those who lived with the caregiver at 43%, and those who lived an hour, less than an hour away. Which is kind of an interesting statistic. Look how low that distress is, 28%. That seems to be kind of the sweet spot. You know, you've got a little bit of space, but you're not so far away. That seems to be the easiest, is that living less than an hour away. All right, let's talk about benefits from caregiving. I've been talking about all the hard stuff and doing a lot of data. Let's talk about benefits of caregiving, because those have been documented as well. Caregivers report heightened spirituality and faith. They get pulled closer to their faith. Many report feeling like they've grown as a person from doing this work. And many caregivers report a sense of meaning, that I'm doing something important, that I feel a sense of purpose about what I'm doing. So those things can be very gratifying. Other benefits, time spent together. You know, that whether it's sitting in a waiting room, whether it's sitting in an infusion center, whether it's driving to appointments, caregivers talk about, you know, we actually got to spend more time together. And maybe they prioritize time together, or maybe it just incidentally happened because of the medical care. Many caregivers talk about the opportunity to give back, especially if it's a parent, to say, you know, this person raised me, all they did to give me the life I have, and I want to give back. Also, being aware of what's going on. I did, again, I was a distant caregiver for my parents, and I felt like sometimes I'd drop in and be like, what the heck happened? Because I had a disconnect, right, from what I'd seen last time and what I saw this next time, whereas the caregiver who's there, they see it evolve, and they aren't quite as disconnected from how things are changing. Many caregivers talk about the relationship being strengthened. Now, one little caveat I want to say, because I'm talking about these benefits, and they are real, there are many benefits of caregiving. I want to say some of the most difficult situations I've seen in my work as a psychologist are caregivers who are caring for somebody, but it's a strained relationship or a difficult relationship. Maybe this person has been abusive of them. Maybe they don't like the person. Maybe the person's just mean to them. But there are some people who take on caregiving for people that there's not a lot of benefits that come from it, but they feel like this is something they need to do. That's a tough spot where you don't get the benefits. There's not joy that comes from increased time together and knowing what's going on. So that's a caveat. So I mentioned about resilience, so we're going to talk about, as a caregiver, how to promote resilience. Okay, so this is the bouncing back part. So self-care. Take care of yourself physically, basic things. Try to eat right, get enough sleep, get some exercise, get some air, find ways to relax. There's lots of them, so find some ways what works for you. Be kind to yourself, and that means judgment to yourself. So being kind, just trying not to judge yourself harshly when things don't go well or you make mistakes, but to be kind to yourself. Attitude adjustment. So we talked about some other attitude adjustments, things like being in the moment, trying not to get too far into the scary unknown, but being in the moment is one way, one type of attitude adjustment. The other thing, like this idea of it is what it is. You know, sometimes like, I don't like it. Well, sometimes can we find a way to just say, it is what it is. This is not something I get to change, and how do I roll with that? I know it might look nice and pretty there, and it's a lot harder to maybe actualize, but it's a goal to aspire to, and it might be something that a counselor can help with if you feel like, I just can't quite come to terms with this. Humor makes everything better, everything. So if you can find a way to laugh, even in awful circumstances, finding a way to laugh can be helpful. It can just lighten those moments that can be so difficult and distressing. And finding a way to laugh with your fellow caregivers, with people here, can be very healing. gratitude work. There's been a lot of research coming out, and I didn't put a reference for some of the research coming out about this, but the benefits of gratitude work, and it's as easy a practice as maybe, at the end of the day, thinking about one thing you're grateful for. It doesn't have to be complicated, it doesn't have to be profound, but something you're grateful for and just centering yourself on that, just the activity of identifying something you're grateful for has benefits. And so I don't mean, again, you have to do a lot of work on this, but again, something you can do at the end of the day or sometime during the day to try to appreciate something like what a beautiful sunset it was, or the temperature was pleasant, or we didn't sit, I got through to the doctor's office right away or something. All right, that's it. That's all my presentation. Oh, I do want to add in one more thing. You maybe think about that. Just support, caregiver support. So Gilda's Club is here. They have caregiver support groups. There are also online organizations that have support groups for caregivers. So it's nice to go to one, but if you don't feel like you have the time or you don't have a location near you, there's online support groups. Emmerman Angels provides peer support for caregivers as well, not just for individuals with a cancer diagnosis. So besides this group, there's support available.
I wish we had the next speaker available to me when I was first diagnosed with cancer, because I would have loved it rather than going to Dr. Google and trying to figure out what's wrong with me and how do I figure out the next steps. But we're honored today to have Dr. Janaki Sharma from the University of Miami, who's going to be talking about my kidney diagnosis, explaining the diagnoses and stages of RCC and how they are determined. So thank you very much. There you are.
Thank you everyone for joining us this morning, and a big thank you to the Judy Nicholson Kidney Cancer Foundation for having me. This Chicago weather has been a nice respite from the 110 degrees that we had in Miami this weekend. So I would like to start by giving everyone a brief introduction into the functioning of the kidney and how cancer can develop in this most vital of organ. It sounds like a lot of you in this room are already very experienced, but there's always a little more knowledge to be learned, right? So every person has two kidneys, and I should say almost everyone, because some people are born with one kidney, some people altruistically donate a kidney, or maybe somebody loses functioning of their kidney throughout their lives. But the vast majority of people have two kidneys, and thankfully each of these kidneys functions independently. The kidneys are small organs. They're about the size of a fist. They're located on either side of your spine, closer to the back than the front. And the main function of the kidneys is to help the body remove impurities, balance your salts and minerals, and balance your hydration levels. Kidneys also secrete hormones that control your red blood cell production and blood pressure. During the course of your kidney cancer journey, you may also hear about something called adrenal glands. Adrenal glands are two small organs that sit right on top of your kidney. They're usually not implicated in kidney cancer, but they often show up on scan interpretations, and patients frequently ask about them. So I think it's important to help mention them. Every day, your kidney filters all the blood in your body 60 times. That's equivalent to about 50 gallons of liquid that's pumped into your kidneys, filtered through, and excreted out. From those 50 gallons, the kidney makes about a gallon of urine that's excreted from your body every day. All that, even though your kidney is only the size of a fist. Unfortunately, from normal kidneys, sometimes you can develop kidney cancer. Cancer at a simplistic level is just normal cells that are growing out of control. These growing cells conglomerate together to form tumors. Tumors can be benign, which basically just means that they're abnormal cells growing abnormally, but they don't have the potential to spread. Or tumors can be malignant. Those same abnormal cells start growing more and more and have the potential to spread to other parts of the body. So the obvious question now is, how do normal cells turn into cancer cells? Most of our body is made up of cells. Cells are the smallest unit of a living thing. Cells grow, reproduce and divide, and then die. That's just normal. That's the way our body maintains its normal functioning. Now, in the process of dividing, sometimes a cell will pick up a new characteristic, something that makes it different from the cells before it. In scientific terms, we call those new characteristics mutations. Mutations, funnily enough, are also a normal part of cell growth. Our cells in our body are developing mutations all the time. Most mutations are minor and don't really affect the ability of our cells to keep our body functioning in its normal state. Some mutations are so major that our body destroys those cells immediately because it recognizes the harm that those cells could do. But over time, if a cell acquires enough small mutations that manage to give that cell the ability to grow independently without any concern for what the rest of the body needs or is doing, those cells can multiply and turn into a tumor. Eventually, if those cells continue to multiply, that tumor can form its own blood supply in a process called angiogenesis, something you hear about fairly frequently with kidney cancer because a lot of our drugs that we use target angiogenesis. Once it develops its own blood supply, the kidney cancer can spread to other parts of the body, either through the blood, or it can spread directly invading nearby organs, or it can spread through entering the lymphatic system. And you'll hear a lot about lymph nodes in kidney cancer and other cancers. I like to think of the lymphatic system as the drainage system of the body. It removes a lot of the liquids and toxins from various organs, and that's why you'll hear it a lot in cancer cells, because the lymphatic system is frequently a source of spread. So these new tumors that form outside of the kidney, sometimes close by and sometimes far away, are called metastases. These are the kidney cancer cells that have escaped from the kidney and traveled through the lymphatic system, the bloodstream, or direct invasion, and caused tumors somewhere else. And this is actually a very challenging concept, I think, because when a doctor tells a patient, you have kidney cancer and you have tumors in your liver, most people will think, like, oh no, I have kidney cancer and I have liver cancer, which is much more terrible than just having metastatic kidney cancer. The truth of the matter is that if we were to take a sample of those tumors in the liver and look at it under a microscope and compare it to the tumor in the kidney, you would find the exact same cells with very similar mutations and very similar mechanisms of growth. So even though the tumors are in different places, it's still the same cancer. And that's why, as a medical oncologist, I can give a treatment in a pill form or in an intravenous form, and it can work on all the different sites of cancer that are in your body at the same time. So while kidney cancer can spread everywhere, there are some preferential reasons that it likes to go. Most commonly lung and bone, followed by brain, liver, and pancreas. If this wasn't complicated enough, it turns out that kidney cancer is not a single entity. Many different kinds of cancer can form in the kidney. Renal cell carcinoma is the most common. It's about 85% of the cases, and the majority of today's presentations are going to be covering treatment and support options for renal cell carcinoma. But you can also get something called urothelial carcinoma of the kidney. This is much less common, only about 5 to 10% of the cases, and frankly much more confusing, because urothelial carcinoma normally starts in the bladder. And so patients can have a tumor in the kidney that acts like a bladder cancer and gets treated like a tumor that would have developed in the bladder, but it's still kidney cancer. Rarer still are other types like sarcomas, lymphomas, or neuroendocrine tumors, and each one is treated differently. So the treatment of kidney cancer is far from monolithic. Even within renal cell carcinoma, which is the most common kind of kidney cancer, there are over 30 different kinds. Knowing the details about what kind of renal cell carcinoma you have will greatly help your doctors in determining your treatment. And so the question is, how do we tell what particular kind of tumor a patient has? We rely upon a branch of science called pathology to do this. Usually patients will have a biopsy, or sometimes they might have their whole kidney removed to figure out exactly what kind of tumor it is. A pathologist will take that sample that was removed from a patient's body, slice it into very thin pieces, sometimes apply special dyes that we call stains to them, and then look at it under a microscope. After looking at it under a microscope, they can tell you oftentimes where the cancer came from, some of its special characteristics, and what subtype it is. And it takes pathologists years of training to gain that specialized knowledge, and so I won't pretend to simplify it, but on the left, we have what looks like a normal kidney, and on the right is a normal kidney, and on the left is a specimen from a clear cell kidney cancer patient. Over 30 types of renal cell carcinoma have been identified. Clear cell is the most common. That's the one that we have the most knowledge about, the one that you'll see the most clinical trials for. But there's also a lot of cases of papillary, chromophobe, medullary, and collecting duct. All of these have different treatment options and different clinical trials that are available. And so that initial biopsy is incredibly important to helping determine the best treatment for you and your loved ones. Now that we've determined the how of kidney cancer, we need to talk about the why. And I think this is probably the second hardest question I get asked by patients, because the answer to why did I develop kidney cancer is usually, I'm sorry, but I don't know. Aside from genetic syndromes that run in families, we don't really know exactly why kidney cancer develops in one person versus another. We have identified some risk factors, but even those are not what we call causal. We know that people that smoke, that obesity, have high blood pressure, that have a family history of kidney cancer, that maybe are exposed to some toxic chemicals in their life. Gender plays a role. Men are slightly more likely to have kidney cancer than women, and race also plays a role. Kidney cancer is more common amongst Black people than amongst white and Hispanics. But we don't actually know what are the steps that cause these risk factors to develop kidney cancer. And in fact, if you have one of these risk factors, it's not necessary, or even if you have multiple, it's not necessary that you develop kidney cancer. And for those that may be worried, keep in mind that kidney cancer is a very rare tumor. Fewer than 1 in 5,000 people are diagnosed with renal cell carcinoma in the US every year. Most patients have minimal to no symptoms at the time of diagnosis. And in fact, early stage disease is usually diagnosed incidentally. And what incidentally means is that you may notice some abdominal pain, some stomach pain, so you go to your doctor. Your doctor's worried that maybe you have appendicitis, so they order a CT scan, a CAT scan. Thankfully, the CAT scan results reveal that you don't have appendicitis, you just had some gas, but it also picked up on a 2-centimeter tumor in your kidney. That's called an incidental finding. If you do have symptoms, or if the kidney cancer has spread somewhere else causing symptoms, your possible early symptoms could be hematuria, that's blood in the urine, flank pain or pain in your back, fevers, night sweats, weight loss. And in rare cases where the kidney cancer has already spread at the time of diagnosis, you may have symptoms from the place that it has spread to. For instance, people that have a brain tumor may notice chronic headaches every night that wake them up from sleep. Once we suspect that someone has kidney cancer, and we've often confirmed the diagnosis with a biopsy, we need to figure out how advanced the disease is. And this is where staging comes in. Staging tells us how extensive the cancer is, and we do it because it helps your doctor decide the best treatment. The most common mechanism of staging that we use is something called TNM. The T stands for tumor, and a lower number indicates a smaller tumor. The N stands for lymph nodes and indicates the size, the number, or how far away from your kidney the lymph node is. And the M is the most simple. M1 means you have metastases, and M0 means you don't. After the tumor size, lymph node involvement, and the presence of metastases have been codified, we can determine the stage of the disease. And I think patients really fixate on this because in the world of Google, stage means everything, right? And it is important for us, but I often encourage my patients not to focus on the stage, but to focus on the options that we've given you for treatment. So stage 1, 2, and 3 tumors are localized tumors. They haven't spread far away from the kidney. And stage 4 disease, as all of you are familiar with, means that the tumor has spread far away. Staging can be clinical, or it can be something called pathological. And I bring this up because you'll see this on your reports, and patients will frequently ask, what does that C, what does that P, what do these numbers mean? So if we do your staging with just imaging scans, CT scans, PET scans, bone scans, you'll see a little C in front of the numbers in the TNM system. If it's based on a surgery that we've done, you'll see a little P in front of the number system, in front of the TNM system. The other thing I want to bring up here is that staging, as you all know, is usually done with the help of scans. And patients will often ask, should I get a PET scan? Should I get a bone scan? My neighbor got this scan, why didn't I? And it's important to remember that every patient is different and each scan serves a role in different ways. And so while most patients will get at least a CT scan and a bone scan, whether or not you get additional scans is entirely up to the physician that you're working with and your unique case. I have a couple of more slides about treatment that I won't get too much into because we have a lot of great speakers today that are going to be giving you more details. But as a broad overview, treatment of stages 1, 2, and 3 kidney cancer, which is localized kidney cancer, the goal is to cure the patient. And so we direct these treatments fairly aggressively. The vast majority of these patients with stage 1, 2, or 3 disease will undergo surgery. Surgery to remove the kidney is called a nephrectomy. And the surgery may take the form of complete removal of the kidney, which is called a radical nephrectomy, or based on the position of the tumor and an individual patient's anatomy. Your urological surgeon may be able to get away with removing just part of the kidney and leaving behind some healthy normal kidney to help functioning of the kidneys throughout your life. If they remove just a part of the kidney, that's called a partial nephrectomy. Other patients with higher risk or aggressive tumors after surgery may choose to get additional treatments for several months after the surgery to decrease the chances of the cancer returning. If for some reason surgery is not an option, and that might be the patient's other medical problems, the age, the location, there are other treatment options that are curative, and you'll hear more about these today. They include thermal ablation, which is the use of extreme temperatures to destroy tumors, radiation, or for patients who wish to avoid any of potential complications from treatment, we also have something called active surveillance, where we would do regular scans to monitor the growth of a tumor and make a shared decision with the patient about when to actually intervene. Stage 4, or metastatic kidney cancer, is an entirely different animal. And in general, metastatic kidney cancer is not curable. However, what I like to emphasize is that with new treatments and combined modalities of treatments, patients can live for many, many years with this disease while on treatment. And in some cases, we can induce durable remissions where patients can have several years where they're living without any treatment. The backbone of treatment for stage 4 disease is always systemic therapy. And what I mean by systemic therapy is basically any treatment that we give you that enters your bloodstream and travels throughout your body and is capable of attacking all of the sites of kidney cancer wherever they are. A medical oncologist like myself is typically the one that would be administering systemic therapy to you. And we frequently use combinations of therapies to help increase the chances of the tumors responding and also to increase the amount of time that your tumors are going to respond to a treatment. And it's important to note here that eventually every treatment that you're on or that your loved one is on will stop working. And that's normal. The tumors learn how to grow despite the treatments that we give them. As your doctor, we expect this. And the good news is that we have many different options that attack the tumors in different ways. And so inevitably, when one treatment stops working, we can start you on another one. Frequently, those other treatment options include radiation or local treatments, or they may include a clinical trial. Part of planning for systemic treatment includes something called risk stratification. And I bring this up again because nowadays patients have access to their records and they can see something, and nobody likes to see poor risk on their chart, right? But physicians use this to help guide your treatment. Most frequently, there are several different risk scores that people can use, but the most common one is called the IMDC, or the International Metastatic Data Consortium Risk Score. It looks at different factors such as how functional you are, several different blood counts, how long has this tumor potentially been growing, and puts together a series of risk factors and a number to determine whether you have something called favorable disease, intermediate disease, or poor risk disease. I always emphasize to patients that no matter what risk category you fall into, patients have all kinds of responses to treatments and all kinds of survivals. And so a risk category doesn't define your disease or you as a person. It merely helps your physician to guide the treatment options that you have available. And finally, painting with broad brushstrokes, systemic therapy for kidney cancer generally falls into two categories, about which I'm sure you'll hear much more today. Tyrosine kinase inhibitors on the left are pills. They're taken daily at home. Sometimes patients will get a little bit of a break in between. And they basically function to block the chemical messengers that are telling the cancer to grow. And you'll see a whole list of them on the left side. Immunotherapy is the other major category of treatment that we have for kidney cancer. And that's an IV treatment. It's given in the clinic once every 2 to 6 weeks, depending upon which drug exactly your doctor is using. And immunotherapy works by teaching your own body to attack the cancer cells and bring some of the cancer cells out of hiding. Usually, as I mentioned earlier, your physician will be combining both of these treatment modalities and maybe introducing other oral or IV treatments to help target your kidney cancer and enhance the response. Throughout the day today, you will hear more about the different treatment options in support of cancer services. I want to thank you for your attentiveness, and I'm available for questions.
I have a simple question. I note that you found a statistic 9% with mets going to the brain. That seemed much higher than I'd ever heard before. Is that because we find them more often, or?
So that number has increased, I would say, in the last 5 to 10 years because there has been increased screening at baseline with MRIs. So NCCN is sort of a national guideline that a lot of oncologists will use to determine what's appropriate screening when a patient first presents to you. And doing a workup for brain metastases is not a standard part of the NCCN guidelines at this time. But I think over the years, major cancer centers and kidney cancer specialists have noted that we are seeing brain metastases that are going undiagnosed until people have symptoms. And the brain is kind of a closed space. So if you develop a big tumor in there, it's much harder to treat than a tiny 1 centimeter tumor that we could quickly remove with surgery or even just radiate with highly targeted radiation. So although it's not part of the guidelines yet, most of us are doing an MRI of the brain at the time of diagnoses to help pick up on these sort of subclinical or not symptomatic metastases.
Would you do that only for somebody who's got a large tumor, or officially, let's say, a 6 centimeter, theoretically non-metastatic?
So if a patient doesn't have any other metastatic disease, we wouldn't do an MRI of the brain. But once someone has metastatic disease anywhere outside of the kidney, at least at Sylvester, it's our standard to do an MRI of the brain. Yes?
How often do you just do the initial and then wait for the person to have some form of a symptom? Or like how often would you suggest to do an MRI of the brain?
Because it's not a guideline-based recommendation, I can basically speak to what we do, which is we would do an MRI brain at the time of screening and then at the presentation of symptoms. So routine MRIs of the brain are not part of our clinical practice unless a patient has symptoms or if they had a tumor in the brain to begin with. Yes?
You mentioned one of the risk factors, age. Have you seen an uptick in younger patients being diagnosed with cancer?
So I have not, and to be honest, I'm not familiar with any publications that have sort of documented an uptick in younger patients with kidney cancer specifically. I know that young adults cancer incidence has gone up significantly over the last 10 years. But there's sort of multiple factors that could be contributing to that. I don't know that anyone has a great pulse of why that's happening. Thank you, everyone. It was a real pleasure to be here.
We are going to be flexible, and thankfully Dr. Kuzel from Rush University, the hospital where my daughter graduated from med school, is going to speak on immunotherapy. What if my cancer is resistant to immunotherapy? Doc, I hope you also cover a question that I've heard, and I know they're doing lots of research on, is why does immunotherapy work on some people and not others, and what's the research that's going on in that area? 'Cause that's a question I know a lot of us patients ask all the time, but thank you very much.
I'm happy to do it.
Appreciate it.
Perfect. Thank you for inviting me today. It's a pleasure to be here. Did I double my time? Do I get? I'll take as much as I want then. This will be great. I'm an oncologist, a medical oncologist, and we wear rose-colored glasses usually. Today I couldn't because I'm indoors. But so I'm going to take a much more optimistic view about the outlook for patients with metastatic kidney cancer. And I'm going to take you through really what I do when I encounter a patient in the office, the information I share with them, and what we're hopefully going to work together to accomplish. So first-line therapy is just a fancy term for meaning it's the first treatment you get for your metastatic kidney cancer. I think nowadays we're in an era where we would like to personalize or individualize our treatments. So the first part of my talk, unfortunately, is based on sort of just very broad methods of individualizing that care. Second part of my talk is going to be much more sort of exploratory, hypothetical, thought-provoking, I hope, and I think it'll address some of your questions. So typical patient that I see in the office, 59-year-old African-American female, comes in, she's been diagnosed previously with clear cell renal cell carcinoma. A few years ago, she underwent an nephrectomy. She, unfortunately, 9 months later, develops some lesions in her lungs, confirmed ultimately to have multiple pulmonary metastases as well as some mediastinal and retroperitoneal lymphadenopathy, stage 4 renal cell carcinoma, clear cell type still, of course, and really quite functional. One of the things we assess when a patient comes to the office is what their performance status is. Your doctor may mention that term to you. That just means how functional an individual is. Are they able to go about their daily activities with no symptoms, function, continue to work, raise their family, participate in activities of daily living? Or are they wheelchair bound because of pain and they're brought in by family members and they need assistance? So that's an important predictor for choices of therapy and perhaps outcomes. We measure often some laboratory parameters. The doctor earlier mentioned that risk stratification model. So there's a number of common laboratory tests that we would obtain to help stratify those patients. And in this case, the patient was mildly anemic, otherwise had relatively normal laboratories. So this is what that calculator looks like. Your doctor probably does this in his head in the office. They don't need to go to this, I hope. And generally, it basically plugs in those clinical features, performance status, laboratory tests, and it spits out basically for you your risk stratification here. So it shows intermediate risk for this patient for a variety of reasons. And the reason that's important is because the previous speaker alluded to guidelines. And many of our clinical trials have been conducted in certain patient populations. And depending on those patient populations and the results, the NCCN, the National Comprehensive Cancer Network, has regular meetings, and they will go ahead and try to put together an algorithm or recommendations for physicians as to reasonable choices for this patient. So your doctor goes to the NCCN guidelines and he says, okay, got an intermediate risk patient. So there on the far side it says poor intermediate. What should I treat this patient with? Well, unfortunately, the guidelines aren't, I find, very helpful because they list 5 different choices for therapy for this patient. One of which doesn't have the words Category 1 after it. Category 1 means the highest level of medical evidence, typically a randomized phase 3 clinical trial, showing a benefit for those regimens over a control arm. So your doctor looks at that and says, oh my God, what am I going to do with you? We've got 5 different choices. How can we sort of work through this? So this is a little more granular detail about those clinical trials. These are 4 of the regimens. I'm only showing you the Category 1 choices here. And these are the kinds of data points that are included in a phase 3 clinical trial. Some of these are what we call primary endpoints, meaning it's what led the trial to be what we call positive, suggesting a benefit for the treatment. And some of these are what we call secondary endpoints, which are kind of interest, but really weren't the focus of the approval for the drugs. Now, when you go to medical meetings, people put this slide up all the time. And then they immediately say, I shouldn't put this slide up because we're not supposed to compare cross-trial comparisons, but they put the slide up anyway. And I've done the exact same thing. And I really did it to show you why we shouldn't do this. And that is because these are 4 different clinical trials, 4 different 2-drug regimens. In one case, there were 2 immunotherapy drugs given, and that was the far left, the ipilimumab-nivolumab trial. And in the 3 other cases, there was a combination of an immunotherapy drug and one of those tyrosine kinase inhibitors that the previous speaker mentioned that are basically thought to be anti-angiogenic. So different drugs, different combinations, but also, and very importantly, different characteristics of patients in every one of these trials. So you'll notice that the first line there shows the breakout of favorable patients, intermediate patients, and poor risk patients in these trials. And every one is a little bit different. Not hugely different, but a little bit different. What I didn't show you here is some of these trials required prior nephrectomies. Some of these trials did not. So there were patients in here who had intact renal masses. Why is that important? Because when you try to look at objective response rates, and in particular complete remission rates, if you have patients with an intact kidney, you will never get a complete remission to drug therapy. So you've sort of biased your results a little bit. So most of these trials used progression-free survival as their primary endpoint. Some of these trials included all risk groups. The one on the far left, the immunotherapy trial, did not. Only included intermediate and poor risk patients. So when you look at this, you've got this intermediate risk patient in your office. You say to yourself, okay, what's important here? 12-month overall survival, is that important? So that's where you got to talk to the patient. You look at the patient, you talk to the patient, you say, what's important to you? Overwhelmingly, what I find is patients say, I want to live a long time. Okay, that's an important endpoint. And what I really like to say is, it's not just living a long time. Ideally, you're going to live a long time and have only a limited amount of treatment so we don't ruin your life for the rest of your time on this planet, and give you a durable, long-lasting remission, and I'll be like Joe Biden, cure. So that's what we're sort of shooting for here. So let's look at some of the things that suggest that we actually can achieve that in our patients with stage 4 metastatic disease. So I'm going to take you through the 4 trials. These are what are called survival curves, Kaplan-Meier survival curves. So you've got on the far side overall survival, but this is the curves that I think are important. These are the progression-free survival curves. Now, a number of these trials were just updated a couple of months ago here in Chicago at our ASCO meeting, so I'm showing you sort of the latest data. So this is 6 years out from the start of treatment for these patients. And you can see that by and large, from about 2 years to about 6 years, that top red line, the experimental arm of the combination immunotherapy, is pretty flat. Almost nobody relapses after about 2 years of treatment. So if I use this regimen, and I complete 2 years of treatment, and the patient has had a major response to therapy, sometimes our CTs and our MRIs and our PET scans are so sensitive, I can't say to them, oh, you know, there's a little something still there. I can't call you a complete remission, but I'll call you a very good partial remission, and I may not do anything to you any longer. And about 30% of patients go on and have very long-lasting, durable remissions that are probably cures in many or most of those cases. So this is the keynote trial. This was the axitinib pembrolizumab trial, and in this case, you can see the green arm. This is overall survival. So again, we're out 6 years, and literally 40% of patients are alive. But you'll notice that in this case, now we've got about an 18 to 20% sort of plateau on that curve. Again, after about 3 years, quite durable with these treatments. So this gets to the overall response. This is important. In some cases, patients are symptomatic when they come to the physician. And getting a response means tumor shrinkage, usually at least 30% of what we call measurable lesions. And if you get a response, it often relieves some of those symptoms. Maybe it takes pressure off a nerve, maybe it opens up a lung. So responses can be important. And some of the advantages of the combination of an immunotherapy and a targeted tyrosine kinase inhibitor are they tend to have higher overall response rates, global CR and PR rates. So, you know, here again, kidney cancer, when I first started treating this disease, it was tough. I mean, we had brutal regimens. Dr. Pili and I, unfortunately, are the same era. And, you know, a response rate of about 20% was really exciting. You know, now we're talking 60, 70% response rates, long-term survival. So this is now the checkmate study. This was nivolumab, an immunotherapy drug, plus cabozantinib, another oral tyrosine kinase inhibitor. And again, overall survival statistically favoring the nivo-cabo. And now when you get to that long-term follow-up, it looks encouraging, but again, little shorter follow-up. This was a more recent trial, so we only have about 3 to 4 year, and the plateau, again, starts around 2 to 3 years, and, you know, it's about 30% of patients. Again, objective response rates, almost 55, 60% response rate with this combination. Overall survival now, this is the CLEAR trial. This was a trial of lenvatinib plus pembrolizumab. So again, IO plus a tyrosine kinase inhibitor. Look at this. I mean, overall survival, we got out 5 years, over 50 to 60% of patients still alive in this cohort of patients. And if you look at the progression-free survival, again, you've got about 30% of patients. So when I choose these regimens and I talk to patients, their families, I'm usually emphasizing, look, my goal is to get you to a durable, complete remission. The question is what the best combination is, and it may differ slightly for different patients. There may be some patients who aren't great candidates for double immunotherapy. There may be some patients who aren't great candidates, frankly, for a tyrosine kinase inhibitor. So I try to balance side effects. So again, response rates with the CLEAR trial, 70%.
Doctor, question for you. The surveys that show Cabo and Opdivo, do they differentiate in the dosage of Cabo, 20, 40, or 60? Because
So
a lot of
people
have trouble tolerating 60.
So in the combination trial, 40 was the recommended starting dose, not 60.
Good.
So it was dose reduced because of anticipated issues with tolerability. And this is tolerability. So we're in the Midwest, so this is called the tornado plot. And the tornado plots basically are a great way to look at side effects. So in this trial, this was the nivo-ipi, two-drug immunotherapy versus sunitinib, a tyrosine kinase inhibitor. So on the left are the side effects of the immunotherapy combo. On the right are the toxicities of the control arm, the single-agent oral tyrosine kinase inhibitor. And in the middle, the slightly darker shades of orange or blue, those are what we consider serious toxicities, grade 3, 4, even 5, life-threatening toxicity or fatal toxicity. And you'll see that immunotherapy has a typical spectrum of side effects. It tends to focus sort of autoimmunity, so patients may develop autoimmune hypothyroidism, pituitary problems, type 1 diabetes rarely. Patients can develop inflammatory liver disease, bowel diarrhea, and those are all autoimmune. They're treated with steroids. Turns out when you look at the rates of some of those toxicities, sunitinib does the same thing. Tyrosine kinase inhibitors have side effects, as you alluded to, and common diarrhea, fatigue, hand-foot discomfort, mouth soreness, a lot of different problems develop here. So again, you need to sit with the patient, kind of figure out what they do for a living, what they do for their activities, maybe which treatment might be tolerable, maybe which treatment's going to screw up their lifestyle completely. This is the Keynote trial, pembroexitinib. Again, you can see a little bit more symmetrical tornado here, kind of on both sides, about the same distances. Giving these combinations of an immunotherapy and a tyrosine kinase inhibitor can be really complicated because you can get diarrhea from the tyrosine kinase inhibitor or you can get it from the immunotherapy. So when a patient comes into your office who's on pembro and axitinib, for example, and says, I'm having diarrhea, now you got to sit there and think a little bit. Say, God, is it really bad diarrhea? Is it maybe mild diarrhea? Should I stop one drug? Do I stop both drugs? How do I want to manage this? So it can be a little bit confusing and, frankly, a little bit of trial and error. Here's the Nivo-Cabo trial that you alluded to. You'll see that some of these adverse events are so significant that patients stop treatment. Quarter of patients had to stop treatment. Some stopped one drug, the nivolumab, some the cabo, but about 7% both. So toxic regimens, side effects, not unusual with these. And again, with lenvatinib and pembrolizumab, maybe even a little bit more in the way of hypertension. This drug, lenvatinib, can really cause hypertension, which can be difficult to manage. But again, diarrhea, mouth sores, hypothyroidism, hand-foot syndrome. So a lot of things need to be nuanced and thought about when you talk about it. You want to balance the efficacy with the side effects for a patient.
Just a quick question. If you have to keep dropping, say, the milligram of the TKI, like the cabo, does that greatly affect the outcome as well?
So all of these trials allow dose reductions. So when you have a dose reduction, that was built into the trials. So I tell patients, look, some of the patients, in terms of the outcomes, also had dose reductions. So don't feel bad. Don't feel like you've got to beat yourself up and can't function and you're going to be a hero and just struggle through it. No, we're going to dose reduce it, make it manageable. It's more important to keep something going than nothing going. All right, so just a summary of these 4 trials. Again, as I mentioned, things to discriminate. So grade 3, 4, or 5 are the serious toxicities I mentioned. You'll see that the 2-drug immunotherapy has about a 50% grade 3 rate. Everything else is up in the 60s and 70s. So these regimens are serious. They need to be monitored by your physician closely. You need to be in touch with his office, nursing staff, ancillary people to make sure that if you're having side effects, you report them. And you'll notice a couple of these trials reported the use of high-dose steroids, and that's to suppress autoimmune toxicity. Only 2 of them did, and it's about the same, actually, whether you give combination therapy or TKI plus a single IO. So all of this should factor into that calculation that you're thinking about. Now, that was an intermediate risk patient, a little bit more what we think of as serious threatening disease. What about favorable risk patients? So again, turn to the NCCN guidelines, get up on the website, and favorable risk, you've got actually 3 of the same regimens. The ipilimumab, nivolumab is not because it wasn't studied in that group of patients. Doesn't mean your doctor can't give it to you, and I've given it to patients with favorable risk disease. It just means that because the study didn't include those patient populations, the NCCN doesn't put it on their website. Unfortunately, insurance companies often look at the website to see if what you're giving is appropriate and whether they'll reimburse it. So sometimes it requires a little massaging with the insurance company, but you can almost always sort of get that approved. So these are the first-line regimens. As I said, the Ipi-Nivo didn't include that on the left. So the 3 that did are shown here. And what's interesting is if you look at this progression-free survival now in the favorable risk patients, you've got these are called the confidence intervals, and you'll notice that the axi-PEM overlaps 1, which means actually statistically it was no better than the single agent tyrosine kinase inhibitor. The other two did shift away to the favoring the combination, even in the favorable risk patients. But you'll notice response rates remain high in this group of patients, complete remission rates remain high. So these are 3 reasonable choices. But again, this favorable risk population spans a real gamut of individuals. It may be a patient with just 1 or 2 lung nodules that are picked up on incidental scanning years after their diagnosis. And the real question is, do you need to treat them at all? And I think the previous speaker mentioned active surveillance, and that is something that we actually will do for some patients. I know there's another talk on future consideration, so I'm going to be like a newscaster. I'm going to tease the talk without stepping all over the information. 2 drugs are good, 3 must be better, right? So this is a trial looking at the combination of the ipilimumab, nivolumab, and cabozantinib. So now we've gone to 3 drugs, and we're going to compare it to 2 drugs, ipi/nivo. This was intermediate poor risk patients, 40 milligrams, again, of the cabozantinib. Here's the high evidence of efficacy, and you'll notice that the 3 drugs do have a significant improvement in progression-free survival. That's the only endpoint that's been reported so far, so it's very early data, not even 2 years really of follow-up in this study. And a couple of points. 1, there's a separation of the curves. 2, we're up to almost 55 or 60% progression-free survival with 3 drugs for metastatic kidney cancer, intermediate poor risk population, strikingly good. But interestingly, the control arm of ipi/nivo did much better than the last trial I showed you. So there, again, maybe something about these trials, something about these patients that are a little bit different. And again, this is very early data. You'll notice that the reason patients came off study, one of the things we look at is progression of disease. And you'll notice in ipi/nivo, about 20% come off for progression, only about 8 with the 3-drug regimen. So more patients are coming off maybe for side effects, because the side effects were real. This is what's called a waterfall plot. This looks at responses, and you'll notice that with the 3-drug regimen up top, you've got everything from the second leftmost bar is a responder. It's taken more patients to respond. So there is some increased bang for your buck, so to speak. But the bang for your buck comes in the form of toxicity. So grade 3, 4 adverse events, liver toxicity, hypertension, all much greater with the 3-drug regimen. So that's the balance. Other trials that are ongoing, and there's a lot of them, and that's, I'm sure we're going to cover that in the next presentation. I'm just going to show the slide. Lots of drug development going on. Some of these in clear cells, some of these in both non-clear and clear cells. All right, so you asked the question, is there, the tool I just showed you really just looks at some clinical features, puts you into one of 3 buckets. It would be great if there was something that we could do to identify an individual patient in the office. Are you going to respond, or are you more likely to respond to immunotherapy, for example? So I'm going to be just a little provocative, show you some sort of very preliminary scientific kind of stuff that could be something, and I'll show you some stuff that maybe you want to think about, which maybe you can modify to help your responsiveness to immunotherapy. So this is data looking at the gut microbiome, and that just means that's the bacteria that's in our bowel movements. So it turns out that the gut microbiome can predict an individual responder to immunotherapy. There's a number of studies which have quantified and qualified the nature of the bacteria in our bowels, and shown that it can be associated with outcomes that are favorable versus unfavorable to immunotherapy. In addition, it turns out that if you take mouse models and these mice don't have any gut flora to begin with, and you populate their gut flora with the flora from patients. So the top one is a responding patient. You take their gut flora, put it into the mouse, inject a tumor into the mouse. Similarly, you take a non-responding patient, inject their gut flora into the mouse, put the tumor in. The non-responding mice all progress. The responding patients actually don't. So there's something really mysterious about our gut microbiome that influences the systemic immune response to these drugs. This is a slide that shows you how complicated this is. I said you could do this in the office. You really can't. This is the kind of thing that would require some pretty sophisticated laboratory setups to get a stool sample, get the data back sort of in a real-time fashion. But this group identified what were sort of beneficial versus harmful clusters of bacteria in the GI tract. And they then went to a series of different models. They did a separate cohort of patients with lung cancer, and they showed that indeed their good bacteria again showed better outcomes. They did a prospective trial on lung and kidney cancer. Again, good bacteria did better than patients with bad bacteria. And now even further trials where they're exploring sort of this concept. There are trials underway where we give fecal transplants to non-responding patients and can convert them to a responding patient. So it's clear that the gut microbiome is important. So testing it would be great because then we might predict you're more likely or less likely to benefit. But could we do things to also sort of, as we treat patients, be helpful? Well, one of the things that have been shown over and over again, including a cohort at Rush in lung cancer, is that antibiotics affect the response to treatment. So, we're all guilty of going to the doctor with a sore throat and saying, give me an antibiotic. And, it's a virus most likely. You don't really need the antibiotic, but we all feel better taking it. So in this case, it's actually harmful for a variety of reasons, one of which is it's going to perturb your GI tract microbiome. And study after study has shown that taking antibiotics either before or during checkpoint inhibitor therapy reduces your risk or your benefit rate. So the take-home message is don't push for antibiotics unless you really need them. A lot of people every winter, I got bronchitis every winter, just give me a Z-Pak so I can take it. No, don't do it. It may actually harm your response to treatment. And this is the fecal transplant sort of data. You can show very nicely that if you take patients with good responses, do the transplant, you can convert them into people who get responses. So again, it's kind of gross, and hopefully it would come in a capsule or something, so it wouldn't be so bad. But yes, at some point, we may suggest that you take a fecal transplant before you take your immunotherapy. All right, just to close, a few other points regarding treatment of kidney cancer. So I mentioned earlier that favorable risk group patients sometimes will have only a handful of lesions. That's called oligometastatic kidney cancer. It's got a technical definition of less than 4 to 5 lesions that are metastatic sites. And there's a long, long history of recognizing these patients with kidney cancer. And you can either have it synchronously, so your patient presents and they have a kidney tumor and they have maybe one lung lesion at the same time, or they can have it remotely, where the kidney came out years ago and now they've got 1 or 2 lesions that have been picked up on a scan, perhaps. So does everybody need those harsh systemic therapies I just talked about? Well, maybe not. So we have a long, long track record in kidney cancer of doing resections for metastatic disease. And we know that we can cure probably 25 to 35% of patients if they have a solitary metastatic site with surgery. So can we push it from 1 lesion to 3 or 4 lesions? That was the point of this data set here that was presented not long ago. And basically, it showed that if you can undergo complete metastatectomies, up to 4 lesions to 5 lesions, you've got a really different survival. And again, we're out 10 years here versus patients without that completion metastatectomy. Now, some of these patients may have gone on to get other treatments, but it's clear that there are certain sites of disease that are favorable for this approach. So lung lesions, pancreas lesions, adrenal lesions, thyroid lesions, those are sort of somehow special sites. So a patient who presents with lesions in those areas may be quite amenable to a good long-term durable remission just by doing surgery and sparing them the toxicity of our current treatments, or at least delaying the need for those treatments. Of course, you trade that for perioperative mortality, about 1%. Nowadays, though, with the Da Vinci robots out there, you could go play with those. Much safer surgical techniques, much less invasive surgical approaches, so that hopefully we can drive these numbers down to further improve the risk-benefit. So now we also have technology that's called stereotactic radiosurgery. So rather than having a knife cut you, these are very, very focused, tight radiotherapy beams. We use them all the time for brain metastases and kidney cancer. But you can now also do body parts, lung lesions, lymph node lesions, fairly easily. And this is a trial that showed that you could deliver this very nicely, treating patients with oligometastatic disease. And again, 1 year freedom from another treatment, 91+%. So again, do you need to take those drugs right away? Maybe not. Maybe there are some alternative approaches that could be done to buy time. Certainly appropriate if you have an older individual, maybe an individual who has pre-existing autoimmune disorders, Guillain-Barré history, Crohn's disease, ulcerative colitis, where you can't use a checkpoint inhibitor. Maybe these might be ideal approaches for that selected patient population. And I'm going to close just with a plug for a clinical trial. This is basically a trial that's asking the question in these rarer patients with oligometastatic disease, is it reasonable to delay systemic therapy by doing something like stereotactic radiosurgery? So I'll put the plug in for it. Clinical trials are always something we should always push with our patient population. Thank you. I know there was supposed to be a group discussion, but I don't know how we're doing questions.
Yeah, I realize there's no simple answer to this question, but when you're on a TKI or immunotherapy or combination, and you've hit durable remission or stability after a period of time, there's some in the medical community that say if it ain't broke, don't fix it, stay on it, the side effects are bearable. There's others that say after a year, after 2 years, after some period of time, it's no added value. And then there's insurance companies who try to play doctor and tell you what they think as well. Do you have a view on that?
So, my dogma for the pure immunotherapy play is based largely on some melanoma data, and I will treat people for 2 years and I'll stop. So if they've had a very nice durable remission, I get to 2 years, I'm done, and I'll encourage them to be just watched closely. If they have an intact kidney at that time, I almost always will recommend taking it out now, because about half the time I'll see some residual kidney cancer in that tumor specimen. The other half, just it's mush, and I took a kidney out. I didn't need to probably, but I think for peace of mind, it's valuable. The trials of IO and TKI didn't really have a time limit. It was basically kind of, if you have a durable remission, keep going until toxicity or progression. The reality is, I showed you, 30% of patients are having these durable, long-lasting remissions. Taking a tyrosine kinase inhibitor for years is really hard, and patients will wear down. And taking an immunotherapy drug after 2 years, I've seen people get a toxicity in year 3 or year 4. So I usually try to identify the really good responders, and I try to weigh the risks and benefits of stopping. Maybe I'll radiate a single residual spot, but I'll try to get them off. They're toxic financially, they're toxic physically, and being on no treatment, patients don't appreciate how bad they feel until they're off treatment. And then they say, wow, I really felt bad.
Other questions? Okay. Thank you very much.
Great, thank you all.
So we're going to go straight to Dr. Msaouel. Hello. Hi. Welcome. It's Joel Stern. It's great to meet you. We have a great audience out here. We've talked about clear cell. We're looking forward to hearing you present on the rare forms of cancer that many people seem to have or are fighting every day. So thank you.
Of course. I've had a pleasure. Good morning from Houston. My name is Pavlos Msaouel. I'm an assistant professor at the Departments of GU Medical Oncology and Translational Molecular Pathology at MD Anderson. Apologies I could not be there with you all in person due to family reasons, but I would like to sincerely thank the organizing committee for inviting me to talk on rare kidney cancers, a topic that is certainly near and dear to my heart. Let me share my screen, which you should be able to see now. And let's see, these are my disclosures pertinent to this presentation is that I have served on advisory board committees with BMS and Excellences and have done non-drug and educational programs for Sykes and Pfizer, whose products will be discussed today. And as shown in this slide, when we say kidney cancer, we actually refer to multiple diverse diseases. Clear cell kidney cancer is the most common histology, and it's found in about 75% of all cases. However, the remaining 25% is comprised of a diverse number of subtypes under the umbrella term non-clear cell kidney cancer. Sometimes these days we might hear the term variant histology kidney cancer. It's the same thing. It just means that it's not clear cell. And each of these subtypes has a different prognosis, different biology, different response to therapy. And however, we should be mindful of the simple fact that each individual seen in the clinic in a way has the most rare disease in the world because only he or she has it. And that's the frameworks that we have been developing to help patients with the so-called rare kidney cancers can actually help all patients with cancer. And shown here is the tremendous progress achieved in the past 15 years with multiple powerful new therapies approved by the FDA for clear cell kidney cancer, the most common type. And this includes targeted therapies, immunotherapies, and their various combinations. Of note, however, all these approvals were based predominantly, or in many cases exclusively, on data from trials done in clear cell kidney cancer and not the other histologies. And a reason why research in more rare kidney cancers is lacking is the mistaken notion that they are much harder to study. So much so that some researchers are advised by their mentors that studying rare tumors is equivalent to academic suicide. And clearly I disagree with this, and we'll show you all today why we can all together advocate for more research in rare kidney cancers and other rare diseases. But before we start thinking about rare kidney cancers, we need to understand what I call the first law of data analysis. And here is a question that we ask of our hematology oncology trainees to answer at MD Anderson. There is no trick to this question. It actually applies to all kinds of studies, whether they're experimental, observational, randomized clinical trials, etc. The question is, as the number of patients enrolled in a clinical trial increases, the probability that the estimates, the results obtained from the trial include the truth, A, increases, B, decreases, 3, remains the same, 4, I have no idea. And the majority will will answer that the larger the sample size, the higher the probability that our estimates will include the truth. Only 5% answer that the probability decreases, and 80% are more savvy and answer that it remains the same, whereas a few did not feel that they know the answer. But the correct answer is that paradoxically and very counterintuitively, as the size of the study increases, the probability that its confidence intervals, its estimates, will include the truth decreases. And it is not just physicians that get this wrong. Because large quantities of data are now available to researchers, this phenomenon has been labeled the big data paradox. And it is a major reason, actually, behind the unreliable predictions made from the 2016 US general election polling data sets and many subsequent election forecasts around the world. Nature, which is one of the most prominent academic journals, published a few years ago, 2 years ago, another instance of the big data paradox, whereby Delphi Facebook, which is the largest public health survey ever conducted in the United States to date, wrongly predicted the COVID-19 vaccine uptake in the United States. And because the big data paradox is fundamental to the way we interact with reality, it was also recently shown to occur even in data sets from particle physics experiments such as the Large Hadron Collider. And I think that a picture here is worth 1,000 words. The gray line here corresponds to the actual proportion of individuals around the country vaccinated every month during the first half of 2021 for COVID-19. This is what actually happened in the gray line. The three other lines are the predictions that were made prior to 2021 based on three different surveys. The blue line corresponds to the huge Delphi Facebook survey performed in 250,000 individuals. It consistently got every prediction wrong. The green line is a smaller survey in 75,000 people that did better than Facebook. And then in red is a much more smaller study in only 1,000 individuals that almost every month, as you can see, predicted correctly and included the correct numbers in its estimates. And this is, by the way, why Facebook is not going to conquer the world anytime soon. But why does this counterintuitive big data paradox even happen? To understand it, we have to learn about what we call the relevance-robustness trade-off that happens in all of medicine. The term bias shown here is the opposite of patient relevance, which is what we care about. We can either use the term bias or patient relevance. They measure the same thing, just in opposite directions. Relevance is what measures the truth about our patients. It answers the question, is my inference true for my patient? And as shown here, the longer the distance between our estimate and the truth, the higher the bias, and thus the lower the patient relevance. Now, variance is the opposite of population-level robustness in our estimates. They again measure the same thing, variance and robustness, but in opposite directions. And robustness is what measures the degree of random error, we call it, in our estimates. It thus answers the question, how close to each other are my estimates from a group of patients? Traditional confidence intervals we use in medicine are a measure of robustness. The higher the robustness, the more narrow the confidence intervals. And there will always be a trade-off between relevance, patient relevance, and robustness in our inference. So less flexible statistical models will have lower patient relevance but high robustness, whereas more flexible models will have high patient relevance but lower robustness. And so the key task is always to find the sweet spots that best balance patient relevance with robustness. This is the holy grail of personalized patient care. And Kelly Liu and Xiaoli Meng published in 2016 a brilliant article that starts from very first principles and naturally builds up all of the schools of data science while trying to answer the simple question, how should we treat a specific patient in clinic? And so perfect robustness would be to just randomize everything. If we do that, then we don't need to think about potential confounders or any other aspects of what we call the underlying causal network. However, despite what some people think, randomization certainly does not balance our patients. It is a different process known as conditioning that actually balances our patients. This is why we cannot randomize our clinical decisions. We don't just flip a coin when we make decisions for a specific patient in clinic. Now, randomization inference is a very, very powerful approach that was originally developed in the early 20th century to optimize agriculture of crops. And it has a lot of value in medicine, but we have to always remember that our patients in clinic are not plants. On the other hand, perfect relevance would be achieved if we knew every single thing about our patient in clinic, their biology, their environment, their goals and values, even the Krebs cycle. But this is unattainable in practice, which is why there will always be a trade-off between relevance and robustness. But remember these terms, use them and teach them to everyone. And as patients yourselves, always advocate for yourselves and ask, how is this finding relevant to me? At the population level, we're interested in robustness in our societies and healthcare system, but every patient cares about their disease, their specific circumstances, and their goals and values. And while we cannot perfectly accommodate them, we can still try to do a little bit better. Now, the reason why the big data paradox happens is the relevance robustness trade-off. And here is why. Let's say we want to find the truth, which is shown here, but the truth is always beyond our senses, which is why we have to create models of the truth. But these models will inevitably always contain some bias. They will be less relevant for our patients, as represented here as the distance of the model from the truth. And when we do studies with small sample sizes, then we obtain wide confidence intervals, wide error intervals that are likely to include the truth, as shown here. But the more we increase the sample size, the more our intervals will narrow and thus be less likely to include the truth that we're interested in. And thus studies with large sample sizes can yield misleadingly narrow confidence intervals around heavily biased results. And this applies to any cancer and any disease, whether it's common or rare. To address the big data paradox, we utilize three different non-mutually exclusive remedies. As shown here, when the sample size of a randomized control trial or other experiment or observation is small, then the corresponding wide confidence intervals may include the true value that we're looking for. However, as the sample size increases, the quality of the gathered data may decrease, and this can be addressed by maintaining high quality data throughout the study. And towards this goal, for example, our department has adapted our Prometheus informatics system to focus on data quality by explicitly providing more details on the origins of the data used in the analysis. And the second mechanism behind the big data paradox occurs because as the sample size increases, the diversity of our patient population may also increase, resulting in both increased bias and increased irreducible error, even if the data quality remains consistently high throughout the study. And this can be addressed by both anticipating and modeling the differences between each patient before and during data collection. This is exactly why we introduced in the field of structural causal modeling to oncology, and why we carefully collect correlative blood and tissue samples from our patients to be used for fundamental, basic, and translational mechanism. And the last mechanism occurs because as the sample size increases, the standard error, the confidence interval shrinks, and the total error of the estimated results is mainly due to what we call irreducible error and bias. This will occur even if the enrolled patient cohort is highly homogeneous, highly similar, and data quality remains consistently high throughout the study.
And our informatics team is addressing this through the use of error intervals that represent both the bias and the standard error. At the same time, we maintain epistemic humility because there will always exist some degree of error that we cannot accurately account for. Now, these frameworks were actually developed to tackle renal medullary carcinoma, RMC, which is a kidney cancer, a rare kidney cancer that predominantly afflicts young individuals of African descent. And we have used these solutions to the big data paradox to generate scientifically relevant and robust knowledge, which in turn has spurred academic funding and interest. And the same thing can be done for other rare and common kidney cancers. And in addition, we're also utilizing patient advocacy and support groups, social media, as well as state and federal activism to raise awareness of and support patients with RMC. And our uniting goal is to eradicate this horrible disease. And similar now patient advocacy efforts can be developed and are being developed across different kidney cancer subtypes. That is why you're now seeing efforts by other rare histologies, such as chromophobe kidney cancer, to take advantage of these frameworks. And here are some actual numbers showing how progress can be made to help our patients with kidney cancer. When it was first described in 1995, the average survival of patients with RMC was only 4 months from diagnosis. And from that time until 2011, this improved to only 7.7 months from diagnosis. But in 2012 was the year that Chris Johnson died of RMC, prompting his mother, Richie Johnson, to kickstart her tireless advocacy to raise awareness and push for research in RMC. Chris's passing also motivated his oncologist, who is also my mentor, Nizar Tanir at MD Anderson, to develop a dedicated RMC program. And by 2014, we started seeing the first patients, such as Herman Connor, whose stage 4 RMC was resistant to initial therapy, but became cured using second-line therapies that we developed for RMC. By 2017, the average survival of patients with RMC had improved to 13 months, thanks to these efforts, as reported by Amishi Shah and team. And our fellow, Justin Lebenthal, is currently analyzing our most recent outcomes from 2020 onwards, when we're seeing the average survival to have improved to about 18 months. But this is not enough. We still lose far too many patients with RMC. But as our research efforts continue to accelerate, we have set the following realistic benchmarks. We will get the average survival to 24 months by 2025 and to 5 years, 60 months by 2030. Our goal is to get to the point where RMC is prevented, diagnosed early, and cured in all patients. These benchmark goals hold us accountable to our patients. And let's now dive deeper into our current knowledge of rare kidney cancers. And broadly speaking, there are 4 types of systemic therapies used for the treatment of kidney cancers. The first is cytokine therapy, such as IL-2, to which most kidney cancers, other than clear cell kidney cancer, do not respond well. The second is what we call targeted agents. And the third is immune checkpoint therapies that harness the body's immune system to recognize and kill cancer cells. And the last is classic old school chemotherapy. And how to choose between those last 3 treatment options will depend on the exact type of kidney cancer each patient has. This is why it is so important to properly diagnose the kidney cancer subtype. And many kidney cancers listed here are resistant to standard chemotherapy, but are potentially sensitive to the targeted therapies used for the treatment of the more common clear cell kidney cancer. On the other hand, some kidney malignancies listed here are sensitive to chemotherapy, but are resistant to most or all of the targeted therapies used for the treatment of clear cell kidney cancer. In addition, renal cell carcinomas with what we call sarcomatoid differentiation may sometimes respond to chemotherapy in combination with targeted agents. Targeted therapies, which usually come in the form of pills, are reasonable options for many, but not all. kidney cancers. And of these agents, cabozantinib is preferable nowadays for papillary kidney cancer. And by studying what we call their immune microenvironment, we can discern the following scenarios for different kidney cancer subtypes. For clear cell kidney cancer, the immune cells are already going to the tumor, but those immune cells that need to be activated, for example, by immunotherapy. The good immune cells need to be activated. For papillary kidney cancer, the second most common type of kidney cancer, we need to both bring more immune cells in and activate them. Whereas chromophobe kidney cancer is what we call cold. It doesn't have immune cells in it. And thus, our first task will be to figure out how to bring those immune cells in these tumors. Now, renal medullary carcinoma and other types like collecting duct carcinoma contain a lot of immune cells that are, though, working as bad immune cells. They actually inhibit immunity against the cancer. And it is therefore our goal to try and remove these cells before activating the good immune cells. Now, because chromophobe kidney cancers are so much more immunologically cold than, let's say, papillary kidney cancers, the clinical responses of chromophobe kidney cancers to immunotherapy are very low, as shown here, unfortunately. Moving on to specific therapies for distinct subtypes, outside of clinical trials, here are a few recommended strategies that are relevant for papillary kidney cancer. Cabozantinib is nowadays a preferred first therapy for this disease. And as shown on the previous slide, immunotherapy can also produce responses, although less commonly than in clear cell kidney cancer. And other targeted options can be used as second or third line therapies. And molecular testing may reveal relevant targetable alterations to drugs such as alectinib or crizotinib. Chromophobe kidney cancer is an unmet need, but we often favor surgical resection of the metastatic disease, even if it is in the liver, because chromophobe kidney cancers are much more likely than other kidney cancers to spread early to the liver. Because chromophobe kidney cancers are generally resistant to immunotherapy and targeted agents, we really push for surgery and or radiation whenever possible. Otherwise, we can use targeted agents, and immunotherapy may also be considered if no other options are available. Translocation kidney cancer is actually the most common kidney cancer in children and young adults in the US, but it may be tough to recognize because it often mimics the appearance of other kidney cancer subtypes. Think of translocation kidney cancer whenever you encounter a cancer that seems more like a mix between clear cell and papillary in young patients, especially women who have a history of chemotherapy during childhood for malignancies or autoimmune disorders or for bone marrow transplant. There are multiple types of this disease. The most common is TFE3 translocation, whereas TFE beta translocation is less common but often has better prognosis. And we're now finding actually that some kidney cancers, particularly in older adults, may be due to TFE beta amplification and not translocation. Now, the management of these translocation kidney cancers is challenging because these tumors are often resistant to all therapies, but we will often start with immunotherapies, which produce responses in about 20% of cases, or we can try targeted agents as listed here. The kidney cancers with fumarate hydratase, F8 deficiency, can be due to either germline mutations, in which case they're associated with what we call the HLRCC syndrome, or less commonly due to what we call sporadic mutations in the F8 genes. And these tumors have a unique metabolic profile that makes them particularly vulnerable to this therapy of bevacizumab plus erlotinib, which impairs the uptake of glucose by the cancer cells. Thus, this combination is an excellent first-line therapy for this disease. But targeted agents such as cabozantinib can also produce responses. There is less experience with immune checkpoint therapies. And in our experience at MD Anderson, while these cancers can sometimes respond to immunotherapy, they are unfortunately less likely to do so than other kidney cancers. Thus, we recommend at least trying bevacizumab plus erlotinib before considering immunotherapies, particularly in patients with aggressive disease that need to be quickly cooled down. RMC, as mentioned before, is a very aggressive cancer. We almost never do surgery up front to remove the kidney. Even if no metastatic disease is seen, we start with chemotherapy up front to cool down the disease and then only remove the kidney after at least 4 to 6 cycles of chemotherapy. The preferred first-line therapy is platinum-based chemotherapy, particularly carboplatin plus paclitaxel, and recently published data support the use of gemcitabine plus doxorubicin as second-line therapy for RMC, and EGFR inhibition with erlotinib is a third-line options. Never use anti-VEGF TKIs or conventional immunotherapies. They do not generally work against RMC. Collecting duct carcinoma is another aggressive kidney cancer arising from the renal medulla, but it is usually found in older patients. We're now realizing that it is a diagnosis of exclusion and actually much less common than other types of kidney cancers. So you should put a lot of effort in diagnosing what exact subtype of this it is and how to treat it. It is similar to RMC, but may be responsive to cabozantinib, whereas RMC is not, and may respond to chemotherapy as shown here. The role of immunotherapy remains to be defined. And in heavily pretreated patients, there are case reports of some targeted therapies that may work. Lastly, what we call unclassified kidney cancers are, as expected, very heterogeneous. The aggressive variants often harbor mutations in NF2, SED2, and other genes. The number one goal with them is to try and classify these cancers by sending pathology slides for review at a tertiary academic center, by looking for clues from the patient's family history or any other clues from the labs and physical exam. And we may try regimens such as immunotherapy or targeted agents. So in summary, although most non-clear cell kidney cancers are resistant to standard chemotherapy, it is actually the preferred therapy for certain rare subtypes such as renomedullary carcinoma. Similarly, some kidney cancers are resistant to targeted therapies and immunotherapies. Therefore, knowing which kidney cancer subtype we're treating is key, and we urgently need novel, biology-driven, target-specific clinical trials for rare kidney cancer subtypes. Do not be discouraged by their rarity. Due to the big data paradox, research and patient-centered inferences are feasible for rare kidney cancers, and lessons learned from rare kidney cancers such as RMC can help patients both with rare and common diseases. Thank you very much for your kind attention. My contact information is shown on this slide, and I will be happy to answer any questions electronically that you might have.
Thank you very much. Anyone have any questions for Dr.?
Yes,
Yeah,
Mike.
Msaouel, thank you. You mentioned some of the challenges studying the rare types of kidney cancer. And one of the challenges is obtaining sample sizes from such a small subset of cancer patients to begin with these types of cancers.
Can you hear?
I was diagnosed with Pavlos in 2020 and underwent a partial nephrectomy. And I had my surgery done at a large hospital in Washington, D.C., and I asked my surgeon what's going to happen to my tumor once it's removed. And, I know it goes to pathology to make sure you have clear margins, and then I'm pretty sure it went into the trash. Wondering if at a hospital like MD Anderson, where I think there's more studies that go into two types of cancers, if the process would be different, but is there something that patients can do today to help future patients in studying these rare cancers? Because I certainly would have wanted my tumor to maybe go somewhere where it could be studied.
What a beautiful question and so important. Indeed, we definitely do not discard tumors here. It is absolutely important that we analyze and understand as much as we can the biology of every cancer as much as possible, within reason. Sometimes, resources may be scarce and it is what it is, but ideally we should analyze them. And in fact, to your question, again, motivated by what we did with RMC, where exactly in order to get it there, we analyzed comprehensively from such a supposedly super rare cancer more than 50 samples from more than 50 patients, and that's what helped move things forward. We are now starting to work with patient advocacy organizations and with other tertiary centers from around the country and the world to allow patients who have surgeries in places that themselves are not capable of doing this analysis to share them with us so that we can both analyze them and create models in our labs, like what we call cell lines and animal models, to move the science forward. Feel free to contact me on my email, and I can help connect patient advocates and patients themselves with these patient advocacy organizations that work with us. This is very, very, very important for the kidney cancer field.
Thank you very much, doctors. Stay well, stay cool in Houston. We appreciate it.
Thank you so much, Joel. Well, first of all, thank you so much for the organizers. This is a terrific meeting, and I think this is, and my colleagues will agree, this is a very special meeting because, really standing in front of you guys, who we are truly working for is very special. And having people, come here with their disease, setting this all up, having pain, and guiding us through this program. So kudos to you all. Good. So I'm going to talk about some new therapeutic strategies in renal cell carcinoma. So I don't want to hurt any feelings. I cannot mention every clinical trial. I will go a little bit in broad strokes across some of the themes I think that are coming back in kidney cancer. But I think what you will probably appreciate is the field is moving forward, testing new ideas, and the participation in clinical trials is absolutely critical. I think that the field is also maturing quite a bit. These are my disclosures. And so, some approaches that weren't a good idea maybe years ago are coming back into being retested. So as you know, the two main therapies that we have right now in kidney cancer is really blood vessel inhibition. These are the pills that carry quite some side effects, as many of you have experienced. And then immunotherapy. Dr. Kuzel really nicely talked about, either pure immunotherapy up front with PD-1 or CTLA-4 inhibitor and CTLA-4 inhibitor, or the combination of a pill and PD-1 inhibitor. I think actually, to be honest with you, this year was actually really important, at least from my point of view. We learned a couple of really important things. Number one is that I think, at least when it comes to long-term follow-up, there's a little bit of a disconnect on the PD-1 TKI combinations where you have this initial very high response rate, but when you look at year 5 or so, the numbers don't look as great as we had hoped for. I find them sobering, quite frankly. And so I think we probably need to really improve and double down a little bit more on the immunotherapy aspect of those combinations. You mentioned triple therapies. One of them went really almost horribly wrong. That is the carbo-nivo-epi, a combination cabozantinib at higher dose at the 40 milligrams is just not combinable, I think, reasonably well with that. Joel asked what's the dose in combination with nivolumab. They had to go down to 40 milligrams because at 60 milligrams dose, the liver toxicity was just way too high. And with nivo-epi, the liver toxicity, I think, is just not acceptable. I think this triplet will not find the time of the day. I think even if the FDA were to approve it, I wouldn't use it. But that doesn't mean that the idea of combining pills with that isn't worth it, because it's probably more an issue of the cabozantinib rather than in principle. So for example, there's a triplet currently in clinical trials. The trial is fully accrued, which actually uses lenvatinib in combination with Merck's PD-1 and CTLA-4 inhibitor. And that's one of the things to look forward to in the future, how that pans out. So some pills are actually not that toxic when it comes to the liver, such as cabozantinib was. Good, so immunotherapy, well, another one. So the other thing I think that we also learned, I think that's important, is if you progressed on a PD-1 inhibitor, there's often very little benefit of continuing it on the next line of therapy. So there was a very important trial called CONTACT-03 that took patients who progressed on nivo-ipi, who progressed on PD-1 TKI combinations, and they randomized patients to cabozantinib alone versus cabozantinib plus atezolizumab, which is a PD-L1 inhibitor. There was no benefit of continuing immunotherapy. In fact, there was only increased toxicity and deaths associated with continuing immunotherapy. Good. So these two groups, and I think one of the things that kind of like defined almost how we treat kidney cancer is that this cancer is to be not sensitive to cytotoxic. You will see some efforts in that regard. There will be more tumor microenvironment modulation. Dr. Kuzel very eloquently talked about potentially the microbiome. I think a lot of work needs to be done in that space, but let's dive into some of this. So again, immunotherapy, I think it's very clear now, was the major move in kidney cancer and long-term outcome. And what he already indicated is this almost plateauish behavior for a third of patients. That number needs to go up. We cannot rest there, but I think it indicates that maybe doubling down on that is a good idea. So ipilimumab is a CTLA-4 inhibitor. It's a completely different target than PD-1. And it's actually really interesting. If you knock it out in mice, these mice, right after birth, they get highly inflamed, essentially turn into one big lymph node, and then die from overshooting inflammation. So that pathway is important. I think it disappointed a little bit in the clinic because the response rate to CTLA-4 alone across tumors is probably only like around 10-15%. That's roughly the same what we see in kidney cancer, but it may help us with the durability of response in kidney cancer. So there have been other agents in development. They gave a lot of side effects, but not really that much efficacy. And so people started thinking about this really unusual target, CTLA-4. And turns out it's actually really complex biology. And maybe we can change the antibodies that we use to tease out a little bit more efficacy and maybe don't make the toxicity too worse. So on the right side, you see ONC392. It's a CTLA-4 inhibitor, but it was so modified that once it binds to the target, typically CTLA-4 is being internalized into the cell. And normally it keeps sticking to the target with the ipilimumab and removes it from the surface of the cell. And people believe that this might be one of the reasons where you get some of these autoimmune side effects. And in this case, they modified the antibody that in the acidic milieu kind of dissociates and comes back, the target comes back to the surface. And for whatever reason, that seems to dissociate, at least in animal models, the immune adverse events, the autoimmune side effects from the potential efficacy. So that's being tested in humans. The drug company has trials in kidney cancer. There's also a trial coming into a consortium where they will test this antibody. On the left side is actually a very interesting variant of another CTLA-4 antibody called botensilimab. It's from Agenus. And that one made the headlines not too long ago because it actually led to a really impressive response rate in normally stone-cold tumors. So as you know, colon cancer typically does not respond to immunotherapy. With colon cancer, I mean like the classic microsatellite stable, the one that doesn't have all these tens of thousands of mutations. You probably heard the news about some colorectal cancers that all responded to PD-1 immunotherapy. That is not the kind of colon cancer I'm talking about. The classic colon cancer that's not based on DNA repair deficits is actually stone cold, and typically the response rate to PD-1 is like 0. When they used this particular CTLA-4 antibody, the response rate was like 24%. So those antibodies are actually coming into clinical trials, actually in kidney cancer, probably through the Huser Consortium. So I think there's a little bit of a renaissance coming in CTLA-4 that could be quite interesting to watch. Another antibody that is actually quite mature, in fact, even when I was at Hopkins, we played with that already. It's a LAG-3. It's a PD. It's like an immune checkpoint, like PD-1, but it's actually causes relatively little autoimmune side effects and became really important recently in melanoma when, in combination with this PD-1 inhibitor, showed actually an improved benefit in the progression-free survival curve. And that is now approved in melanoma. So now, obviously, the company, BMS in this case, is more excited. They want to test it now, also renal cell carcinoma. So probably a modest benefit. We still have to see what the long-term outcome is. But you will now see clinical trials coming. For example, there's a concept that BMS wants to do where they combine nivo-epi with actually the LAG-3, either all together or maybe leading in with an induction and then continuing with the PD-1 and the LAG-3 antibody. So those permutations are coming also for previously untreated patients. Another theme, I think, the new kids on the block are, I think, now cellular therapies. What I didn't mention on this particular slide is, for example, TILs, tumor-infiltrating lymphocytes. They have a long checkered history. There are some companies that pick that up, like Iovance, for example. They don't have dedicated renal cell carcinoma trials, but there's data in melanoma, data in non-small cell lung cancer, where actually taking a piece of a tumor, expanding T cells, and just play the numbers game, just giving them back to the patients in large numbers without really knowing what was expanded. There are response rates. In some patients, they can be reasonably durable. An extreme version of that is really making CAR T cells. And what that means is you take the patient, well, sometimes the patient's own, sometimes an off-shelf product, quite frankly, of lymphocytes, and then you transduce them with a completely new receptor that the cell never had. And that's typically an antibody that can see a particular signal. And so it's almost like an artificial arm that the cell is getting. And if the arm attaches to anything, the cell gets activated as if its normal T cell receptors were to find something interesting. And then these cells get very aggressive and kill whatever it's being attached to. So these are CAR T cells. They obviously change therapy in hematological malignancies, in leukemias, etc. I think solid tumors is a completely different ballgame. These cells need to be able to invade a very immune suppressive, hostile solid tumor microenvironment. They have difficulties to maintain themselves. But there are two clinical trials, two products, so to say, that actually show some activity for the first time in renal cell carcinoma. So CD70 is highly expressed in clear cell renal cell carcinoma, but it's also moderately well expressed, actually in reasonable numbers, in certain papillary renal cell carcinoma. So that's an opportunity for those two diseases to participate. So I actually had a patient who got some of these CAR T cells and actually had a transient response to that. So they take this data and go back to the drawing board and play around with some of these constructs to make them even better. So I think the future is quite bright. I don't think it's going to be the first-line therapy. These are actually quite intense therapies, but for patients where conventional immune checkpoint inhibition, conventional immunotherapy doesn't work, that hopefully will be a reasonable option in the future. People are thinking about just having more than one target. So CD7 is one target. If the cancer cell loses that cloak, if you will, or that marker, the tumor would become resistant. So people are now building cells that can see two signals, for example, to evade that. So in principle, T cells, they can see multiple things, or multiple T cells, they can see several things at once, are typically the best way to eradicate cancer. We mentioned interleukins before. That is the oldest immunotherapy there is in kidney cancer. I grew up with, I learned from Dr. Pili, who was my mentor at Johns Hopkins, and I remember the times doing high-dose IL-2 and answering the pager every 8 hours, see if the next dose can be given. Some of you have gone through it. You swell up like a balloon in the intensive care unit. It's no fun, but there's a small percentage of patients who get these complete responses that can last like probably forever, and some patients are cured. So it's a rather draconic method, but at that time, that's all we had. And it's still satisfying to see some patients of mine, quite frankly, that are doing exceedingly well. Again, one intense period, hopefully had a response that potentially cured you, and then you're done with therapy and you go about your life without typically much consequence. So the hope is, can we have something that might be a little bit more broadly active? There were some limitations in the efficacy, the way interleukin-2 works. And they figured out how to make potentially some newer versions of this. Now, the history has been very checkered, so there were clearly failures of pegylated versions of regular IL-2, IL-10, and that certainly doesn't help with enthusiasm of investors to go back into this topic. But there are some very interesting molecules where they actually made kind of like artificial interleukin-2-like molecules that will target only the receptors that are needed to hopefully stimulate and expand the T cells that are necessary for the immune response, but don't expand the suppressors, the bad immune cells that Dr. Msaouel mentioned. So there are companies that we are still trying to convince to do something in kidney cancer. So keep tuned. There are also mild modulators of the immune response. So for example, adenosine receptor antagonists like seroflotinib, for example, that's currently in a clinical trial with a Kidney Cancer Research Consortium. I will mention that a little bit later, where really the goal is, can we potentially deepen the response? Can we get more patients into the deep partial responder cohorts? We know that if you get a deep partial response, it's actually as good as a complete response. So can we deepen some of these things? And so there are triplet studies going on, nivolumab, ipilimumab, with, for example, an adenosine antagonist. Many of you will know CBM588. I think it's very popular. I don't know what the sales of the company is that makes this particular dietary supplement, but probably pretty good. That is based on data that Montipal generated with two provocative studies. Again, all small numbers. We have to see if it's actually real or not. But certainly there was an enhancement seen in patients who were randomized to getting CBM588, either for the combination of nivolumab, ipilimumab, or the combination of cabozantinib and nivolumab. Now, the control arms didn't perform as well as we had hoped, but should be a signal. Somebody should invest in it. Somebody should do it to at least get the answer in a randomized fashion. So again, CBM588 are bacteria that are felt to be potentially positive when it comes to leading to immune presentation in the gut environment and beyond. So radiation, I know my colleague Dr. Hannan is here. He loves to use his death rays to get rid of kidney cancer. There are other versions of radiation that can be deployed. And so there have been antibodies that have been around in renal cell carcinoma evaluations for a long time. One of them is called girentuximab. It's a CA9 antibody. It was used a long time ago in an attempt in an adjuvant trial to reduce the risk of recurrence. It was a completely negative trial. But then there's like, okay, well, we have a really good antibody actually that finds CA9. Most clear cell renal cell carcinomas are CA9 bright positive. Can we attach something to it? Like there are all these antibody drug conjugates. Can we just attach something to it and maybe radiate it locally with a little bit of radiation? The analogy would be, for example, in prostate cancer, We have PSMA probes. They attach a little chelator for radioactive lutetium-177. It's FDA approved. Can go to metastatic prostate cancer, can irradiate the lesions, and actually by itself can lead to responses in some patients. The idea is, can be used, it can be a little bit irradiate the tumor bulk. It's not stereotactic radiation. Raquibul, you will not be out of a job. But is it enough to potentially, damage some of the cells, lead to release of antigen, and maybe tickle the immune response by C-gasting, like pathways, for example. And so there's a clinical trial combining that with cabozantinib and nivolumab. As I said, we are revisiting things that didn't work so well in the past. Cytotoxic chemotherapy doesn't play so much of a role typically in the past, but we're looking at some other cancers where antibody-drug conjugates made a major impact, such as, for example, breast cancer. And it can be with some more modern linkers, some more modern payloads, can we maybe achieve something in that space. And so there are several companies, or two companies at least that I know of, they have the same thing, antibodies now with really poisonous payload, and see if there is anything happening in kidney cancer. This particular trial will expand among 3 different malignancies that express the particular target well, and one of them, fortunately, is kidney cancer. So I'm not saying this is will be a great drug, but I think those approaches are coming, and hopefully it's going to help us with our armamentarium. I think the third big leg of kidney cancer, clear cell therapy, is coming, and that is the HIF-2 inhibitors. As you know, this is a very unique target, by the way, that was discovered actually at UT Southwestern. A company spun off, developed small molecules called Peloton, that was bought up by Merck, and now it's called Belzutifan. That is FDA approved for von Hippel-Lindau syndrome. So young individuals, familial renal cell carcinoma, multiple clear cell renal cell carcinomas, typically on both sides of the kidneys, but also other tumors, certain neuroendocrine tumors, hemangiomas in the brain, around the spine, a lot of morbidity associated with this. And I don't know, 6 months ago, I had a patient with VHL in my office. He was in tears. Why? Because all his tumors started to shrink and he had no side effects, virtually no side effects from the HIF-2 inhibitor. So it's a uniquely well-tolerated drug. The quality of life is unlike anything I've seen, at least for targeted therapy. And I think it will become a very helpful tool in renal cell carcinoma. It works uniquely well in the VHL population. Why? Because they have this particular genetic defect, so the way it works is clearly associated with the VHL pathway, so response rates in that population is higher than what we would see in sporadic kidney cancer, so it's around 50% chance to see significant shrinkage in kidney lesions, etc. That will be less in the average kidney cancer patient that doesn't have a familial background. The response rate is probably going to be more around 25 to 30%. Nonetheless, that's as good as any other pill, and also it works, by the way, in heavily pretreated patients. It now found its way into the label of NCCN, so if you ran out of options, that is now something that insurance companies are more willing to pay for. It's not a high level of evidence, so insurance companies don't have to pay for it just because in the NCCN guidelines, but it's certainly there, and you can start a discussion with them. But clinical trials are hopefully going to read out soon, comparing belzutifan with everolimus, for example, as a single agent, but also certainly in combinations. So it makes a lot of sense to actually combine it with VEGF inhibitors. We don't think it's the same way it interacts. It probably has more an effect on the oncogenic driver, if you will, in kidney cancer, and so there's probably more some additive effect where the TKI and the HIF-2 inhibitors probably add onto each other. I think there is one combination I think is going to be really exciting to watch, that's going to be available through clinical trials in the near future. Those trials are gearing up, either a Merck trial or, for example, a Nicholson Therapeutics, where they actually now combine the HIF2 with a CDK4/6 inhibitor. Some of you may be familiar with breast cancer. The addition of a CDK4/6 inhibitor to estrogen receptor antagonists was one of the major breakthroughs in prolonging survival in breast cancer patients. Here, Dr. Kalin's lab, who is a Nobel laureate out of Dana-Farber, who was intricately involved in oxygen sensing, he actually found that is, interestingly, what they call synthetic lethal. So kidney cancer cells really don't like to be hit from both ends with a HIF2 inhibitor that may just slow the cancer down or shrink a little bit. If you give a CDK4/6 inhibitor that slows down the cell cycle in general, seems to be making it really, really uncomfortable, and hopefully will have significant effect in the clinic. So I think these trials are coming in the fairly near future. No, on the angiogenesis side, it's more like, okay, can we maybe take an agent that wasn't great and make it a little bit better? So cabozantinib had its issue with a long half-life, has its issue with, unfortunately, liver toxicity that makes it less combinable with immunotherapy. So they went back to the drawing board and made essentially molecules very similar, I think, in the targets that it hits, to cabozantinib called XL092, and which they're now combining with immunotherapies, even in triplets, for example. So I think those are also trials to be watched. There's another agent that's being now going into phase 3 clinical trials soon, Beterexapt. It's from a company called Araviv. It kind of like removes a certain ligand for an aggressiveness tyrosine kinase or receptor in the on kidney cancer cells in the micromet called AXL. By itself, you probably wouldn't expect too much activity, but hopefully in combination, it can make TKIs, for example, work better. So there are phase 3 trials gearing up to test that concept, probably well tolerated with minimal side effects. This is just almost like a disclosure. Okay, UT Southwestern is part of the Kidney Cancer Consortium. It's DoD support. So as I said before, because of you guys, we have now a DoD, Department of Defense, Congressional Directed Medical Research Program, the Kidney Cancer Research Program, $50 million a year that they gave out also to kind of like get institutions together to collaborate and work together to bring clinical trials that maybe the industry wouldn't do, or that brings us together and creates really a working group. Hopefully the dots will expand across the nation, but there's a number of sites that are participating. So if you look for clinical trials, is another way to look at it. But again, there are many clinical trials. Look regionally, what's available to you, what's logistically accessible to you. But obviously, my bias is always in clinical trial first. So with that, I will stop and take any of your questions.
Dr. Hammond, when I met with you, one of the epiphany that you just stated a second ago is one that many people don't know. People see clinical trials as a last resort. And I just think it's really important that you make that point, that we all make that point as we talk to other folks on social media and Facebook communities, because there's a lot of people out there that always look at clinical trials as a last resort, and they feel that if they do a clinical trial, they can't go back on an approved treatment option afterwards.
Yeah, I totally agree with you. So first of all, what's FDA approved is on the shelf. It's always available to you, can always go back to it, etc. But I think clinical trials, they can really give you opportunities to get access to things that you wouldn't get otherwise, right? I have patients on a HIF2 inhibitor. I mean, literally like a week or two ago, I had somebody go into a CR. He's been like 2 years plus on a HIF2 inhibitor. He's, keeping his bees and everything, and he is living a great life, right? He wouldn't have had access to the drug if he hadn't gone on a clinical trial. So it's really, really important. Obviously, when you're initially diagnosed, and I think That's especially, you will be, more be able to talk about that. But I think when you're initially shell-shocked from the diagnosis of kidney cancer, you probably don't necessarily think right now at the time about a clinical trial. You just want to start on something. It would be really good to be able to catch those patients early. I don't know how to do that. The other thing, I don't know if it's true or not, but I have a little bit the feeling that, since COVID, etc., I think there's a little bit more mistrust when it comes to medical research. I find it higher now that patients decline clinical trials. I don't know if it's true. I don't know if Roberto Pili agrees with that or not. But I would love to rebuild the trust in the community, the public trust that we have with our patients, at least give us a chance to talk about clinical trials. Yes?
So is it, who's responsible then to request the clinical trial? I always thought it was a last resort and the doctor would bring it up to you. Do you have to advocate on your own behalf?
Yeah, so advocate on your own behalf. The truth is, at every stage in your journey, you should look at clinical trial options. That even begins with you were just diagnosed and your stage 3 tumor was removed. You may have access to even adjuvant trials at the time, right? You can just go on pembrolizumab that's approved or just observe, it's equivocal, or you may enroll in the clinical trial that now combines, for example, potentially pembrolizumab with belzutifan, for example. So there are all kinds of things at each stage of your journey. There are opportunities for you. If you take one pill of standard of care, you will close the door to all of the clinical trials that require treatment-naive patients. So you may close the door to certain very exciting triple therapies or others, etc. So sometimes I see patients for second opinions who just started something. And to me, it's not very satisfying because I can't really offer them clinical trials anymore. And I don't want to spend too much time about what they could have had if they hadn't started. That doesn't feel right. So typically I'm with just like, okay, just continue what you've been doing. If things don't go well, come back. But if you get a second opinion and you can hold off, some patients cannot hold off. They need to start something right away. But if you can hold off, get a second opinion first, look at clinical trials, talk to the community here that you have about things that might be available to you. That would be my recommendation. Yeah.
I'm currently in a clinical trial, it's a belzutifan plus lenvatinib versus Cabometyx.
Thank you.
I've been on it for a little over 2 years. It's working very well for me. I'm currently Ned. I absolutely love Ned. He's living in my home. It's a disease. But I'm curious if there's, I know this trial has only been out for 2.5 years or so. I started it relatively soon after it started. And I'm wondering if there's any statistics yet on how it's doing overall? And secondly, when do you think that belzutifan will be FDA approved?
So it's a very good question. First of all, thank you so much for participating in the clinical trial. I assume it's the 011 study that randomized patients to cabozantinib versus lenvatinib versus belzutifan. It's a pivotal trial, meaning that trial will eventually lead to the approval of the combination if it beats cabozantinib or not. That's the only way to get things FDA approved. So you helped yourself, but you're also helping the whole community. So thank you. So there are different trials, and I think the first ones to read out, and hopefully this year, is going to be, for example, the simplest version, which is just belzutifan by itself against everolimus. Everolimus is a very weak competitor. It's almost, to be honest with you, almost ethically. There are ethical, concerns a little bit, at least on my end. But the trial is accrued. We are waiting for the data. The question is, hopefully it can beat it. It should be able to beat it. The response rates typically to everolimus are only 5%, and the PFS is around 4 months. So it should beat it. That's my hope. And then hopefully, we will get the answer very soon. But that would approve it as a single agent. Then there are these other combinations like you're on to see what it does in combination, etc. It will be a different flavor. because you probably have some side effects from the other pill that you are taking.
Vatinum is not fun.
Yeah, exactly.
The only side effect I had from belzutifan was hypoxia, and after drug reduction, that I was fine.
Yeah, yeah. And so, we still have then then at some point we will get the data, etc. But then we still need to figure out, who can we give just belzutifan for example, right? Because there's real value in quality of life, but the response is only 25%, right? So how do we find the people? So a lot of questions, but I think it's really coming. I think it's going to be one of the most exciting next therapies in kidney cancer. It doesn't cure patients, we believe, although we have to see how some patients do really long term. Some patients can be on this for years, but it is a very unique approach.
Is there just certain cell types that drug is being used with?
Yeah, I think it's really most powerful when it comes to VHL biology, and I think the drop off in the efficacy when you go to the classic genetic syndrome of VHL to sporadic kidney cancer, meaning the one that spontaneously occurs from 50 to around 25%, tells you that it's probably going to be less likely to be working in non-clear cell kidney cancers, but it will be interesting to look at some of those as well. There might be some tumors that might be particularly hypoxic or have HIF2 driven by a different mechanism.
You said non-clear cell?
It's probably less likely to work in non-clear cell. But I think it should also be, we need to understand more if there might be some tumors that have a different pathway that might drive HIF2, for example. So I think it's important to look at some of those questions, but it's probably less likely to work on non-clear cell.
One more.
Hi, thanks, Dr. Helmers. My name is Glenn Sykes. Nice to be here. You just slipped something in there that I wanted you to expand on. You said you didn't think, I think you said belzutifan you don't think will bring a cure to patients. Did I understand that correctly? And if I did, why did you say that?
So probably less likely. I hedged a little bit, but I would say, from the initial experience, I think a lot of patients for a lot of patients it doesn't work, and a lot of patients will eventually progress. Some patients can be on it for a long time. Maybe, like my patient that I saw 2 weeks ago, 1 or 2 weeks ago, who went now into CR, maybe it does get rid of the cells. It may also be that it may cure patients in the adjuvant setting, right? So we don't know that yet. The VEGF TKIs never really got rid of microscopic disease, right? So that was the story of the whole adjuvant Sutent era, etc., that very few people believed in. And the reason probably is because it doesn't go after the single cells. It just makes the soil hostile, so to say, and delays a little bit the outgrowth. Now, the HIF2 inhibitors, they go after how kidney cancer thinks. And that might be enough for a single cell that's floating around trying to survive. That might be enough to kick it over the edge. And you may do something that, for example, cytotoxic chemotherapy does in adjuvant breast cancer patients. So in breast cancer patients, chemotherapy only cures in the adjuvant space when you have single cells around, and that's enough kill-off to cure some women. When the cancer comes back and you see macroscopic disease on the CAT scan, that the same chemotherapy doesn't cure any woman, right? So it may also be the space in which belzutifan is given that it might be even more effective in. So a lot to learn. It's just my bias, okay? I'm not saying I know the truth, but we'll see how it goes.
Well, I'm pleased to announce our next speaker, Riccardo Autorino from Rush University. I wish I had known him before. I'm very intimate with the Da Vinci robotic surgical approach. It took my prostate out, but I was not given that option when I had my kidney taken out. So I'm looking forward to your presentation on the robot and kidney surgery.
Thank you so much. Thanks for I'm honored for this invitation. I enjoyed the meeting, and I'm gonna give you my task is to give you an overview on robotic surgery. If I find my presentation here, it should be this one. And the reason why actually, you can see that, can you? Okay, and the reason actually I'm in the United States is because of this, because I was, at that time I was in Italy, that was over 10 years ago, and I moved to Cleveland, Ohio, at the Cleveland Clinic to learn about, robotic surgery, how to do it, and to have my training there. So that's one. So that kind of brought me here. That's the outline of my presentation. It's going to be a little bit different. We talked about medical therapy so far. This is more like a surgical issue here. So I'm going to talk about, what's just an introduction. What's robotic surgery? Not all of you might be familiar with that, and what are the procedures we do with the robot to treat kidney cancer. And of course, I'll be happy to take questions. So, what's robotic surgery? The robot is a term that was coined in in the early 20s in this play from a Czech writer, and the meaning comes from the Czech, actually, a language. It means forced labor. And sometimes I have questions. I'm asked by patients. So how does that work? The robot does the surgery for you. And it's not exactly like that, or at least we are not at that point, thankfully. So the robot, basically, it's a machine, just a machine we use to be able to do a better surgery. It's just an evolution of laparoscopic surgery, of the small incision surgery that has been introduced before robotics, actually in the early 90s. And it's a master-slave system, right? And you can actually see that, you have the robot, thanks to the company. The robot is out here. You can test it, see how it works. But you have two components. One is where the surgeon sits, and the other is where the surgery is done close to the patient. And this is a story goes back to the early 80s. And the first actually robot, by definition, in urology was in the early 90s in UK to treat BPH, prostate enlargement. At Imperial College in London, whereas the robot which is currently used comes from some project that started in California, also with the involvement of the Defense Agency for Research. And at that time, the idea was really to have some sort of technology that could allow battlefield surgery. So the idea was having a surgeon who could basically do a surgery without even being where the patient is during, for example, a war scenario. And was not really ever used for that, but some of the initial companies, again, early 90s, there was a first system called Zeus, then it started the story, and this is actually, a video showing Dr. Maresco, who is an eminent surgeon in France, was able to show the feasibility of telesurgery. So in this case, his patient was in Strasbourg, France. He was in New York, sitting on a chair on the robot, and he was able at that time to perform telesurgery. So, being a surgeon, not being in the same place as a patient, just to show this was of course just a feasibility, just a case that was done, but never is not in that's not what we do yet. So. But that it was interesting to see how technology can have this sort of evolution. And then the story with Intelligent Surgical, which is the company who makes the Da Vinci, started with spin-off from Stanford, and then some other different minds, so doctors and engineers working together. And initially, the robot was really made. The Da Vinci was really made to do cardiac surgery, but he ended up working mainly for the prostate. And it was FDA cleared in 2000. And of course, as any other technology, same thing as for CAT scan on MRIs or whatever, or radiation therapy machine, the technology advances. So you have updated version of the machine, and so which makes for us surgeons to do a better surgery, just because it makes our life easier, because you have more tools that you can use. And that's just a video to show you again how it works. That's the OR room setup. You're gonna have the surgeon sitting at the console here, and then you have the patient, so-called patient card. The part of the robot goes where the patient is, where the instruments are attached. The instruments that go to the body of the patient, so we are allowed to perform the surgery. As you can see, as I said, the robot it's basically a filter between us and the patient, because it allows us to have a magnified view, a 3D view inside the abdomen of the patient. As you can see here from the video, the tips of the instruments of the robot are able to replicate the movements we do with our hands. And these are very precise. There is no, physiologic tremor that I might have as a surgeon disappears because the robots make that job for you. And you can see very clearly here how basically this works. And again, I invite you to, if you didn't do it, try the machine that is outside just to have an idea. So, and again, so that's why the urology as a specialty has been actually at the forefront of this evolution from open, where we used to be, big cuts, big incisions, to laparoscopic surgery, to where we are again seated at the console to do the surgery this way. And certainly this is a trend has been exponential over the past, especially over the past decade, even though the robot has been around for over 20 years. But this is a recent study from Dr. Badam and Mount Sinai showing that the role of robotics for kidney cancer in particular has been really exponentially grown. Now, what are the procedures? Just also to clarify, and this has been mentioned before, certainly the main procedure that has been, let's see if this works. You have the option of, once you have a mass on your kidney, a tumor on your kidney, you have the option of removing the entire kidney or of keeping the kidney. And that's what we usually prefer to do, if possible, if technically possible. And that's called partial nephrectomy, right? So the reason for that, because you want to maximize functional preservation. Surgery, treating cancer patients nowadays is not only about, getting rid of the cancer, also to try to keep their quality of life, their function, and also for the future, because that same patient might have another tumor in the future. So you want to keep as much as possible the kidney function that will allow that patient to also have other therapies, or maybe a CAT scan, because the function is good enough to get a CAT scan. This is again just an animated version of it, or some other instances you might not have possibility of saving that kidney, so you have to, and I'm going to show you some examples later. So you might have to, with the same machine, you can do a radical nephrectomy, which means basically you have to cut the vessels and then you have to, because the mass is too big, and you have to remove the entire kidney. As shown, it's not exactly that easy, but that's how it is, the cartoon shows. And then you have another option, which is for a different type of cancer, which is urothelial cancer. Urothelial cancer is a different beast completely from RCC. And it's not that the primary focus of these. In this case, you're going to have, not only the kidney removed, but also the, part of all the ureter and part of the bladder. And I'm going to show you later on that the new, especially the latest version of the Da Vinci, if really facilitated us in this task of being able to perform a surgery which involves basically to work in different part of your body. So it's a little bit more complex surgery. As you see here, goes down to the bladder. Again, this is for urothelial cancer. I think it's better to clarify this point so you understand also, again, what are the different surgical procedure we do. They talk about this. I'm gonna spend any word on this. So, but with kidney cancer, these are some clinical scenarios. You might have situations, and which is probably the most common. The smaller mass, like those two, 1, 2 centimeter, 2.5, 3 centimeter. Or you might have a larger mass, like in this scan here, and those pose different challenges and how to manage them. They also talk about this. As surgeons, really what we need to have is a good imaging, right? You wanna know how big is the mass, where it is, how it's located in relation to other structures around the kidney and within the kidney, because that's how we determine whether or not we can save that kidney. I also want to mention about this, has been mentioned, but sometimes also they send patients to us for renal cysts, right? And the patient comes with the idea that there's a cancer there, and it's not always like that. It's not always like that. It's sometimes some of these cysts are more irregular, and they look at certain. They have certain characteristics on the CAT scan. They might need to be removed because they might harbor cancer. One thing we've learned with time is also that not all small renal masses, as we call it, those under 4 centimeter, needs to be removed. And actually, it is within the guidelines that some of these, especially those within 2 centimeter cutoff, they can be just watched initially. Don't jump to do a surgery; it's not always necessary. There are some large data sets. There's a couple of them. One for Fox Chase, Johns Hopkins had one where they demonstrated the registry that these, most of these, they will grow slowly. So they actually don't really need to be treated. And some patients stayed under surveillance for what, as we mentioned before, what's called, active surveillance, or you can call it delayed intervention. So you decide to watch it initially, and then if that mass grows, or maybe because the patient is too stressed to have that, to know that the kidney might have a kidney cancer, kidney mass, they want the mass out. So at that point, we'll decide to do surgery. And these are the options on the table. As I said, the partial nephron sparing, we call it, so meaning sparing the nephron. The nephron is a unit of the basic unit of the kidney. Then the radical, where we remove the entire kidney. Oh, there is also the ablation, which is another thing that we're not going to touch upon today, but it's also another option for selected cases. Robotic partial nephrectomy has been really the after prostatectomy for the prostate. You mentioned the prostate, but really partial nephrectomy, the robotics has changed the way it's done, and the indication has expanded so much the indication for these. And this is basically now the kind of the standard for kidney cancer, nephron sparing kidney cancer surgery. There are some technical things we have to consider when we select the patient for these. We consider how healthy the patient is, what the kidney function is, if he had that patient had the previous surgeries, and then we look at the tumor at the complexity of the tumor and try to basically understand whether or not it's feasible. This is a kind of a probably 2-3 years old video. What we do during the procedure, we usually clamp the artery. We're gonna basically interrupt the blood flow to the kidney, so we have as much possible as bloodless field. It's not completely bloodless, but we are able in that case to see better what we're gonna cut into. You can see here with one of my robotic arms, I'm lifting up the tumor, and then I'm kind of enucleating, resecting the tumor from the. This is the good kidney. We're going to remove that part, which is a non-functioning part of the kidney where the tumor is. And then, and the procedure is made of 2 steps, basically. One is the tumor resection, and the other one is the tumor renal reconstructions, where we have to put stitches to kind of make sure that the kidney does not bleed after the procedure. And we do that, again, as you can see, doing this step and also the following one, with a magnified view, with a 3D view, being really with my eye close to where the tumor is, it makes a difference, right? Instead of me standing, imagine doing the same thing with you standing at the table, and I mean, my view, I'm not Superman, but if I were Superman, but I'm not, I would be able to do the same thing. But you can, and then the precision that you can do by manipulating those stitches in there because of the technology. So I'm just going to move on, but this is the reconstructive part of the. Now, so what we aim here with robotic is really trifecta. We use this term in the urology literature because, and it's a term used for horse races, as you know. So it's cancer control, so you want to get all the tumor out, functional preservation, and no complication. That's what every surgeon aims when doing this procedure. And again, the CAT scan is important. You want to know. In this case, it's a big upper pole mass. Again, where is it located? You have the liver, you have on the right side, the IVC, you have the adrenal gland somewhere in here. So you want to know what you're dealing with. That's important to have a high quality image. That's why we have some scoring system to tell us how complex is that mass that we're gonna treat. And as surgeons, we have to digest the images from the CAT scan, from the MRI, to try to then plan our surgery, and it's not an easy task. That's why, and that's why I want to show you some of the new things that are coming up, which is that 3D imaging, basically. So be able to use those CAT scan or MRI images and be able to do a 3D model of the tumor and the kidney. So we are able to then to do a better, a better surgical planning. This is from a company out, in Italy actually, as you can see, this model allows me as a surgeon and this can be used also for teaching purposes or for, patient explanation, to be able to have that model to understand a little bit better what we are dealing with. Can be used for training. So basically imagine having a model of that patient, of that kidney, and be able to do a rehearsal of the surgery in the lab. So, and these are, there are studies on this. Imagine how can that, also improve the outcome. This is another, case where basically it's a further study called mixed reality. So you have a projected images of that 3D model. The surgeon can look around. You have that same 3D model there. You can look at every component, blood vessels, and the tumor and relation of the tumor to the blood vessels and the ureters and all and you can decide, each different. You can see from different point of view what you're dealing with. I was talking about tools we have. Another very important tool we have is ultrasound. We can do intraoperative ultrasound. It's a tiny probe that we can put inside while we are doing the surgery, and this is a small tumor in this case. We can decide, and it can help us in deciding where the tumor ends and where the good kidney starts, so we can then cut exactly where, in the right plane. And this is, again, are things that, facilitates our work as surgeons. This is another case, I believe. Same thing. As you can see, so in that case, it was easier to see where the tumor was. In this case, not that easy. It's a larger mass, so ultrasound is key here to understand where I need to cut to be able to get all the tumor out. And sorry, that's another case. That's also actually a case where the ultrasound is really key, because it's sometimes you have the tumor which is completely inside the kidney, so you have no visual clue by just looking at the kidney, and so you have to use these to be able to then, again, cut in the right spot. There's another tool we use, which is fluorescence imaging, which is available in the new machines, which basically some sort of dye that is used during the operation. And I believe this is an example. In this case, I clamped one artery, and then I light up the kidney with this dye by using a special filter that is on the scope of the robot. And I realized that that blood vessel was irradiating only the lower part of the kidney, but the mass was still with blood. And so I went back on the artery, on the main artery, which I had found, to clamp the other artery, as you can see. Why? I was trying to do what is called selective clamping, which is basically sometimes you might decide, instead of clamping the main artery, to clamp only a secondary artery, because one of the things I didn't mention is that while we do this under ischemia condition, after we clamp, we can stay there for 2 hours. We have to do it as quick as possible, because as been demonstrated, when you go over the 30 minutes cutoff, the kidney function starts deteriorating. So you don't want to take that, be too long, basically. There are some studies on this, on the ICG. And then we have another step, which is augmented reality, which is not really, still not commercially, or there are a lot of, but there are a lot of companies working on this. It's not really, our daily practice, but basically where you can use that model and overlay that model on the, and that is, is possible basically with the, within the console where you look, and you can basically can guide you while you're doing your your resection. And that's that's again, this is another evolution of these. This is another even evolution of the technology where you can basically predict when you clamp a vessel, you can predict where that vessel, that artery is gonna go into the kidney. The kidney usually kidney is irradiated by different branches of the artery, and you can decide to only clip one branch, so then you can do ischemia. You can remove the blood only from one region of the kidney where the tumor is, so you are more selective, and you don't damage the kidney so much. And this is a one example. I think we don't have time to show everything, but it's one example of these. I'll touch a little bit on the outcomes of a robotic partial. Robotic partial is very safe and for small renal masses. The one that I usually try to convince the patient not to operate on, which is the one up to 2 centimeter. I tell the patient, let's just watch this. But sometimes patients was they just want surgery, because it's a we talk about shared decision. That's what it is, right? You try to talk to the patients, advantages, disadvantages, and then you say about that. Most of the patients nowadays, go home next day, right? And we are trying to aim at doing actually outpatient surgery, same day discharge. And this is another very interesting study. It already has some years now, but they look at the national data and they show that hospitals with the robotic system in place, with robotic technology, we are able also to offer a higher percentage nephron sparing surgery. That's why I think the impact of robotics has been really huge in this sense of saving kidneys, saving nephrons, and making a broader use of partial nephrectomy. And with time, we expand in indication, again, not only small masses, but also larger masses or higher stage. This is debatable, of course. Here, for a clinical T3 mass, the standard is still to remove the entire kidney. However, in some selected cases, we are able to save that kidney to offer a partial nephrectomy. It's not always possible, of course. Also, this is some other special situations. The patient might have had, I don't know if might have had a ablation or a previous partial nephrectomy. The tumor comes back on the same kidney, so you can offer that patient a salvage partial nephrectomy procedure. You can still save that kidney and maximize the kidney function preservation. And this is a patient case where a patient had failed the cryotherapy, and he had developed a mass close to in the hilar region of the right kidney. Again, for sake of time, I won't show you all the thing. Or cases like these where the patient has a solitary kidney, so patient had the kidney removed, develops another mass in that kidney. Is a case I did about 6 months ago here. And so, this lady was able to keep the kidney function, removing the other mass from that kidney. This is where becomes really imperative to save that kidney. A lot of data on partial, as I said. I'm gonna just spend next just very small number of slides on radical. Radical refractory, meaning removal of the kidney, is really reserved on situations where it's not possible to save the kidney. That includes also locally advanced disease or metastatic disease, where really the surgery is not the primary piece of the puzzle, or patients who might have some sort of symptomatic bleeding or something that will lead to removal of that kidney. And this is, for example, young lady where I didn't feel that I could do a good job by saving the kidney, so I decided it was too much into the vessels here, and I think that was right decision on the pathology was a T3 renal vein invasion. So I didn't feel. I think the safest option was just to remove the kidney for this lady. Maybe eventually offer some adjuvant therapy, as the next speaker will talk about. Robotic has been also for radical is being growing the role. And then again, a couple of slides on urothelial cancer. This is again the one that grows inside the cavity of the kidneys. Again, different type of tumor, but here here the idea that with the robot we are able to remove. Sorry, I'm gonna just clip to some of these slides. To remove the kidney from the ureter, the kidney up to the bladder. I'm able to remove. Basically, we are able to remove all that and do this in minimally invasive fashion, which means the patient will go home again most of the time in the next day or two. And it's a completely different story. Imagine doing the same surgery with where you have to work in the bladder, in the kidney. You have to do. Used to be two big incisions, one down here, one here, because they were two organs. And you can do the same thing with just one, in one procedure. So that's, I think that's also has been growing in terms of role. This is the ureter going to the bladder, and then it's going to show the bladder opening later on. But I think we can go move on. And then, last thing I want to mention, this is the new technology is now available also, where in our hospital and other hospitals in town as well, is the single port robot. Basically here the idea is which is an evolution of the same machine, but completely different idea, the idea of performing the same surgery to a single incision, which, as you can imagine, can also reduce the maximize the outcomes for the patient, reduce the invasiveness of the procedure, which is again an amazing technology that we are able to use. We've done about 40 cases at Rush for partial nephrectomy with this machine, and this machine allowed us also to discover a different approach to the kidney, which is a retroperitoneal approach. As you can see here, to get to this small renal mass, I don't have to go through the abdomen as we used to do, but you can go from the back directly, which is just one single incision, and that eventually, that's our perception, that's some data coming out, but basically less pain, less use of narcotics, faster, patient going home and return to daily life. So again, just to conclude, robotic surgery has certainly changed the landscape of kidney cancer surgery because of the advantages over open surgery. With robotic partial, we are able to spare most of the kidneys we see. Of course, we're talking about stage 1-2 cancer, but and then there are some other more invasive radical nephrectomy procedure for cases where that is needed. The single port surgery is another next frontier in this space. And thank you again for the invitation.
Next speaker, Dr. Matthew Zibelman, I think I pronounced that right, from the Fox Chase Cancer Center. He's talking about adjuvant therapy for stages 1, 2, and 3, and why this, to me, is a very relevant topic, is we get tons of questions in our Facebook community. I'm on stage 2, and they did surgery. Should they be doing something else? Should I be having immunotherapy? What should I be doing and not doing? I don't like, active surveillance, so I'd be interested to hear what you have to say about that. So thank you very much.
I don't know if I know the answer yet either for all those questions, but I'll do my best. All right, so again, I'm Matt Zibelman from Fox Chase in Philadelphia. I really appreciate the opportunity to be able to come and speak to you all today. Although I'm in Philadelphia now, I did my residency training in Chicago, and so always grateful for an opportunity to come back. My family came with me, and my youngest is getting her doll's hair done at the American Girl store right now, so always the important sites that we have to go to. So I'm going to do my best to talk about adjuvant therapy, which is a complicated topic, I think, even amongst professionals. So I will do my best to really try to outline some of the basics and some of the things that we as physicians think about and use to measure the benefits of adjuvant therapy and just really what adjuvant therapy is. I'll dive a little bit into the data, but try not to get too deep into the weeds in that, but just really try to show you some of the things that we think about in regards to the potential therapies that are out there. And I'll really try to focus on the differences between the doctor perspective and the patient perspective, because I think we don't always line them up perfectly, and that's something that I think we need to continue to do a better job. And then I'll try to conclude and try to answer some of those Facebook messages. So what do we mean by adjuvant therapy? So to make sure we're all sort of on the same page. So this is how they define it at the National Cancer Institute. This is additional cancer treatment given after the primary treatment to lower the risk that the cancer will come back. And so basically we're trying to give some sort of medical therapy, systemic therapy, to eradicate the body of any sort of microscopic disease that may have spread prior to your definitive treatment for your cancer in your kidney. Obviously, most commonly may have been surgery with some of those fancy robots that we saw about earlier, but there are other options as well. Regardless, we know that even with a surgery that looks like it has removed all of the tumor, patients have recurrences. And this is because of microscopic disease that is able to spread prior to that time. And our hope as medical oncologists is to be able to give medicines to eradicate that so the cancer doesn't grow back. So I try to sort of portray this as a cartoon. So this is a patient with a cancer growing in their kidney. Surgeon comes in with their fancy robot and removes it, and hopefully this is what we hope happens, and they're cured ultimately of their disease. Unfortunately, what often happens is that patients come in with a tumor, and their cancer has already spread microscopically to other places in the body. Our scans at this point may not be sensitive enough to be able to detect some of these small recurrences, and we don't yet have biomarkers in the blood or in other ways to be able to detect who has this microscopic disease and who doesn't. So the surgeon goes in and removes the cancer, and these microscopic areas over time start to grow. And so we see them, and eventually they show up potentially on a scan or with symptoms, and this is what we then call recurrent metastatic or stage 4 cancer. So the idea of adjuvant therapy is after that tumor has been removed, while that microscopic cancer is still lingering there somewhere, can we give a treatment and potentially get rid of that microscopic disease permanently? And so that would be the ideal effective adjuvant therapy that we're all striving for. Unfortunately, right now, current adjuvant therapy options are not ideal, at least in all cases, and they're not always effective. And so how do we as physicians decide, and how can patients decide who and when should they get treatment? And it's really ultimately comes down to this ultimate balancing act of balancing risk versus benefit, and trying to understand what is the potential benefit of going through with this adjuvant therapy, and what potential risks may I be putting myself at, and is there a balance there? So here are some of the ways that we as doctors try to measure this. We talk a lot about overall survival, and I think this is somewhat understandable. This is really just your expected lifespan, regardless of whether you're going to die of kidney cancer or of some other cause. We also talk a lot about disease-free survival. So this is the period of time that a patient will live without known recurrence of their cancer. So after they've had their cancer removed, the amount of time that they're alive with no known evidence of disease, which is a term that we use a lot. But there are definitely other considerations that I think are really important here. We also have to think about quality of life, not just quantity of life. And the effects of both the cancer returning and the cancer treatment can be quite impactful on patients' daily lives, and we have to factor that in when deciding whether adjuvant treatment is worthwhile. And there are other costs as well. There's the monetary cost. This can be obviously the cost of these expensive cancer medicines that we also have, but also the costs of co-pays for hospital visits, of driving to and from the center paying for gas, of having to buy lunch because you're spending the whole day there. There's a lot of costs, and these can build up. There's also the time cost. Patients who are getting treatment are coming to the doctor more. They have to come and sit there for treatments. And that's less time that you have at home or being with family and loved ones. And that's a real cost that I think we're starting to become more aware of. And finally, how this impacts caregivers and friends and family, a lot of you here today, and this can affect our lives in so many ways. So it's really trying to understand what matters to clinicians, but also clinicians trying to understand what matters to patients. When we as doctors talk about adjuvant therapy and clinical trials looking at trying to show a benefit of adjuvant therapy, we often think the sort of holy grail is the trying to cure. We're trying to cure the most patients by eradicating that microscopic disease. And so that's where overall survival arguably could be the optimal endpoint, what we are measuring in these trials. But it's not perfect. Overall survival is confounded by multiple things. It's confounded by treatments that patients get if their cancer does come back. There can be variability in access if we run these trials globally in different countries that maybe have availability of different drugs or not availability of different drugs that can affect those patients' outcomes. And there are other unmeasured effects that we can't predict when we are deploying these large trials. For example, a large pandemic that affects the entire world. And so lots of things can affect overall survival. So maybe disease-free survival is the better endpoint for adjuvant trials, and this is what we most commonly have used. This is because we can often get to an answer more quickly, and it directly measures the effect of the trial, the individual drug and how it affects patients, because we're just measuring when your cancer comes back versus doesn't. But this also is problematic and is not perfect. It does not necessarily correlate with maybe the things that are most important to patients, notably who is being cured and living longer and living better. If a drug slightly improves the disease-free survival, in other words, the average time when your cancer may come back, but you have to suffer through horrible side effects to do that, is that really worthwhile? And is this endpoint really measuring that? And so lastly, what's the cost? And that comes back to the quality of life questions. And is the benefit that we ultimately gain from an individual therapy, is it worth all of the potential toxicities that are associated with that? So I'm going to talk a little bit about the treatment options and how they've evolved over time. And I'll sort of separate these into 3 time buckets. Until not that long ago, we didn't have any available adjuvant therapies for patients with kidney cancer who had their cancers removed. And so patients would go on a surveillance plan where they would follow with their doctors with scans at some regular interval and try to detect cancer that came back at an early time point. In 2017, we had approval of the first oral drug. This was sunitinib, one of the tyrosine kinase inhibitor or TKI drugs you've heard talked about at some of the earlier talks. I'll show just a little bit about those trials, but this showed a benefit in disease-free survival. It delayed the time on average that a patient's cancer would come back, but patients had to go through a year of therapy and the side effects associated with these drugs to get that benefit, and the benefit was only about a little more than a year. And there was not ultimately an overall survival benefit. And so as a result, there has been little uptake from the community with that drug. Most recently, immunotherapy, which we've heard a lot about in earlier talks, with pembrolizumab was also shown to give a disease-free survival benefit. And we don't yet know with long enough follow-up if there's a true overall survival benefit, but this drug has become our best option for patients off of a clinical trial. So the first sort of set of trials that looked at this was using sunitinib, and I mentioned that this trial, which was called the S-TRACK trial, showed a benefit compared to placebo. We compared it to placebo because we didn't have a drug to compare it to that was shown to work. And so although that trial showed a modest benefit, it was sort of in the context of 4 other trials that were done with similar drugs and similar designs that did not show a benefit. So another thing that made physicians and also patients, I think, less interested in this therapy was that we had one trial that showed a small benefit and a bunch of others that didn't. And so going back to Dr. Msaouel's talk earlier, this has to do with the relevance and bias. And, if you have a bunch of trials that don't show benefit and one that does, is there some luck? Is there some other factors there that made this one drug potentially positive? So that led us to sort of the new era, and this was the immunotherapy trials. So my animation's a little messed up, so I'll bring all those up. On the left side of the screen, you see what we call the Keynote 564 trial. This is the trial that showed the benefit of pembrolizumab, an immunotherapy drug, over, again, placebo for patients and delayed disease-free survival on average. But we had another situation where we had 3 other trials that completed or presented early results around the same time, and none of those trials showed a benefit. And so again, we're sort of left with, what is it about this drug, or are there differences amongst the trials that might potentially give us some clues as to why we see a benefit in one and not with the others? So this is, I think, the only slide I really look at curves, so I'll try to limit those. But this is the Keynote 564 trial. This is the trial that showed the benefit of pembrolizumab. And just to walk you through it, along the bottom of the curve there is time in months. Along the top is that disease-free survival that I've been talking about. Patients who were randomly selected to get pembrolizumab sit on the orange line. Patients who were randomly selected to get placebo sit on the blue line. And what we see is those curves over time go apart. They're different. So the percent of patients who are disease-free, alive, and don't have cancer are different in those 2 trials, and it benefits or favors the pembrolizumab arm. I have a dotted line there showing you at the 2-year mark at 24 months, the difference is 77.3% versus 68%. Not a huge difference, right? An absolute about 10% difference, let's call it. But that was the benefit that we've seen from this trial. Compare that to the other 3 trials that happened using similar approaches, and you see those lines don't separate, right? The lines are on top of each other. There was no benefit, no improvement using the therapy compared to the control arm. If you look at the numbers there, one of the numbers is incorrect, but if you look at the numbers there, you'll see that they're overall kind of similar to what we saw on the pembrolizumab trial. 77% of patients were alive and cancer-free in the top trial, but some of the others are pretty close. In fact, in the middle one, it was 76.4%. Someone earlier mentioned we can't compare across trials, and that's true. And so what is it about each individual trial that maybe led to some of these differences? So as always, the devil is in the details. So here are some factors that we look at across these trials, and every trial has slightly different criteria that allows patients to go on, and maybe because of where they're treated or who's involved, have slightly different characteristics of the patients that are involved. And so we look at certain things such as a bigger tumor. We know that patients with larger tumors are more likely to have their cancer spread. We know that patients that have evidence of cancer in their lymph nodes, whether clinically on imaging, as was mentioned before when we talked about staging, or if ultimately found at surgery, those patients have a higher risk. We heard about non-clear cell cancers, so all the cancers that don't include clear cell. And some trials allowed those patients and some didn't, but we know that those patients may be less likely to benefit from immunotherapy, so that affects the outcomes of the study. There's something called sarcomatoid kidney cancer, and this again is with our pathologists' help. When they look at the cancers under the microscope, some of the cancer cells have this sarcomatoid or sarcoma-like appearance, and we know that those cancers can, one, act more aggressively, but also are more likely to respond to immunotherapy, so more of those patients may increase the chance that that drug is effective. And finally, some of these trials allowed patients who had cancer that had spread to one area outside the kidney and allowed all of that stuff to be resected surgically, but where that was spread to and how long it took for that to spread may have an impact on how patients would do. And so those slight differences, even though these trials were otherwise similar, can sometimes make a difference between a positive trial and a negative trial. And if you focus on the first column, the pembrolizumab trial, we see that they had the most big tumors, they had a higher amount of positive lymph nodes, they didn't include any non-clear cell patients, so patients that may have been less likely to benefit. They had the most sarcomatoid patients, and they only had a few patients with cancer outside the kidney, but those patients had recurred very quickly or along with their original cancer and seemed to do really well. And so ultimately, they may have found a way to create a trial that included the most patients likely to benefit and at least partly explains why their trial turned back positive. So how do we choose, right? I don't know these results, and an individual patient, I don't know how to apply who is truly going to recur and who's not. So how do we as clinicians and how do patients help identify who's most at risk and who's likely to benefit? So even doctors look at this data differently. The FDA approved pembrolizumab based on that data I showed you for adjuvant treatment of patients with resected kidney cancer. But the European Union didn't view this the same way, and they did not feel, at least at this point, that data is good enough for approval, and thus this is not readily available in Europe. One thing we can do is really try to estimate risk as best as possible. This is something that I'll often do with patients who I'm discussing and considering adjuvant therapy. This is an online tool that is widely available. It's free. Patients can access it. Clinicians can access it right in the room. The website is cancernomograms.com. And this was put together by some of the group at Fox Chase, where I'm at, based on data from one of the earlier adjuvant trials. Basically, it gives you a few variables regarding yourself and your cancer, how old you are, what kind of cancer it was, how big the tumor it was. Most of these can be available through your chart or with the help of your doctor. And it gives you an estimate. It basically spits out what is the likelihood that my cancer is going to recur at certain time points. And I think this can be a helpful tool as you're discussing potentially with patients who can benefit from adjuvant treatment to really understand what their risk is. So what about patients? How do they view this and what matters to them when thinking about whether to go through adjuvant therapy? The Dina Battle and the KC Cure group have done the most work in this in trying to help use their large cohort of patients and ask some of these questions to better give us as clinicians and researchers ideas about what patients value. In one of their earlier studies, they just asked if you were able to get treatment to prevent your cancer from coming back, what would be important for you? And I think somewhat interestingly, the largest group said, I need more information, that's not enough. And then other groups said only if it prolongs survival, and others were really bent on how much toxicity there was. So I think this gives us some clue as to what patients are really thinking about. In that same study, they also just asked specifically what reasons would be most important to you to be willing to take an adjuvant drug. And although we as clinicians often argue about is overall survival better, is disease-free survival better, what's the ideal endpoint? For patients, they didn't really differentiate. Both of these were important to them. They didn't necessarily differentiate one from the other, and I think that's maybe something that's important for clinicians to consider. This is a more updated trial that they presented more recently at our GU ASCO meeting, which is a meeting of GU cancer doctors that we go to every year. This was specifically of patients who either had or were eligible to get adjuvant treatment. So these were decisions that they were making or had made. Of the patients, 67% had received an adjuvant treatment, 20% or so had declined it, and another 14% went into a trial and were randomized to the control arm of the trial. One thing they asked them was, what did you think your recurrence risk was? And they stratified that by how big your cancer was, what your stage was. And interestingly, the patients tend to believe that their risk of the cancer coming back was higher than the doctors, and this was across all of the stages. And then I think even more importantly is this I created this little bar graph here based on the data they presented, but 25% of patients you see here think that their recurrence risk would be reduced by treatment by greater than 50%. So a quarter of patients thought it would get better by 50% by getting treatment. Another, basically 50%, thought it would be reduced by at least 30%, right? So 75% of patients thinks that by taking treatment, my cancer will have at least a 30% chance or better chance of not coming back. But in reality, in the pembrolizumab trial, that is only 10%. So there's a huge mismatch here, and clearly we're not doing a great job of helping our patients estimate risk. This was another attempt at trying to understand what doctors and patients think about and how they make decisions about adjuvant treatment. Don't worry about the details here, but basically they gave patients and doctors sort of two choices. They gave a case with, if you could take, this was your risk, here is the drug A that you're going to get. It has this % chance of working for you. It has this chance of side effect A, B, and C, versus this other treatment where they slightly differ it. Maybe a little bit better chance of your cancer coming back, but a little bit less toxicity. And they gave patients several of these different scenarios, had them pick which one they would choose, and then asked them afterwards, what made you choose this one? What was most important when comparing these two treatments? And ultimately, all my animation's gone, but all the patients are up top, and the physician's answers are on the bottom. You see the second bar there is the highest for both of them, but notice it's much higher in the orange, which is the doctors, versus in the patients in the green. And so that bar is looking at improving the chance of survival, so of living longer, basically. And so that was what both doctors and patients thought was most important, but it was viewed as much more important by the doctors. Interestingly, if you look at all of these over here, these have to do with how long I have to be on treatment and what my side effects are, and those were minimized by the doctors, but were much more important by the patients. And so, again, there seems to be a mismatch about what the doctors are viewing as most important versus what the patients are. How about side effects? We didn't talk much about side effects here, and the specifics of them, you've heard a little bit about that in other talks. We know that with immunotherapy, patients are subject to these immune adverse events, we call them, essentially these autoimmune events that can happen to any organ at any time. And these, although on a day-to-day basis compared to the oral TKI drugs, patients can feel well, when someone has an immune event, it can be dramatic and have long-lasting effects. And what we see is that these adverse events that affect daily life, what we often call grade 3 or higher, so in the first column is the pembrolizumab trial. So about a third of patients will have these, about 20% of them, so 1 in 5 patients, are directly thought to be due to the drug. Again, about 20% have to discontinue the drug, and almost 10% have to get high doses of steroids to correct an immune side effect. So these are not insignificant toxicities that patients have to go through to get that essentially 10% benefit. And there are other toxicities I mentioned as well. So time toxicity. And that's what I mentioned earlier about how much time you spend in the healthcare system, in the hospital versus at home. This was not specific to kidney cancer, but this was, I think, a good graphic that was published a couple years ago. And if you look at the columns here, option A was patients on some sort of treatment. The blue boxes are time that you're at home. The red pinkish boxes are times that you're somewhere in the hospital getting treatment, dealing with a side effect. And the upper column is supposed to be patients live longer, their overall survival was better, but their time at home overall was much less, versus patients who maybe went on a surveillance regimen and at some point their cancer came back a little bit sooner on average, but they had spent a lot more of that time at home. Maybe that's more important. If ultimately your cancer is going to come back, maybe getting that time is a priority for some patients. Finally, this is more of a societal impact of these treatments, but it is something that we do sometimes have to think about, and especially as pharmaceutical companies charge outrageous prices for these drugs, what is the impact on society? Are these drugs cost effective, and are we getting actual bang for our buck? In this analysis done by the Penn Group, they did show that pembrolizumab, even based on the data we have now, appears to be cost effective, but these are issues that we continually have to think about and look at. So I'll wrap up here. I'll sort of leave a few take-home points. So the addition of pembrolizumab for adjuvant treatment, I think, has been a welcome addition for patients and gives an option, but it's probably not for everyone, and it's really important for clinicians to really help patients understand their risk and help them decide. Optimizing the decisions based on risk and goals is really the key to treatment, and something that we have to continue to work with our patients on. Differences in outcomes across these trials may not necessarily be due to one drug being that much better than the other. It may be due to specific intricacies of the individual trial, but the data is the data, and we have to work with what we have and what we know. Toxicity factors, and not just physical toxicity, but financial toxicity, time toxicity, all of these things need to be factored in when we're deciding about treatment options. And finally, future trials need to really prioritize the patients who are likely at highest risk and most likely to benefit from treatment. So I'm happy to take questions. Thank you.
Thanks, Dr. Zibelman. First of all, that was a great presentation, really easy to understand, some complex material. I really appreciate that.
Thank you.
And I wish I had it at 2011 when I was looking at the trials, because
There would have been a lot less on the slides back then, unfortunately.
Well, thank you. But I am curious about the toxicity issue, because you brought up something and then you come back to it. But I am curious if it's coming up. You talked about something I think of as relationship toxicity, which is the cost with your family, friends, employer, all the toxicity related that's sort of outside financial, outside of time. Is that something that is also being talked about and tracked and figuring out how to track it maybe? Because I think it's significant. I think it's real.
It's something that I think we're more aware of. We have a name for it now, time toxicity, and so it's something that I do think people are trying to study. And so I do hope and think that it will start to be incorporated a little bit into some of these trials prospectively, so something we start to compare and look at moving forward. I think it's a really hard thing to talk about, though, especially up front with patients, right? You're already in a very complex discussion about the risk of cancer coming back, the side effects of treatment, right? And trying to sort of put together what you might anticipate, how often you're coming to the center, how this might impact family is hard to predict and hard to talk about. And so I hope we have data to help, but it will always be, I think, a complex part of the decision making. Somebody else, I think, had a question. Yes.
I had a question about how doctors, thank you, how doctors and patients might discuss this properly, and if the doctors are a bit more optimistic in some areas than what patients have it in mind. I wonder if there's value to a teach-back approach where not necessarily the doctor saying, now tell me what you just heard, but the doctor's asking, the patient saying to the doctor, here's what I understood. Am I right? Am I wrong? Because obviously that disconnect impairs the ability to make a well-considered decision at a pretty tough time.
Yes, first off, I totally agree with you. I think doctors are often overly optimistic. I didn't show any of that, but I think that's been shown. I think trying to really ask your patients and do the best you can to understand what they really understand and don't understand, and patients also taking that upon themselves, I think, is really important. I know personally, I usually ask my patients sort of first, what have you been told? What do you understand? You know, with this discussion, often these patients have talked to their surgeon who has told them, you know, oh, you should go talk to this medical oncologist. Sometimes they give them a lot of information why they're coming to talk to me. Sometimes they give them less information about why they're coming to talk to me. And so I kind of want to know that and understand what they know coming into the room. And then I do try to read the room and have them explain to me, you know, what they do understand. But, you know, it's a lot of information we throw across, and these are complex discussions. And I think it's hard in one meeting to really get all of the nuances and intricacies. Yes, thank you. Thanks, everyone.
It's my pleasure to introduce, and I hope I do this right, Dr. Raquibul Hannan. Did I get that close? Did I get it close?
Absolutely.
Thank you. Who's going to be speaking on a subject near and dear to me, because I had it, and I'm going to have it again, I think. Stereotactic radiation therapy for the treatment of kidney cancer. Welcome. Thank you so much.
Thank you very much for inviting me. It's really an honor and pleasure to be here, and also to see so many patients, to be able to talk to them and to really find, what we're doing the work for and what we're doing the research for. It's really an humbling experience. So thank you for having me. I don't have any relevant disclosures, and here are my research grant fundings. The animations are off, but anyways. So did you know that there are no such thing that a tumor that cannot be eradicated with radiation? With sufficient dose of radiation, all cellular processes can be destroyed, and there is no tumor that would survive. So then the main question is, why do we not kill all cancer cells? And the reason for that is collateral damage, which has plagued radiation therapy for over 100 years. And normal tissue suffers the same fate as the tumor cells, and that really the radiation dose cannot be tolerated by the normal tissue, which is what my dear colleague calls the death rays. Dr. Hammers calls it the death rays. But yet he's the one who is always sending me the patients when he needs the help. The system in therapy is not working. So what he really means to say is death to the tumor rays, not just death rays. So to get there, though, how do we really focus the radiation to the tumor and spare the normal tissues? And that's what really the key is. But we know that radiation is just like light. It travels in straight paths. So it doesn't bend. So how do we really focus that? And the answer to that is really, it's magic. And all sufficiently advanced technology is magic. And today I want to take you to the back door of how the magic is performed. And I want to explain to you how stereotactic radiation is done. So it's called SABR or SBRT. CyberKnife and Gamma Knife also uses the same technology. So at the end, for the purpose of this talk, I'll interchangeably use SABR or SBRT. What you want to understand is that it's not a standalone new technology. It's actually technology that is built upon previous technology. So all the terms that you have heard before, 3D conformal radiation, intensity modulated radiation, IGRT, and so on and so forth, it's all using all of that, and then additional technology gets added on. And I'll briefly go over them and explain you exactly how they work. So for the purpose, we start with the very basic, which is the 3D conformal radiation. What this does is you are bringing the radiation from different directions. So here you're bringing it from 4 different beams, from 4 different directions, but they all converge on the target, which here happens to be the prostate. And what we depict with the radiation dose is we use colors to depict the radiation dose. So here you will see the red is high dose radiation. We like to call that hot. The blue is low dose radiation, and we like to call that cold. And then orange to green is the intermediate dose of radiation. You can see by bringing the radiation from multiple different directions, we created a box of red, hot, high dose area, and we put that onto the prostate. Still a little bit of the rectum is getting some dose of radiation, but primarily all the other tissues are spared from a higher dose, whereas the target is getting the most dose of radiation. So you can imagine that we can try to bring in the beams from multiple different directions. So 5 different directions, and now you have created a pentagon, and even 15 different directions, and now you're trying to make it more and more focused, spreading out the lower doses that are well tolerated by the organs, and then we know what the tolerance are for each of the organs. So this is 3D conformal radiation. So the next advancement was the intensity modulated radiation, and the hallmark of that is what we call the multi-leaf collimator, or MLCs. These, you can see, are really thick lead leaflets that are dynamic, that can move and take the shape of the tumor from whichever direction we are bringing the beams from, right? So by doing that, what you have created now is intensity modulated radiation. So let me go back a little bit to explain this better. You can see that the color inside the beam is actually uniform. It's uniform radiation because there is no modulation of the beam. But here you can see that the color inside the dose of radiation inside the beam is now modulated. It's not uniform. So it has taken the shape of the tumor from this direction and then again this direction and so on and so forth. And the effect of that is you see a carving out effect. That's one of the powers of the intensity modulated radiation. So now you are able to carve out the radiation dose from any of the organs that may be nearby, and here and you can see that the rectum is appropriately spared. So that's intensity modulated radiation therapy. And I'll have a short video to demonstrate how that works, if the video works. Okay, so here is the patient on the table, and again we are treating the prostate. You see the multi-leaves are built into the radiation gantry, and they're moving as the radiation is coming along to modulate the beam that is coming, taking the shape of the tumor from that direction, and that creates this pathway of radiation. Then it goes to the next spot, and it does this again, and so on, eventually to dose paint the prostate or the target to have the highest dose of radiation, sparing the normal structures. So that's intensity modulated radiation therapy. So the next advancement is the arc IMRT, which you can imagine that now you're limited because you can only bring the beam from only limited number of places, but instead of doing that, you can make it a continuous arc. So it will be an infinite number of beams from all around, and as the gantry moves, the multi-leaf collimators move seamlessly. So it will be not only efficient, but it will be also fast. So that's the arc IMRT, where there is seamless motion with infinite beams coming from all directions. And there is a short video to demonstrate that and how that works. So here is a tumor that we're treating that's in a very critical location between the kidneys and other organs, bowels. The gantry is moving, giving radiation with each. So you see the MLCs moving seamlessly, taking the shape of the tumor from each direction. And at the end, you have painted the dose. You have given very low doses to the other organs like the kidneys nearby, where the tumor is red hot, everything else really blue and cold. So that's one of the powers of the arc IMRT, and that's one of the newer technologies that we use daily. So the next advancement is image-guided radiation therapy. So you have all this technology to focus the radiation, but how do you really know you're hitting the target? So to overcome that, what we did is we added an X-ray source and an X-ray detector right onto the gantries. So as the gantry moves around the patient, this X-ray source will create what we call a cone beam CT or another CT scan, and we'll be able to see exactly what we are hitting with the radiation. So now we are seeing and we are hitting, and that also brings in a lot additional precision while delivering the radiation. So that's image-guided radiation therapy. So the next problem is this. You have a tumor, you can see, but it is not stationary. It's actually moving. It's a moving target. So how do you overcome that? And this is the same for kidney. Here is an image of a kidney, and you can see how much the kidney moves with the breathing. Hopefully this works. Okay, this is not working. That's fine. You will have to believe me. The kidney with respiration actually moves quite a bit, almost 1 to 2 centimeters. So how do we tackle a moving target? So that development of technology is tumor tracking. There are a number of technologies. One of them is tumor tracking, where the beam is actually moving with the tumor, and we still are able to focus the radiation right onto the tumor. And there are a number of technologies that allows us to do this. Other ones are gating and 3D conformal, 4D image guidance. So with all of that, and then another additional technology added to it, which is bringing in a body frame. So the body frame that you can kind of see here around the patient not only immobilizes the patient more, but also brings the coordinate system. The frames have coordinate system built into it. So you bring the coordinate system like the GPS closer to the patient, and you increase the accuracy significantly. And now what you have is the ultimate, which is the stereotactic radiation. You have a tumor very close to multiple critical structures like the esophagus, the spinal cord, the airways, and you still are able to deliver very high ablative tumor doses and spare normal structures. This allows us to deliver higher doses with each time. So now you can only do the treatment in single 3 treatments or 5 treatments, and minimize damage and maximize the tumor control. So this is stereotactic radiation and my brief introduction for you. Now the next question is it effective for kidney cancer, right? So you know that radiation has been, kidney cancer has been resistant to radiation for many, many years, and mainly to the older form of conventional radiation that took the 5, 6, 7 weeks of small amounts of radiation, which is really not effective for kidney cancer. But when we apply stereotactic radiation, and we just completed this phase 2 trial that we reported, we enrolled patients with biopsy-proven and growing kidney cancer, and we showed that it had a 95% cure rate at 3 years. We biopsied each of the tumors and showed that pathologic confirmation of tumor killing was present in 100% of the patients. So yes, it is very effective for kidney cancer for the treatment of primary, but not just primary, but also metastatic, as I'll talk about next. So can SABR help surgery for kidney cancer patients? And in our experience, it has been yes. So there are patients where we treated IVC tumor thrombus, which you know is a grave complication from kidney cancer, that the tumor travels into the inferior vena cava. It can go all the way to the heart, as you can see here, and becomes very complicated surgery because it becomes a vascular surgery. So surgeons not just have to take out the kidney, but they have to open up the vein, which has blood flowing through it all the time. So vascular surgeries are one of the most complicated surgeries. So we have had experience treating the IVC thrombus where systemic therapy did not work, and actually all of our patients had symptomatic benefit, and in many times we were able to control the tumors as well. So we are now doing a phase 2 prospective study where we do the radiation just to the IVC thrombus before surgery with the goal of reducing recurrence systemically, also reducing local recurrence, but also at the same time take advantage of an immune benefit of radiation, which I'll talk about a little bit later. We have already reported the experience from the first 6 patients that tolerated the combination of radiation followed by surgery well. We also already saw some examples of abscopal responses there that I'll also touch upon down the line. So can SABR control metastatic kidney cancer? And the answer to that is also yes, that we published a few years back in a retrospective series where we treated 175 metastatic kidney cancer metastases and showed a local control of more than 90% with stereotactic radiation. We applied this concept here that one of our speakers previously touched upon briefly, is what happens if the patient has oligometastatic cancer, so only few sites, 1, 2, 3, 4, or even 5 sites. Can we control these cancers just by doing radiation and delaying systemic therapy? And the answer was yes. We were successful in 91% of the patients to control for 1 year. On an average, nearly 2 years, we were able to control the cancers just by giving radiation to new sites that will come up. And most interestingly, the toxicity was minimal. And we measured specifically quality of life by giving patients questionnaires before radiation and after radiation and following them. And we showed that there was no significant decline in quality of life for these patients. So the next thing we did, and this is in collaboration with our patient advocate, Glenn Sykes, whom you'll hear talk later on, the phase 2 trials are small trials that really do not change the practice, mainly because we don't know at the end whether we are helping the patients by controlling these cancers that we can see. When we know that these patients have microscopic cancers that will eventually come back, and at that time if we start systemic therapy for those patients, we have delayed the systemic therapy. So we don't know if we really have helped the patients or harmed the patient by delaying the systemic therapy. So this is why we designed a phase 3 randomized trial, which is now funded through NCI and is scheduled to open next month, where we will take the oligometastatic patients, we will randomly place them into one of two arms. The one arm, arm A, will get the radiation sequentially. So if new metastases come up, we'll keep treating it with radiation. Eventually, when we cannot treat it, the patients will start systemic therapy, versus in the other arm where they start systemic therapy up front. And this is where we really hope to get participation from patients to really know the answer. Eventually, are we going to are we really improving the outcome for these patients? So the primary endpoint is to make sure that this is a non-inferior trial of overall survival. So the two arms have balance, and overall survival is really not compromised by delaying the systemic therapy. At the same time, the main benefit would be, if we have not compromised overall survival, we have certainly helped the patients by not giving them the grade 2 toxicities that you saw from systemic therapy. Combination therapies have over 40-50% rates of grade 2 toxicity, and quality of life will measure both of them carefully, and we are certain that the arm A will have benefit of quality of life if we know that the overall survival is not compromised. So this is a trial that is about to start next month. So the next question is, can SABR help drug therapy for kidney cancer? And this is another strategy that we have worked on, and we published on retrospective, also prospective study. In this study, patients with metastatic cancer on systemic therapy have progression only in 1, 2, or 3 sites that have become resistant to the systemic therapy. Our current practice is to abandon the systemic therapy that otherwise was working, go to the next line of therapy, and now there aren't too many lines of systemic therapy available, and the next line may not be as effective. So can we extend the duration of effectiveness of systemic therapy by taking out the resistant clones? That's exactly what we have done in this study, and we have shown that we can increase the duration of systemic therapy by almost 11 months to a year with minimal toxicity. Again, we have done patient quality of life surveys that showed that the quality of life for these patients were not decreased by giving them the stereotactic radiation. So the last topic to discuss is, can radiation help immunotherapy? And this is also one of the topics that I do research in the laboratory to find out how we can use radiation to improve the immunotherapy. So one of the side benefits of radiation therapy is it actually can stimulate an immune response and start an antigen presentation. And this is where the abscopal effect has been demonstrated, where if a patient has A, B, and C tumors, and we give radiation to A, and that one responds, but down the line we see that B and C also responds without receiving any additional radiation, and that's really what we are calling is the abscopal effect, which means an effect that is away from the target. And there has been a number of studies that show that this abscopal effect is really mediated by the immune response. And this is one of the patients in the IVC thrombus trial that I was mentioning earlier, one of the 6 patients that had a metastatic disease. We went on and we radiated and did surgery on the thrombus away from this metastasis. And after that, over a period of 12 months, the patient had a complete response with the metastasis completely disappearing. And we were able to biopsy the tumor right before it disappeared, and we saw a very high infiltration of immune cells eating up the tumors in the metastasis. So this is, I think, an evidence that really radiation is able to induce an immune response or stimulate the immune response that is already there. A number of mechanistic suggestions have been made of how this works. Radiation killing the tumor cells, bringing in the dendritic cells that really take up the tumor antigens. Then they go into the rest of the body, educate the T cells, and then the T cells find out the cancer wherever they are and kill the T cells. So this is a strategy that we are calling the immunotherapy plus SABR or I-SABR strategy. And just to demonstrate that in animal models, we designed an animal trial where we had randomized the animals to receive just the cancer vaccine plus radiation therapy alone, no treatment, and the control vaccine. And we saw that the control groups had large tumors. The cancer vaccine produced some effect, but not really a very good effect. Radiation also by itself produced some effect. But when we combined them together, we saw that 60% of the tumors in the mice were cured, and 40% had a very small amounts of tumor, as shown here, and this is also shown in the graph here. So with this, we were one of the first institutions to start iSaber trial, phase 2 iSaber trial of IL-2 plus radiation. Dr. Hammers has reported on the iSaber RAD-VAX trial that improved immunotherapy response from 40% to 60%, and we are about to start another trial where we combine STING agonist with a new form of radiation called pulsar radiation and nivolumab for our metastatic kidney cancer patients. So in conclusion, we know that stereotactic radiation is effective and safe for patients that is able to give high local controls to kidney cancer with minimal side effects. We know for primary kidney cancer, the cure rates is 95% or higher. SABR may have use for IVC tumor thrombus in kidney cancer. For selected oligometastatic RCC patients, SABR may be able to safely delay systemic therapy by 1 to 2 years. This is something that has to be proven in phase 3 trials, which is ongoing or which will be opening soon. SABR may also be able to extend the duration of the drug therapy in selected patients. And SABR may help us unleash the full potential of immunotherapy for our metastatic kidney cancer patients. So with continued clinical and translational research, we really hope to be able to find all the places where this new technology that we have can be integrated in the multimodality management of kidney cancer patients. All of this work has been really extensive collaboration between medical oncologists, urologists, and other in our institution, but also mostly from patient support and participation in trials. So again, thank you to you for participating in our trials.
Full disclosure, this question is very personal to me. I had radiation on my iliac, 15 days low dosage. I now have a new growth right by my iliac. They cannot do photon radiation. I'm having proton radiation, and I'm just curious if you know about that.
Yeah, absolutely. So it sounds like you had the 15-day radiation, so you really did not have the focused high-dose stereotactic radiation. Depending on the location, stereotactic radiation still may be possible.
Okay, so
absolutely. We have done it for a number of patients, and we see very good control rates. So yes, and proton may be an option, but even photon radiation with stereotactic radiation may be an option.
In your view of proton versus, can you explain for all of us what proton is?
Absolutely. So
it's a little bit new to me.
Yeah. So the proton radiation, remember, is instead of sending photons, it is sending particles, which is protons, and it has an inherent benefit of giving a higher dose of radiation and less dose to the surrounding tissue. The one issue, though, is that proton radiation technologically is not nearly as advanced as the stereotactic radiation. So at the end of the day, the ability of focusing radiation is much higher with stereotactic than proton, because you will hear about proton and you'll hear about IMPT, so intensity modulated proton therapy, and that's about 2 notches of technology behind the stereotactic radiation.
Thank you. Other questions?
Great talk, thank you. Is there a role for particle-delivered radiation therapy, like how they do for hepatocellular carcinoma, for renal cell, like theranostics, something like that, or even HDR, Reiki? Is that something that's being developed?
That's a very good question. We actually did treat a few patients with HDR therapy where we did it in post-operative setting. So post-operative setting, you really have a T4 tumor that has invaded the nearby organs, and the surgeons couldn't quite get a negative margin. And intraoperatively, we will bring in the radiation catheter, give the HDR intraoperative brachytherapy, and we have done a few in collaboration with our urologist, and I would, I think it is effective because you can, in the operating room, you can really move the bowels out of the way, and then you're giving high dose of radiation. The other one Dr. Hammers touched about in terms of theranostics that probably are coming up about with targeting with lutetium and gerontoximab may be effective.
Thanks, Dr. Hannan. I had two questions. I'll put the first one out there and see if anyone else has another one. But one of the things, in my patient community, and I don't necessarily know how long ago people were treated with radiation. I have had SABRE in the last 2 years. Someone will come up with something wrong with them, and it will be attributed to collateral damage to a radiation treatment in the past. So certainly a big fear of mine when I think about my future. But one thing that would be helpful for me to know is how long patients have been treated with SABRE, and how long, how far out have been patients tracked in terms of collateral damage that comes in years later.
Very good question. So we have been doing SABRE since 2007-ish. So we do have quite a bit of long-term data. And side effects from radiation can happen late, 2, 3, 4, 5 years later, it still can happen. And that's one of the things that you see, even though the numbers are low, like 2%, 3% rate of late side effects, it can happen. So, we are right now, the study that we have published have follow-up data is about 2 years out, and right now we are actually reviewing our experience again, and we'll have a median follow-up of about 4 to 5 years. And we really hope to be able to capture all the side effects that has happened. And even still, those are not more than 5%. So it's right around there. This study has not been published yet. We will hope to publish it in the next 5 to 6 months, I think. But yes, we are doing reports on long-term outcomes, not just local control, but also toxicity. And I think still at the end you will see it's much less than other therapies or systemic therapies, but there are definitely some side effects that can happen.
Thanks. I look forward to reading it.
What about secondary malignancies? So let's say if somebody is less than 50, for example, right, and you apply them with curative intent, for example, what number would you quote them of secondary malignancies from the radiation?
Yeah, very good question. So we know that those numbers actually. The risk of secondary malignancies coming from radiation is exceedingly rare. They are on the order of 0.1 to 0.2% at 10 to 15 years. So it's only relevant to younger patients that we are giving with curative intent radiation. So the vast majority of other metastatic patients is actually not relevant. But when you look at the studies, you really have to look at the absolute risk rather than the relative risk. So absolute risk, if you look at it, it's really on the order of 0.1 to 0.2%. So very close to the background level of radiation. Remember, we are getting exposed to radiation in the background level at all times. So it's close to that, but it's just slightly higher than that.
Yeah. Just so I understand, is the SABRE the same as SBRT?
Yeah, absolutely. It's just a synonym. Different places like to call it differently.
Okay, thank you. So if you've already had, like myself, I had 25 traditional old-fashioned, because way back in the day. Then I had 2 rounds of the SBRT, but you just made me excited because you said you can now get the colon out of the way, because that's why they were avoiding doing more on me, because they were afraid of hurting the colon. So you're saying there's a way to get the colon out of the way?
Correct. So that I was talking in context of surgery, but even aside from that, there is a more advanced technology that actually I did not bring in here. It's called adaptive radiation. So now we are able to adapt. So, and we're doing that in one of our MRI LINACs, MRI linear accelerators, one of the more advanced technologies, where it's an MRI machine that is also giving radiation. And in the MRI machine, we're seeing the motion of the bowels, because bowels actually moves constantly, and that was one of the problems why we could not avoid that. But now we can see the motion of the bowels right there, and we plan the radiation and deliver it right there in one setting. So we are able to treat tumors that are much closer to the bowels nowadays. So absolutely, I think it will be an option.
Is that being done in the facility you're at, or is that being done?
UT Southwestern is one of the few facilities that has it in the country. I believe there are a few other places that also has this technology. It's called adaptive radiation.
Thank you so much.
Thank you.
One of the questions I know we've all asked when we get stage 4 RCC is was there a genetic predisposition to getting this cancer? I know there was for prostate for me. My father had it, my brother had it, and then I got it. Renal cell carcinoma, I don't think, at least my type, based on genetic testing, there was anything. But we're fortunate to have Dr. Gopal Gupta from Loyola University, I assume in Chicago area, speaking about hereditary genetics and kidney cancer. Thank you, Dr.
Great. Good afternoon, everyone. It's a real pleasure to be here. I'd like to thank the organizers and for inviting me in, for the patients for being here. So I was asked to give a talk on the genetics that underpin hereditary kidney cancer. And there's actually a lot of lessons to be learned from the study of hereditary kidney cancer and all the therapeutics that have come from these discoveries. Easier for that mutation, for that thing to happen. But the thing I want you to understand is that typically the genetic aberration in sporadic kidney cancer is typically the same. So here are the inherited forms of renal cell carcinoma. Von Hippel-Lindau, you get clear cell. There's a hereditary papillary renal cell carcinoma. There's a hereditary leiomyomatosis renal cell carcinoma syndrome. There's a one called Birt-Hogg-Dubé, where you get chromophobe and you get hybrid oncocytic tumors. And then there's some newer ones that were more recently identified, succinate dehydrogenase, and we all know tuberous sclerosis, but that's been associated with clear cell kidney cancer. So let's just go into von Hippel-Lindau. So this is a hereditary syndrome with a prevalence of 1 in 36,000. The von Hippel-Lindau gene can be inactivated due to deletion, insertion, mutation, methylation. If you think you have it, a genetic counselor can pick up almost 99% of these mutations. Now, you can see you'll get lots of cysts in your kidneys, but you also develop clear cell kidney cancer. And these tend to be on both kidneys. You can have multiple, up to 600 tumors per kidney over your lifetime. And that's just a picture down there. In addition to the kidney cancers, you can get pheochromocytomas, which are epinephrine-secreting tumors of the adrenal glands. You get benign tumors of the pancreas called pancreatic neuroendocrine tumors. But some of the real problems are not even related to kidney cancer. You get brain tumors. These are hemangioblastomas. You can get blindness from retinal angiomas, and balance problems from endolymphatic sac tumors. So the VHL gene, as I mentioned, is a tumor suppressor gene. So when it's working, it's preventing cancer from happening. When it becomes deactivated on both chromosomes, it allows a pathway for cancer to happen. And it was discovered in 1993. It's autosomal dominant, so if you have it, there's a 50% chance your children will have it. So that's why it's very important to identify early. And this really is an important schematic because the whole point is once you identified the gene, right, you had to understand what was the gene doing. What was that gene product doing? How does it lead to cancer? And this is really important. So when you lost VHL, VHL was preventing a very potent transcription factor called hypoxia-inducible factor from going into the cell nucleus and saying, listen, we have a lack of oxygen. I can't grow here. It's tricking the cell into thinking it needs to recruit things to survive. So it goes into the cell and it starts to make new blood vessels for growth. It starts to get sugars and energy, and it stimulates growth overall. And these are all hallmarks of cancer. And it does it in an unregulated fashion. Now, you may recognize some of these medications. These are only made available by understanding these gene products and how VHL was working. Before this, the medical oncologist can tell you, they had high-dose IL-2. And after the discovery of the VHL gene, we got Sutent, sunitinib, directly downstream from this, blocking these targets. So it's really important discovery for all patients who have kidney cancer, as you can see from the therapeutics. And it was so important that in 2019, the gentlemen, researchers from around the country who helped us understand what is VHL doing, won the Nobel Prize to understand this. And you can see downstream, there's a new drug based on this work called belzutifan, which right now is actually really effective in treating von Hippel-Lindau patients, but there are phase 2 and phase 3 studies of belzutifan, which is a HIF-2 inhibitor in sporadic kidney cancer as a consequence of this research. Okay, let's move on to hereditary papillary renal cell carcinoma. So this is a condition described in 1994 at the National Cancer Institute. After studying, what they had to do is study family trees to figure out, okay, you have papillary type kidney cancer, any relatives? They do this, they take blood, and they finally can narrow down the gene. So this again is autosomal dominant. It's highly penetrant, but you only get kidney cancers. There's no other manifestations. Nothing else happens to you. The big difference between this and VHL is that MET, the target, is actually really processed in sporadic papillary type 1-2. But these patients have an actual mutation in the gene. So the way you think of this is this is the opposite. This oncogene, they call it an oncogene because instead of losing function, the cancer cell wants to make more and more of this because it promotes signaling. So in sporadic kidney cancer, this lives on chromosome number 7. You'll see amplification of chromosome 7 in papillary type kidney cancer. And as a surgeon, these tend to be highly multifocal. You go in to do a kidney operation, your job is to go in there and take out everything you can see and try to preserve as much kidney function as possible. So I just mentioned here trisomy of chromosome 7. That's where this MET gene has been seen in sporadic. These patients have an activating mutation in the MET gene, and of course it's a gain of function. And then you can see in the yellow, because of this pathway, because of understanding how does MET work, there's a new drug that's not so new called cabozantinib. And there's been really excellent data showing great responses in the CABO-SUN trials and in combination with other medications. Again, I kind of mentioned this, but it's sitting at this cancer is on this gene is on chromosome 7. You can see amplification. Somehow the tumor figures out how do I make more and more copies of this to promote cancerogenesis. So let's move on to Birt-Hogg-Dubé syndrome. This is also an autosomal dominant syndrome, 1 in 200,000. VHL, if you remember, was 1 in 36,000. So this is less common. Interestingly, this is first found by a dermatologist who was seeing patients, and when examining their face, he would see these like little shiny pearly papules around the nose, and so he called those fibrofolliculomas. And then the story was that patients either had a history of spontaneous pneumothoraces, where their lungs would collapse. So you'd be on an airplane, you get depressurization, and you get a lung blood that might collapse. So they started to put this together, and then they found out that they were also developing kidney cancer, and it was of the chromophobe type. At the NIH, they found that the gene was folliculin on chromosome number 17. And this again is a tumor suppressor gene, so you have to lose function like VHL. Here are some of these things. Once you see this, you're going to go look at everyone and start to diagnose these because they're kind of nonspecific. But if you have this germline mutation, 85% of patients do have these fibrofolliculomas. and they're benign. They're not cancerous. Now, these are the lung cysts. For some reason, they develop cysts in the lung. That little tissue in the forceps is actually the lung tissue. When it's not inside your chest, it collapses, but then you could see that giant thing. It looks like someone blew air in it, and that's one of those lung cysts. So kidney tumors, when it was first described, you can get them both sides, but they're usually later in life than VHL. And that might be because they're chromophobe. And when it was first described in 2005, the paper, they actually included oncocytoma, which is benign, but that is no longer. If you have a Birt-Hogg-Dubé mutation, you cannot have oncocytoma. Those tumors are cancerous. And they're either one of these hybrid oncocytic tumors or a chromophobe, and sometimes you can get clear cell. Now, the last hereditary kidney cancer syndrome we're going to discuss is hereditary leiomyomatosis renal cell carcinoma. This was actually called Reed's syndrome. And what a leiomyomatosis is, these are these are like uterine fibroids. Uterine fibroids are leiomyomas. Reed's syndrome was women who would have very early hysterectomy for having severe fibroids. And so if you're a female and you're a carrier of this mutation, you probably had your uterus out when you were very young. And that's one of the things. You have to have that. It's one of those things that's part of this syndrome. But the problem with this syndrome is that the kidney cancer associated with it is very, very aggressive. And it's a papillary type 2. And fortunately, we have not seen that in the sporadic, but you can see papillary type 2 not otherwise specified, which is different but equally as aggressive. And these tumors can spread when they're very small. There are patients who have this mutation who've had metastatic disease as early as 11 years of age. So knowing it is very important to screening and preventing kidney cancer. They also have these bumps, these leiomyomas on the skin, and they can be very cold and touch sensitive. So if you're seeing these patients and screening for that, that's something that's very important. And 81% of these patients will have this. I talked about the large and multiple fibroids that present at a very young age. And you can see the penetrance, meaning how many people with this germline condition have uterine fibroids, 98%. So it's very penetrant, and it's previously known as Reed's syndrome. So this is a really scary kind of presentation. If you have HLRCC, you need to get screened very early. And you're not looking necessarily for solid lesions. You're looking for even cystic lesions that may have a little bit of solid in them, because any solid component can be very, very aggressive. And the management is very different. You need to get wide margins surgically. You need to not spill this tumor. And often this will spread initially to the regional lymph nodes. You know, the textbook teaching is that clear cell, these other ones, typically spread to the lungs, but these definitely spread to the regional lymph nodes. It's a challenge to diagnose these because papillary type 2 as a pathologic subtype there's a lot of mixing of different things out there. SDH tumors, but there's some things in here, these need to be sent out to a specialized pathologist for review if you suspect HLRCC. Now, this is kind of for the nerds in the audience, but the gene so I was a biochemistry major at the University of Chicago, and you had to study this Krebs cycle. This is how cells make ATP so you can fuel things. So the gene that's responsible for this is an enzyme, fumarate hydratase. That's weird. That's wild. That's crazy. This is like part of life. A cell cannot really efficiently use glucose to make ATP, which is what we use to power everything, without this cycle that's happening in the mitochondria. And what happens is when you knock out fumarate hydratase, you get a buildup of fumarate, because this fumarate hydratase is converting fumarate into malate. And actually, what's happening is it's using the same strategy as VHL. This fumarate builds up. It tells the cell that we're choking here. We need oxygen. And actually, these tumors are addicted to glucose because they can't use glucose in this cycle. They have to use glucose to convert it to lactic acid. So these are very PET scan sensitive, and there are a lot of strategies to target this. It's kind of like an Achilles heel that's been identified. And there's some really interesting stuff coming out. So we're not going to talk too much about management, but I'll just put this out there. If you suspect a hereditary kidney cancer, or if you meet a patient who's under 40, or any patient, you want to get a detailed family history. You need to find out exposure history, what's going on. I am a big fan of MRI. MRI allows you to really look at the complexity, the intricacies of kidney cancers in the kidneys and the regional soft tissue. So if you've not gotten an MRI in addition to your CT scan, it's a really good idea. Determining cystic from solid on an MRI is night and day compared to CT scanning. And again, refer to the experts. Refer to a genetic counselor. They have a wealth of information. They know how to take a detailed family history. They know when to, and this is not only for hereditary, this is even after metastatic disease. You know, there's tests out there to try to understand the genomic profiling of these cancers. And again, make sure you do your research and look for clinical centers of excellence. You know, you don't want to go to someone who doesn't do much of this type of complicated work. You want to go to a place where they've assembled a team, a multidisciplinary team of people who are thinking about kidney cancer to try to achieve the best outcomes. So some of the lessons we've learned from hereditary kidney cancer we use in sporadic kidney cancer as well. It's this 3 centimeter rule. You know, typically kidney tumors, if they're found early, under 3 centimeters, don't spread. Now, if you're at risk of getting 600 tumors in your kidney, you can't go in after each time you keep getting tumors, otherwise you'd have no kidney left, you'd be on dialysis. So what we do here is we wait until the biggest tumor on the kidney gets to about 3 to 4 centimeters. Then we go in there, and our job is to take out every cyst and every solid we can while preserving the kidney. Okay. And so some of these things we'll just skip for now. But what's on the horizon? You know, a lot of this is pattern recognition, right? You get a tissue, you put it on the slide, you give it to the pathologist, they get together and look on a microscope. And we're going, well, that hasn't changed for 100 years since they developed the microscope, probably, I don't know when. You know, you're looking and you're only as good as the tissue that you're given. So why can't we take some of this out of it? Well, the NIH and smart researchers all over the world have understood this, and there's this Cancer Genome Atlas is just an amazing advancement. So the NCI decided, you know what, let's get to the bottom of this. Let's get like 3,000, 5,000 tumors. We're going to do DNA sequencing, RNA sequencing, proteomics. We're going to give it to the best statisticians, the best minds to kind of just figure out what's happening, how do we understand this. And, you know, they're creating profiles of these cancers. And this is really going to power the next generation of scientists to come up with the next big discoveries. And without this work, you can't make the progress in the therapeutic field. So one of the things we learned is size per size, kidney cancer, if caught early, doesn't have as much mutational burden. Now this doesn't apply to kidney cancer that's caught late. Anything that's had time to mutate and grow can then become aggressive and metastasize. But this is for early. And we're understanding what are some new targets. So we've talked about VHL, we've talked about hypoxia, but some of these things were right under our nose. So if you look at VHL, it's on chromosome 3, and we were very excited. We know where it is, we know the gene. But what we didn't see is that when you break off the gene where VHL is, there were like 3 other genes nearby that we didn't study yet. And now we're understanding that it's not just VHL. BAP1, PRBM1 are very important as well if you get mutations in those. And those are going to be druggable targets, I think, very soon. We're doing the same work in the TCGA did clear cell, they also did papillary and chromophobe. And papillary, like I said before, there's a lot of not otherwise specified. You know, where does this fit? What is this? So we're getting a genetic readout on what this is. And again, some of these new genes are coming up that will hopefully be druggable targets for patients. And you know, making sure we're aligning patients with the right therapies that they can respond to, rather than using kind of a blanket, okay, let's try this and see if it works. Why can't we pick patients who are actually responders? You know, so we're getting there. And then this cartoon kind of just puts it all together. It says, okay, this is kind of our understanding. This is how we're doing the subtyping. This could enrich a clinical trial. If you have papillary subtype 2A, you might go into this drug arm. You know, so this is just kind of the up and coming. So classification is important because you have to know what you're dealing with. So you can see here the current renal cell tumor subtypes. We kind of mentioned clear cell, papillary, chromophobe, collecting duct, renal medullary, unclassified, oncocytoma. Then these new ones are coming in that we're understanding. So there's always continuous progress being made in understanding kidney cancer. And then some of these newer additions are actually, you know, if we can diagnose them, they're actually responders to targeted therapies. And we're understanding their molecular features as well. So I think the TCGA and all these scientists out there who are doing great work, there's more coming on the horizon. So I'd like to end with that. Thank you.
I'm fascinated by the fact that apparently there's now 20 World Health Organization versions. They just add them every once in a while. But more importantly, in clear cell kidney cancer, there's also subdivisions according to molecular characteristics. We haven't heard anything about that today, and yet that's been around, that I'm aware of, for at least 8 to 10 years. Are we missing variations that we think are clear cell that might be reclassified into some of these areas, or does that add to the challenge of treating clear cell when it might be more than one disease?
That's a great question. I'm not sure. To be honest, I'm not. But, you know, 80% of clear cell has an underlying von Hippel-Lindau mutation, right? Now there's 20% that VHL is not inactivated, or we can't detect that it's inactivated. Maybe it is in ways. You know, we don't even understand really how all genes can be deactivated. The idea of methylating a gene to deactivate it is kind of a newer concept. Sometimes you just can't detect it. But I think some of these adjacent genes, like BAP1, are looking very promising in preclinical studies. But yes, you're right. Every time the pathologists get together, they take the data and they come up with new classifications, but they're not always actionable yet. Hi.
If you are a sporadic kidney cancer patient, does that make your children genetically predisposed to be having kidney cancer if you're sporadic, or how does that work?
Yeah, great question. So sporadic is so everyone's a sporadic unless they have a known family member who had a mutation, right? So if you're under 45 and you have kidney cancer, there's a chance you may not be sporadic. There's a chance you may have a hereditary kidney cancer mutation because that tends to happen earlier. Now, if under 45, the guidelines say that patient should be referred to a genetic counselor to undergo further testing to see if you're still going to be in sporadic or not. But unless you have a family history, or unless you undergo genetic testing that shows in your non-cancer cells, right? Not in the cancer that they maybe took out of you, but in like a skin cell, is that gene deactivated? Then you are sporadic.
So do you recommend for patients that are diagnosed under 45 and have children to have their children have early genetic testing?
Right. No, what we recommend is that the patient meet with a genetic counselor to have that discussion about should we test, to also get a detailed history so you can go back and then ascertain from family members, did Uncle Joe, did he have kidney cancer, or, this type of thing, to put together the pedigree and then have that shared medical decision making, because sometimes there's other ramifications to undergo genetic testing that you have to be aware of and have that discussion. But certainly a meeting with a genetic counselor for this idea that you might have children and you're at a young age, and could they be affected?
Just one more question. Sorry, we're going to keep the schedule.
Yeah.
I was wondering, I was genetically tested and everything was negative, but looking ahead at all of the new subtypes that are being researched, do you recommend genetic testing again? Because now there are different things to be tested for.
Right. So one thing is germline testing, meaning do all the cells in your body have that mutation? But let's say you have kidney cancer that's metastasized. They can still do whole genetic testing on the tumor cells to try to understand what mutations might be happening in that particular cancer and whether they would respond to a drug, which is different than inheritable risk, right? So I think if the medical oncologists are in the audience, they can speak to when they perform, they call that somatic, not germline, genetic testing on the tumor. So.
Thank you so much.
All right, thank you very much.
The next presentation is going to be via Zoom. Dr. Jonathan Chachko. He's going to be talking about management of bone mets and kidney cancer. I did not create this agenda, but if I was creating an agenda, these are all the topics that I'd want to hear about. So thank you. And you got it, Jim? There he is. Welcome.
Sorry about that. I wanted to be there in person. Definitely had a few issues with my flight and a ground stop in Charlotte. So rather than a chance getting sort of waylaid in Charlotte, I figured I'd just give the talk by Zoom. So hopefully I can join you guys next time. I know we're running a little bit tight on time, so I'll try to just give the highlights of my talk. My name is John Chachko, so I'm an assistant professor at the University of Florida, and I'm a medical oncologist, so as I'm sure many of you are familiar with, we give medical therapies either via infusion, like immunotherapy, or orally with medications called VEGF inhibitors, most frequently for kidney cancer. I'm a medical oncologists are an important part of your treatment team. I'm going to be talking today a little bit about bone metastases, specifically what patients with kidney cancer and their families should know about these. So a few of the goals for today. So we're going to learn about the frequency and morbidity of bone metastases in patients with kidney cancer. We'll understand how bone metastases are detected by imaging and also by symptoms that patients may have, and learn about some of the main treatments for bone metastases. Let me go ahead.
Okay. So we'll learn about the frequency and some of the morbidity of bone metastases in patients with kidney cancer, understand how these findings are detected by imaging and by symptoms that patients may have, and learn about some of the main treatments for bone metastases, including surgery, radiation, cancer-directed systemic therapy, and bisphosphonates. And then we'll learn about the management of pain from bone metastases. So first of all, how do we find lesions in the bone? So bone lesions from kidney cancer can actually be a little bit difficult to spot on imaging. And that's because the lesions related to kidney cancer in the bone are most frequently lytic, meaning that the lesions are sort of hollowed out instead of denser. And those are more tricky to find. Oftentimes in patients with kidney cancer, bone lesions are identified because patients are symptomatic, and then we perform some additional imaging. And there are a few main tests that we can perform, and we'll go over this. So first of all, CT scans. So CT scans can show lesions associated with severe bone loss. And this is probably the scan that patients with kidney cancer most frequently obtain. Bone scans, or nuclear medicine bone scans, are given when a patient receives a tracer, and then a few hours later they will receive the scan. And the idea is to help to find metabolically active lesions, which are frequently cancer and it's seen in the bone in patients with known kidney cancer. Bone scans are unfortunately not as good at looking at lytic lesions, which are the type frequently seen in kidney cancer, but can still be helpful and can still be useful if lesions do show up on bone scan. MRI can be very helpful at detecting bone metastases and finds them in about 95% of cases. But these can be time-consuming and are not usually used for routine monitoring, since the scans can take so long if we were to do an MRI scan of the whole body. They can be especially useful for evaluation of bone lesion near the spine. And an MRI can also be particularly useful if there's an area that a patient is saying is painful, and we want to find out, is there a bone lesion there? And an MRI can be really, really good at detecting that. So how do we treat bone lesions? So bone lesions are treated in a few primary ways. These include surgery, radiation, cancer-directed systemic therapy, and then also bone strengthening agents. And we'll talk about these methods in a little bit of detail. So the treatment for bone metastases is delivered. Sorry about that. Don't know what that is. Okay. Sorry about that. The treatment is delivered, is determined by many variables, including the number of bone lesions, whether they are symptomatic, whether they might predispose to a morbid injury, and then also patient and physician preference. So first we'll talk a little bit about surgery. So surgery can be helpful if there is intractable pain, an impending fracture, spinal instability, or if the surgery is given with curative intent. That is, if all lesions are being definitively treated. So surgery is actually very, very effective at treating bone metastases. About 91% of patients do report relief of pain after surgery, and about 89% report good to excellent functional outcomes. So there is a real role for this intervention, but we have to make sure that we're doing it in the right patient. So for example, somebody that has a lesion that's particularly painful, where surgery can relieve that pain, or alternatively, if there's one isolated area of bone metastases and no cancer elsewhere in the body, with surgery we may be able to definitively treat that patient so that they don't have any cancer that's left. And that's always something that we aspire to do if possible. Radiation can also be an effective treatment for bone lesions in patients with kidney cancer. Systemic therapy such as VEGF inhibitors or immune therapy can be continued during radiation. And it can serve as another valuable treatment option. In addition, radiofrequency ablation can reduce pain in about 70% of patients. Cryoablation, where we essentially try to freeze the bone metastasis, can also control pain in about 68% of cases. These are probably a little bit less frequently used than standard radiation therapy, but nonetheless can be effective in the right patient. In addition, systemic therapy can also be a very useful method of treating bone metastases. So VEGF targeted therapy and immunotherapy appear to be active in treating kidney cancer with bone metastases. Sunitinib, one VEGF targeted therapy, has been shown to delay the formation of bone metastases when compared to another treatment which we don't use as frequently called sorafenib. So we do know that sunitinib is effective in treating bone metastases. And just as a review, VEGF inhibitors are typically given via pill that patients will either take once or twice a day. And they work to starve off the blood supply of the kidney cancer tumor and can also work in the bone. Cabozantinib is another VEGF-targeted therapy that can decrease osteoclast activity, change bone remodeling, and alter osteoblast activity. So as a reminder, just to fill you in a little bit about this, osteoclasts are the cells that essentially break down bone. Bone is constantly being remodeled. So by decreasing osteoclast activity, we can help decrease the breakdown of bone. And we know that kidney cancer, especially if it's in or near the bone, increases the breakdown of bones. This helps to prevent that. So one study randomized patients to receive either cabozantinib or everolimus, and patients with bone metastases had their disease controlled for about 7.4 months with cabozantinib versus only about 2.7 months with everolimus. So some clinicians feel that this is particularly interesting evidence supporting the use of cabozantinib in patients with bone metastases. We don't know, there hasn't been a comparative study to say that cabozantinib works necessarily better than other regimens, other VEGF inhibitor regimens or other doublet regimens where you get a VEGF inhibitor plus an immunotherapy in treating bone metastases. But certainly this is a good hint that it might be effective. And we do think that there may be some mechanism for this based on the receptors that cabozantinib targets. So it targets VEGF, but it also targets MET and AXL. And by targeting these three receptors, we're felt to have a little bit more activity in the bone, or at least that's one theory. Another study compared the combination of cabozantinib and nivolumab to sunitinib. So cabozantinib was favored in patients with bone metastases. So in general, for most patients, particularly with clear cell, the most common type of kidney cancer today, we usually do start with a doublet therapy, including a VEGF inhibitor and immunotherapy or two immunotherapies. And in this study, it looks like this combination was better than sunitinib monotherapy. So that's not a particularly surprising conclusion to some of us that treat kidney cancer, but we don't necessarily know rather that one combination therapy is better than another with current data. So another therapy that can be utilized is bisphosphonate therapy. So bisphosphonates inhibit the activity of osteoclasts. So those are those cells that break down bone, and these include zoledronic acid or Zometa and denosumab. Or Xgeva is the brand name for that, and this can reduce the risk of fractures in patients with bone metastases. So bisphosphonates do have some side effects, and they can include low calcium, injury to the kidney. This is notably seen more with zoledronic acid or Zometa than Xgeva or denosumab. Rarely patients can get what's called atypical fractures, where they may fracture in an unusual site. And something called osteonecrosis of the jaw can occur. It's seen in about 1.3 to 1.8% of cases, so it's uncommon, but it can be quite serious when patients do develop it. It can cause significant symptoms in the jaw, or the jawbone can be exposed through the gum, and it can be quite painful for patients. So the way that we try to limit this is by making sure that patients have good dental health before we start, and to try not to give an indefinite course. So we try to give about, usually I try to give about 1 to 2 years of therapy. There's some thought that giving extremely prolonged courses of this can increase the risk of this complication called jaw osteonecrosis. So it's just as a review, these medications are generally thought to be, be safe for patients, and especially with bone metastases. For most patients, we do feel that the benefits outweigh the risks, but there are just some side effects and toxicities that we need to be aware of and watch out for. And again, Zometa or zoledronic acid has some risk of kidney injury that's felt to be lower with the other medication called Xgeva, or the generic name denosumab. So sometimes I tend to lean towards using Xgeva, but they're both quite effective. In terms of managing pain from bone metastases, so bone pain can certainly be quite significant for patients, and so this is obviously a big concern for myself as a physician, and certainly for patients and their families. So it can be worse with movement or at night, and there can be tenderness to palpation. So anti-cancer treatment is certainly a key component of the treatment of bone pain, and bisphosphonates can decrease the need for analgesics. So they can be a really helpful adjunct. NSAIDs like ibuprofen or Advil are felt to be more effective for bone pain than acetaminophen or Tylenol, but some patients with impaired kidney function may not be able to tolerate NSAIDs. So certainly talk with your oncologist or your medical team and let them know that you're going to be using NSAIDs or Advil before you start it. Opioids can be helpful for moderate to severe cancer-related pain. And certainly long-acting opioids can, or like MS-Contin or OxyContin, can be helpful if pain is ongoing throughout the day. In addition, steroids can help with bone pain by reducing inflammation and swelling. And we do usually want to use them for as short a period as we can, because certainly with long use of steroids, there actually is some risk of a number of complications, but particularly when you're worried about bone health, there can be some decrease in bone density. So we do want to watch out for that. And then in addition, medications called gabapentin or pregabalin have shown inconsistent benefit in treating bone pain in clinical trials. And so we don't often utilize those. So just in terms of some conclusions, so certainly please let your doctor know if you have bone pain. Those bone lesions may not always be picked up on routine imaging, particularly CT scans and nuclear medicine bone scans. And again, that's because these lesions are often lytic and they're just a little bit tricky to detect with our standard imaging. MRI is very, very sensitive for picking up bone lesions. So for patients that have an area that is painful, if you do an MRI, that can be a very good way of ruling in or ruling out these bone lesions. I would say most doctors don't use MRI for screening because it's an extremely timing test to do an MRI of the full body. So oftentimes we really do reserve it for trying to diagnose a lesion when someone does have pain in an area. The treatment of bone lesions can be carried out with many modalities, including surgery, radiation, systemic anti-cancer therapy, and bisphosphonates. Surgery can provide excellent pain control and good functional outcomes, and can be especially favored in patients with a single metastatic focus, i.e., for example, we'll see that one lesion, we want to remove it, and there can be some benefit to doing that. Radiation can provide really, really good control of painful or potentially morbid bone lesions. I'm sure that you've all heard today from some of our other providers that radiation actually is quite effective for kidney cancer. Decades prior, we were a little bit unsure about that, but recent research has shown that it is quite effective. Systemic therapy can be a really important component and can be continued during radiation therapy in most cases. In terms of systemic therapy that can be particularly useful for kidney cancer, some folks think that cabozantinib may be one agent that can be very helpful, but it hasn't been directly compared against other doublet therapies. So just to clarify what I was saying earlier in the talk, so doublet therapies is when you use two medications at once, usually a VEGF inhibitor, the oral medication that patients take with an immunotherapy, or two immunotherapies. And we don't necessarily know that one of these doublet therapies is better than another for bone metastases, but for most patients, we do prefer some form of doublet therapy. Bisphosphonates are an adjunctive medication that can help reduce the risk of fractures in patients with bone metastases and can help with pain control. We do have to be aware of some side effects or toxicities, but in most patients with bone metastases, they can be a valuable component of their treatment. And then pain control is certainly important, and that can be done with multiple agents, including NSAIDs, as long as you make sure with your team that it's okay and safe for your kidneys. Opioids can be particularly helpful as well. So that was my talk. I'm very, very happy to take any questions that you guys have.
Hi, sorry, I missed the beginning of your talk, but I just wondered, as somebody who goes for regular bone density testing, would that show any indication if I had a bone metastasis beginning somewhere?
Thank you very much.
Thank you.
Thank you. So a confession to make, nutrition in my management of RCC is not my forte. So I'm looking for, I am eating more veggies, more fruit, less meat, less processed meat except for lunch at the Marriott today. But I'm doing my best. But we're honored today to have Roberto Pili, doctor at the University of Buffalo, who's going to discuss nutrition and kidney cancer. Thank you.
Well, thank you, Joel. I want to thank really the Junior Nicholson Foundation, Linda, Rachel, and all the team. It's been an honor and privilege actually to work with you throughout the years. I was there in Florida, I think, in inaugural meetings with Nick Nicholson. So thank you for all you do for our patient with kidney cancer. So today I'm going to talk to you about nutrition. You haven't heard about the nutrition so far. It's really close to my heart, how this can be impactful. And I'm going to discuss how maybe changing the diet, we call it dietary intervention, may have an impact on how patients deal with their disease. And I'm going to introduce this exciting project that we have in University of Buffalo called SNAC. It's called Science of Nutrition and Cancer Center Clinic, and its mission. If you're looking for a specific diet for patients with kidney cancer, probably I'm going to disappoint you at the end of my talk, but I hope nutrition is really nourishment of energy that is obtained from food consumed, or the process of consuming the proper amount of nourishment energy. An example of nutrition, as I've seen here, is really eating a healthy diet. And I want to try to make the case that to me nutrition is also to eat a healthful diet. And what I'm going to mean for healthful diet is going to be down through my talk today. Metabolism, you heard a little bit early on, is really changing food and energy. Our body needs energy, as you know. And these are I don't know if you can read it from the back, but these are the macronutrients that we use, proteins, carbohydrates, and fat. Those are broken down in the small units called amino acid, glucose, and fatty acid. And they help us to produce energy. And as been mentioned early on, the end point is really produce ATP, this token of energy, the fuel, the gasoline for our body to build the tissue in our body. And the cells are using this type of process. So why focus on diet and cancer? Well, let me tell you, there are a lot of, we call it epidemiological evidence that suggests that a healthy diet actually can prevent some type of cancer or can decrease the aggressiveness of type of cancer. This is an example of prostate cancer, but this has been shown also in breast cancer and colon cancer. And population there eating more fruits and vegetables seems to have less incidence of this cancer, maybe less aggressive type of this cancer, and vice versa. If the patient population they eat more animal protein, they seems to have more of this type of, we call it epithelial tumors. To me, this is a slide that I only present on my talk. It's very telling. These are, we know in Japan, in Asia in general, epithelial tumors like breast cancer or prostate cancer are low in incidence. Likely for genetics, but we want to believe also about the diet. So the studies show that when first generation or second generation of Japanese people migrate to Hawaii, their incidence of actual prostate cancer and breast cancer went up as close actually to the white Caucasian population, suggesting that perhaps the microenvironment and perhaps the food that they were taking indeed that was responsible for that. Now the American Cancer Society are guidelines in terms of nutrition and cancer prevention. These are common suggestions that we always want to pursue. I don't know if you can read again from the bottom, but you're going to have access to these slides. Maintaining a healthy weight throughout your life is very important. Maintaining physical activity is important. Consume a healthy diet, and the concept of healthy diet is probably more plant-based diet, more fruits and vegetables. And if you drink alcoholic beverage, to limited consumption. And I would say, I would agree with the CDC recommendation that there is no doubt the less alcohol we drink, the lower our risk for cancer becomes. And even for patient with cancer, I think the limitation of alcohol, I think, is important. If you look at the webs, there are many websites that might be very helpful to guide through what is a healthy diet. If you have kidney cancer, I really like the brochure from the American Institute for Cancer Research, UK, but other sites are very helpful. Again, I don't think you can read this. The Canadian Society for Cancer has a very detailed suggestion for patients who had the nephrectomy. Again, you cannot read this much probably from the back, but they recommend if you have a nephrectomy to protect your contralateral kidney. You're going to hear more from nephrology this afternoon. Lower the amount of protein, lower the amount of salt, lower the amount of phosphorus, and again, limit your alcohol consumption. Now, in terms of risk factor, we heard early on that there is no clear cause for kidney cancer, but definitely we know that obesity and hypertension are associated with kidney cancer, and obesity is associated with inflammation, and these are some of the studies done. This is, for example, an Italian case control studies or the Iowa Women Health studies linking dietary inflammation with kidney cancer, or body site and kidney cancer, obesity. And interesting, actually, here from the Danish group, early life body sites may be associated with increased risk for kidney cancer. So what is inflammation? I want to thank Bert Kirsch, a very talented registered dietitian when I was in Indianapolis, to lend me these slides. It's really the disorganized immune response. And it is actually harmful because the higher the level of inflammation we have in our body, our immune system is not working properly and cannot fight infection, and perhaps it cannot get rid of cancer cells. This is called immunotolerance. Now, there is a potential way to decrease the inflammation in the body with healthy diet, and this is really a plant-based diet. Avoid processed food, excess meat, saturated fat, and again, eat more plant-based foods. Why is that? Because these fruits and vegetables are higher in vitamins and minerals or fibers. There is actually a lot of interest in how high fiber diet can boost your immune system. Phytochemicals has been associated with some type of anti-tumor response. And again, the recommendation is to have 1.5 cups of fruits and 2 or 3 cups of vegetables daily in your place. And this is the classical Mediterranean diet pyramids. On the top of what things that we should limit in consumption, and in the bottom the things that we should eat more often. And as you know, Mediterranean diet, not because Riccardo and I were Italian, but as you know, has been always recognized perhaps the more balanced diet that you can envision. So my take-home message about this first part of my talk, to reduce inflammation that we believe it may hamper if you're getting the immunotherapy response to this treatment, and try to avoid dairy products, red meat, limit this consumption, increase really plant-based protein and fibers, increase cruciferous vegetables, eat maybe more fish, supplements with vitamin D and C are important, and definitely integrate physical activity if you can. I'm going to tell you at the end of my talk, again, diet and physical activity goes hand to hand. But throughout the years, definitely dietary intervention have been shown to have a very important impact on pathways that lead to cancer. And this is the work actually from my friend and collaborator, Luigi Fontana. Luigi is really world-renowned nutritionist now at University of Sydney. He's been primarily focused on protein restriction, how actually reducing the protein in the diet can actually increase longevity. Very, very interesting data. And 10 years ago, when I was at Roswell Park in Buffalo, we came up with the idea and test the hypothesis. If that's protein restriction can decrease aging process, can they have actual impact on cancer? And this to me was again, unfortunately, still a Mac and PC do not talk to each other, so there is some problem with the projection here. But this to me was an eye-opening experience. Okay, really in medical school they don't teach you much about nutrition. UB were actually fortunate because there is a culinary medicine that actually is taught to medical students. But that to me was the first time I saw that by changing the diet in these are mice that were implanted tumor, human prostate, human breast tumor in the flank, and we measured the growth. And if we change the diet from 20% to 7%, these are isocaloric diet. These mice get the same amount of calorie. However, we just decrease the amount of protein. We increase the carbohydrates, but we decrease the protein from 20%. This is a regular percent of protein that also as a human beings we have in our diet. Decrease to 10% was a significant effect on growth of tumors. And this is like a given chemotherapy or hormonotherapy. Again, these are prostate cancer. But breast cancer and kidney cancer, we see the same. And to me, it was fascinating that not only the amount of protein is important, but it's the source of protein. In this case, we give a soy as a main vegetable source of protein, or casein. As you know, casein is the main protein in the cow milk. That's why every patient I encounter, no matter what type of cancer, I tell them not to drink cow milk. We are not meant to drink cow milk. I know maybe there are some of you with dairy farms, but definitely is. I'm worried more about animal protein, some animal protein than natural carbohydrates. But this was fascinating to us because we could achieve the same anti-tumor activity by just changing the source, just giving soy as a main plant-based food as compared to casein as a main animal protein. We see the same impact on kidney cancer. This is a kidney cancer model, the Anca model. And actually with corn, if we give an extra of corn as a main protein, the only protein that these mice have, the tumor actually grows much slower than with other source of protein. Fascinating to us. In my lab, I was fortunate to have a very talented students that dig into why protein restriction can actually decrease the growth of this tumor. And we find out that actually has an impact on immune cells, and particularly macrophages. There are different types of macrophages. These are cells that tend to eat up cancer cells. And there are good macrophages, bad macrophages. And we saw with protein restriction, we were able to increase the good macrophages. But more importantly, as oncologists, we were excited. I was excited because when we give a PD-1 inhibitors, immunocheckpoint inhibitors, we give it to patients. In the mice, they were actually receiving a low protein diet. It is in the purple line. These mice actually live longer because we were able to treat more effectively the cancer by combining the low protein diet with the immunotherapy. And that's why we come up with this concept initiative to really build a place where we study science, nutrition, and cancer therapeutics. These are really, as you know, an unmet need for not only kidney cancer patients, but all our cancer patients. And try to really follow this patient longitudinally and to see how nutritional counseling and dietary change can help the outcome of our patients. This is a multidisciplinary approach, meaning we need to pool a different expertise. I'm a medical oncologist. We need to have expertise from basic scientists, from epidemiology, microbiology, pharmacology, nutritional scientists, and tumor immunology. But our goal is really to integrate diet with cancer therapeutics, whether it's immunotherapy or targeted therapies for kidney cancer, for example. And we do actually have a clinical trials right now up and running at our institution. I believe it's the only clinical trials in the country that test this hypothesis. For a short period of time, we reduce the protein in the diet, in this patient that are starting or getting immunotherapy. And these are patients randomized either to normal protein or to reduced protein. And we are trying to learn by collecting blood, collecting stools. We heard about the microbiome. I'm going to mention to you later on. So I mentioned to you about the micronutrients, how we utilize the micronutrients to produce energy in the body. Again, these are a little bit complicated. The Gupta also mentioned about the Krebs cycle. I'm not going to go into detail, but I want to just mention to you that cancer cells actually do not utilize the normal, regular way to build energy. And I compare the cancer cell like a coal. Using coal is a dirty, a very inefficient way to produce energy as compared to maybe green energy that normal cells do through their mitochondria. And the cancer cells do, it's called a Warburg effect. Maybe you heard about this word. Cancer cells, again, is not that simple, okay, but has been recognized a long time ago that you heard about that they tend to utilize more glucose or to utilize other source of energy in a less efficient way. And we try to actually burn glucose and produce this lactate. They try to ferment actually lactate in the cytoplasm. This actually raise the pH outside the cells. That's, you heard about the cancer cells like to create an acidic microenvironment. So that's what most of the cancer cells do. Again, it's not that simple, but for kidney cancer, it's actually quite relevant. These are very elegant work by Kim Rathmill and Marcel Linehan a few years ago, showing actually that kidney cancer, in particularly clear cell carcinoma, because you heard about the inactivation of the deletion of hippo-lindo genes, there's this upregulation of F1, F2, and that's actually drive the consumption, the uptake and consumption of glucose. But kidney cancer will also use the mitochondria, the Krebs cycle, as it's been mentioned early on, through the fumarate. There is actually specific mutation that you heard before. And years ago, we thought that actually some kidney cancer can be addictive to a non-essential amino acid, glutamine, that actually enter this mitochondrial production of energy. And we thought that actually there was thought that glutamine was an Achilles heel for kidney cancer. There was a lot of excitement to target this, we call a metabolic pathway. Things, of course, do not necessarily go the way we think. And unfortunately, there was these clinical trials that did not show the benefit that we thought initially. Again, this is still a very important strategy to implement. But just to mention, when we talked about target metabolism in kidney cancer or in any type of cancer, is a kind of complicated task. In our lab at the University of Buffalo, Sabrina Horsey, very talented PhD student, is now trying to learn how the mitochondria are used by kidney cancer cells. And we are particularly interested in translocation kidney cancer. You heard about this really rare disease, a very aggressive disease. And we learned that actually they use a lot of mitochondria to produce their function. But we learned also some clear cell carcinoma use mitochondria. They use actually amino acid more than glucose to get their energy. And again, I'm gonna go to details here. It's more scientific talk on these slides, but using this, we call it seahorse technology. Do you see that bump there? Tell us how much the mitochondrial function in these cells, in this tumor. And she started playing actually with the amino acid. She restricted the amino acid, they reduced the amino, keeps the glucose. These cells still have a plane of glucose, but just reduce the amino acid, whether they're essential amino acid, the amino acid that we don't produce and we need to get from the food, or the amino acid that are not essential. But in any case, we see a significant slowdown the metabolism in these cells. Now again, just in translocation kidney cancer system, but be particularly sensitive to this. So our goal is now is to enroll a patient in our biobank studies where we collect tissue from either nephrectomy or tumor biopsy. We try to learn the metabolism, how these cells behave. They use more glucose, they use more fat, they use more amino acid. And we have a way to create this tumor in vitro. We call it organoids, or in the mice, and we tested different permutation of these dietary interventions I mentioned to you. You heard it from Dr. Kuzel early on about the microbiota. We cannot talk about diet without talking about bacteria in the gut. And this was a very elegant studies done a few years ago, published in Nature, showing how diet can quickly change the bacteria in the gut. And these were healthy volunteers that were fortunate actually to be fed with French cheese and Italian prosciutto, and they saw a dramatic change in the bacteria. And as you know, you heard about the good bacteria, bad bacteria in the gut. And why this is important, you heard about it. We know that antibiotic, if you change the bacteria in the gut, this can be detrimental or hamper the response to immunotherapy. So we want to believe the diet can actually help to change the bacteria in the gut in a good way. And there's a lot of work that has to be done. Fascinating, this group from Gustave Roussy a few weeks ago published this paper in Science. Now we have an answer why patients on antibiotics change the bacteria may have less response, because it seems to the immunosuppressive cells from the gut goes to the tumors. And this is really driven by the change of the bacteria in the gut. It's fascinating. But this, I believe, is the new frontier in medicine, oncology, how diet can change the bacteria in the gut. Not only change the metabolism directly on tumor cells, we're very interested now to see how proliferation modulate the immune cells metabolism, but also through the bacteria in the gut, how this can be exploited to combine with targeted therapy. And as I mentioned to you, the other flip of the coin is really exercise. Exercise is so important. This study just came up a few weeks ago showing that very few minutes a day of strenuous exercise can make a big difference, can actually reduce cancer incidence. I want to believe this is important also if patient has cancer. There's a lot of interest now to integrate diet with exercise, and this is the same things that we're doing at UB. So my major message is really, I think every patient with cancer, every patient with kidney cancer deserve to have a dietitian as a personal trainer. As you know, the main challenge that we have is really the nutritional counsel is not paid, is not provided, and so we cannot build, so it's not sustainable. We are fortunate at University of Buffalo we have a way to support that initiative, but hopefully in the future payers will recognize the importance of nutritional counseling in cancer patients. And my dream is to have a place where our patients come, they get their treatment, but also they learn how to cook well and to eat well, to do exercise, and to meditate. So these are my summary slides. Nutrition and diet is a unmet need in kidney cancer patients. There's still a lot that needs to be done. I think it's fascinating how diet can change the metabolism of kidney cancer cells or in the microbiota. And our goal is really to try to exploit, to learn more about the metabolism in kidney cancer and how we can exploit it with that intervention. And at the end, to improve the clinical outcome of our patients. So these are acknowledgement of people in my lab and my collaborators, and thank you for listening. Yes?
If you have to be on an antibiotic while on immunotherapy, is there something particular you should do in the treatment when you finish the antibiotic?
Very good, important question. And there is a lot of there was a lot of interest, for example, for probiotics. Is probiotics actually helpful? Unfortunately, there was a paper in Science in a clinical trials looking at high fibers immunotherapy, and the assumption also probiotics. And probiotics actually were doing more harm than good. So I don't have a clear answer to your question. I would say minimizing the course of antibiotics. As I said, for example, a patient has UTI, uncomplicated UTI, can have a sulfa drug for 3 days, probably is better than a quinolone for 7 days or 10 days. So minimize, try to cut down. But of course, if you need to get antibiotics, you need to take antibiotics.
We'll take one more.
You mentioned the importance of nutrition. What about common medications that people take and that is impact on metabolism of kidney cancer? I'm thinking of like women with birth control, and I've heard, it's potential effects on cancer patients, but are there other types of medications that have been looked at?
Well, this is a tough question. I don't have an answer for that. I think, again, to have a multidisciplinary approach, to have a pharmacy that actually work with you, with oncology, to look at drug-drug interaction. In terms of hormonal therapy, of course, it can have an impact on metabolism in the body. And that's something definitely has to be discussed with a primary care physician and with a medical oncologist. There are some metabolic drugs like metformin that's been studied actually with the potential benefit. It's a anti-diabetic drug, but so far it's not really been panned out to be very effective. But it's a very important topic.
Thank you very much.
Thank you.
I'm pleased to present Dr. Matthew Murphy from the Moffitt Cancer Center, who's going to talk about my favorite subject out of all the decisions I made in my life with respect to my diagnosis in dealing with cancer. Seeking out palliative care, day one was absolutely the best decision, and I still use them almost on a daily basis. So thank you.
Thanks everybody for your patience and technical difficulties, but we got it figured out. Again, my name is Matt Murphy. I'm a palliative care physician down at Moffitt in Tampa. And I know everybody's filtering in back to their seats here after the break. So I'll start off by saying, let me start off by saying first and foremost some disclosures. I don't have any conflicts of interest to report anything related to the content that I'm going to present. But in terms of our agenda, I have to be perfectly honest. I was really, really excited when I was asked to give a talk on this topic, palliative care, how it helps you, because that lends itself to a very broad talk, a very high-level talk, which I think most people appreciate. I left my Kaplan-Meier curves at home in Tampa. I'm not looking to get too much into the weeds, and again, I really enjoy that, just having a conversation. So much so that I even, created what I thought was this clever little slide in terms of our agenda. Palliative care. What is palliative care? How it helps you. How can palliative care help individuals and families and caregivers with kidney cancer? And some time for questions and answers. But I have to say, hearing so many of our other, fabulous speakers today, I caught just a few things from different speakers that made me think, maybe I should touch on that, whether it's methadone, and maybe I should talk a little bit about methadone in this talk, or supporting caregivers. We should talk about the, interdisciplinary team and how we can best support caregivers and families of patients, or pain management for bony metastases. What are the different classes of medicines, right? So some of these things have already been touched upon. So, I'm going to leave those alone, and some of these other topics maybe are a talk for a different day. But what that got me thinking about is just the broadness of our field in general, of palliative care, of palliative medicine, and how we can lean in all of these different areas to really complement the care that's being provided by the oncologist, the radiation oncologist, the other members of the team. So let's get into it. What is palliative care? So I'm going to be giving just a broad, technical, I guess, type definition from CAPC, which is the Center to Advanced Palliative Care, which is a national organization really focused on research and advocacy, for patients living with serious illness. And so this is from their definition. And so what is palliative care? It's specialized medical care for people living with a serious illness, cancer being one of those. And palliative care really is focused on providing relief from the symptoms, the stressors of that illness, improving quality of life for both patient and family. And I would extend that to anybody else within the circle, again, coming back to perhaps non-family caregivers. This care is provided by a specially trained team, right? What we refer to as the interdisciplinary team, which is the heart of the palliative care model. And that team consists of doctors, nurses, many other specialists, some of which I'll list and touch upon in a couple of slides, all working together with patients' other doctors to provide that extra layer of support. And this care is provided based on the needs of the patient, not on the patient's prognosis. And in that same vein, the delivery of palliative care really is appropriate at any age, at any stage of a serious illness, and that can be provided alongside curative treatment. So one of the things I think that lends itself to confusion with regard to palliative care is that it's the field of many names, right? So you may hear palliative care referred to by some or all of these. Palliative medicine, supportive care, supportive medicine, supportive oncology, hospice, and palliative medicine, right? I've heard the word hospice used a few other times today. That can certainly be a scary word that may have some connotations associated with it. Recognize that regardless of what that service is called at any particular institution, the care that one receives is likely to be similar in many ways. And just talking about that term hospice and palliative medicine, that is the name of our specialty training. So when I became board certified in palliative care, my certificate says board certified in hospice and palliative medicine. That is because we are the physicians that are trained, have additional training to take care of folks who are receiving hospice care. And our field really, I'll say, kind of became more formalized in terms of board certification back in 2008. So we are a newer field considered to, compared to most rather. So that's just, the reason why you see that. That's the name of our field. So I mentioned the interdisciplinary team, and what does that mean? Well, frankly, we've all heard all day today from a bunch of different members of the interdisciplinary team, or heard those members of the IDT alluded to. So here's a graphic, just kind of outlining patient and family at the center of all that we do, and you see this team, right? This team of different disciplines surrounding the patient and family, working together to provide cohesive, collaborative, all-encompassing care. And one interesting thing, when you look at the word palliative, right, or palliate, and look at the root, in terms of its etymology, it comes from Latin palum, right, which is a cloak, to protect. So thinking about this, all these people protecting patient and family from distress, which I think is really fitting. I actually had to take this graphic, this cartoon, and expand it out because there's just not enough room to fit all the people that are part of this team. And this still is not going to be all-encompassing, but we just heard a wonderful talk about the role of nutrition in the care of persons with cancer, right? So you see the dietitian, you see integrative medicine, which where I work at Moffitt down in Tampa, we have an integrative medicine team when it comes to acupuncture, acupressure, yoga, music therapy, massage, art therapy, all of these additional services that can enhance that person's care. You've got behavioral medicine when it comes to the psychosocial support, of dealing with serious illness, psychologists, psychiatrists, of course, rehab specialists. So all of these folks, including many others, may be involved in that interdisciplinary team delivering that high quality care to that person. And so really this is the question of the talk. How can palliative care help individuals with kidney cancer? And I was really thankful to hear Joel share his story and involving a palliative care team early in his care. And again, that just speaks to the complementary value that the team can bring to what the oncologist is doing. So how can we help individuals with kidney cancer? Well, pain and symptom control certainly is a ton of what we do. This is primarily the reason why I have new referrals, why I'm seeing a new patient visit to talk about pain and symptoms. We can help patients and their families better understand their illness. We can help the healthcare team understand how illness is affecting patients and families. We've talked about all kinds of different considerations, not just the possible adverse effects of cancer treatments, but financial toxicity, multifaceted relationships between family and friends, the people kind of outside that exam room who are also being affected by this diagnosis. And so that's a way for us to lean in and communicate to other members of the team. And, hey, this is what's going on. I mean, are you aware of this? And how can we all lean in to try to help? Talking about what are the goals at the moment, recognizing that goals may shift throughout time, throughout treatment. What are the goals of the patient, their family? What are the benefits and burdens of these different treatments? Have those been discussed? Do we need to talk about that a little bit more? True shared decision making, right? Really ensuring that everybody's on the same page as to, what are the risks, the benefits, the alternatives to the current treatment. Talking about advanced directives, code status, right? What have you put pen to paper? Have you spoken with your spouse? Who would be the person that is your surrogate medical decision maker if you're not able to make a decision for us? These are all things that we can touch upon in advance, right? All with the intent of staying out of crisis mode. When I meet a person for the first time in the office, I say, I'm Dr. Murphy, it's nice to meet you. One of the things that we're going to work together is to keep you out of crisis mode, whether that's aggressively managing your pain, really making sure that we're talking, in advance of, if this, what are we going to do then, right? So really having that plan drawn up and put together. And as part of that, coordinating care, high quality communication, facilitating high quality communication between the various team members. So we're always happy to have that discussion with the other physicians, other members of the team to talk about, whatever may be causing distress to that person and or their family. So put another way, this is a cartoon that I put together really just to show it graphically, but to give you an idea of my personal practice, this probably in terms of, it's not exactly drawn to scale, right? But in terms of the things that I do in my day-to-day practice, and what we're helping people with, right? So we talked about pain management, coping with serious illness, helping with complex decision-making, care planning, helping to manage appetite, fatigue. You see all these things. I'm not going to necessarily read all of them. One thing that we certainly do, right, and notice it's a small part of my practice, right, is hospice. And I love the way that it was put earlier, that all hospice is palliative care, but not all palliative care is hospice, right? So hospice specifically focusing on aggressive symptom management, ensuring high quality of life for persons, not only serious illness, but if there is the expectation that that person has 6 months or less remaining in their life, and also recognizing that if somebody elects to enroll in hospice, with that general feeling, people certainly can and frequently do outlive that 6-month prognosis. So just something to mention. And that is not what I do in my daily practice, but again, recognize that that is our field. And so if I wanted to practice primary hospice medicine, I could do that, right? So just one slide on pain management. And the reason I'm doing this is because in individuals with solid tumor cancers, and individuals with kidney cancer being one example of that, referral to a palliative care team that first touch point, so to speak, with the palliative care team may be for assistance with pain, right? That's something that we commonly are helping to manage. And again, in my practice, that accounts for the majority of new consultations. And this really does allow me to very intentionally partner with patient and family to carve out that patient of their care, so to speak, to really lean in and focus aggressively on pain management, allowing the patient's oncologist to really, again, focus on the delivery of, say, the immunotherapy, right? And really keeping a close eye and monitoring progress in that department. So I think that also, and there's a point about this, but we really do have that extra training in safely managing and that's not just opioids, but other classes of medicines, maybe things that aren't routinely encountered by oncologists or by physicians in other disciplines, but that we, again, more routinely manage, and we're comfortable with managing those. So really it's about providing individualized care, and we've heard a couple of talks today when it comes to the genetics of and molecular biology of cancer, and really the future of oncologic care, developing those targeted therapies for each individual, right, based on their tumor profile. So that very much is the future of oncology. That really has been the past and the present of palliative care. We really do focus and pride ourselves on delivering that individualized care. What works for Mrs. Jones may not work for Mr. Smith, and that's because we're all built differently. It's a common phrase that I say to my patients quite frequently. We're all built differently. At the risk of sounding unscientific, that really is the truth. And so I've heard other folks talk about, well, sometimes this is a trial, right? And that's also true. Everything is a trial. What's most important is that frequent reassessment to know what's working, what's not working. Do we need to make changes? I frequently tell my patients, you're driving the bus. This is really at the heart of shared decision making. You're driving the bus or driving the car. I'm sitting in the back seat. I may be telling you, all right, we're going to get off on this exit, and then we're going to make a left. And you might say, no, I want to go one more exit. I'm going to get off at the next exit, and then I'm going to make that right-hand turn. There are many different paths to get to where we're going together. We're going to get there together. It's about just talking through it and figuring out what is the path that makes the most sense, right? And really that is determined by, how does that plan fit into the context of that person's life? When I see somebody in the office, I really do have the value of time. For my new patients, I may spend 45 to 60 minutes with that person. For a follow-up visit, it may be 30 to 45 minutes of face-to-face time, talking about what's working, what's not, what should we do next. And so it's so important to talk about what is happening, what is going on outside of that exam room, right? How are things going at home? How are things going on a day-to-day basis? Are we having more good days than bad days in a given week? And depending on the answer, again, what are the things that we can do together to try to flip that script? So that really is what we strive for, that individualized care. And I think what is most surprising to people is when I say, well, you've been in your body for the last X number of years, you know it a heck of a lot better than I could ever hope to. What do you think is going on? What do you think we should do? I have some people who say, I've kind of been worried about this. My body's telling me something. I think maybe this is going on. And I say, okay, let's explore that a little further. Maybe we can, act upon that and see what we see in that vein. I have other people who say, I don't know, doc, that's why I'm here to see you. What do you think is going on? And I'm happy to give my thoughts on that. But again, that really is at the heart of shared decision making. So just kind of wrapping up, should I see a palliative care doctor? Is this, is palliative care and the palliative care team something that I need to be thinking about? Well, if you're not sure, ask. There's certainly never any harm in asking, what are the resources? Is there a palliative care team available to see me? At some institutions, that's only in the hospital. They may only have a consult service where somebody who's admitted to the hospital has access to the palliative care team. at other places, certainly major academic, cancer centers, in all likelihood do have the benefit of having an outpatient office setting as well to allow you to see your palliative care doctor regularly. If you have uncontrolled symptoms and you want some additional suggestions how to feel better, there was some discussion earlier today about the value of second opinions or having another set of eyes, another set of ears to look at the situation with fresh eyes. I think there's a ton of value there, right? And so that's something that should be welcomed, right? To have another set of eyes looking at the situation to best help that person. If you're worried about next steps, if something is being offered in terms of that next cancer-directed treatment and there's side effects versus potential benefits, let's sit down, let's talk about it, right? We're hoping for the best and we plan for the rest. I tell my patients hope and worry can coexist. Ideally, they do. I tell people I'm always hopeful that that next treatment is going to be helpful. And at the same time, I'm always worried. And that is, again, just maintain that line of communication and, one day at a time. That next step, okay, where do we go from here? If somebody is considering discontinuing cancer treatments, or if there are no additional cancer-directed treatment options at that moment, that might be something that person is coming to see me a bit more frequently, that I'm a little bit more involved in their care. I don't have the graph, but frequently you see a graph where at the time of diagnosis, that person's oncologist is representing 95% of that person's care. Maybe the palliative care physician is representing 5%, maybe just meeting for the first time and saying, hey, maybe nothing for us to do right now, but you've got my number, you can call me, come in and see me. And then if there is disease progression, if that person is having some clinical decline, you may see the palliative care physician start to have a higher percentage, so to speak, in terms of working with that patient and their family. But again, just recognizing that it's about that team-based approach, working with that person's oncologist as well. And importantly, we never stop treating and taking care of somebody. I've never been a fan of the phrase, well, we're going to stop treatment, right? You can stop cancer treatment, cancer-directed treatment, but that doesn't mean that we're stopping, treatment or taking care of that person. That care may just shift. It may look different. So instead of that aggressive cancer-directed treatment, maybe we're doing aggressive pain and symptom management, working to explicitly working towards improving that person's quality of life, improving their function, right? So I just wanted to recognize that if we have a transition away from cancer treatment, there are plenty of those other treatments that become more and more involved. I've yet to hear the words, I wish I was sent to you later. Anytime this comes up, somebody says, I wish I came and saw you 6 months ago. I wish I came back and saw you as soon as I was diagnosed. So again, if you're not sure, ask. If you're not sure, ask. I think one of the limiting factors is that there's simply not enough of us, fellowship trained, board certified palliative care physicians in this country, and we're working on it. It's becoming a more and more popular specialty, so you're seeing more and more people come out of that training pipeline. But also we are trying to do things just like this and disseminate this messaging and some of these skills that we do each and every day to the oncologist, to the primary care physician, to the radiation oncologist to start doing some of these things. But certainly, if you're not sure, ask. With that, really that's all I have, so I'll just finish by saying thank you again for having me. Really a pleasure to be here with all of you, and I'll take any questions that you might have. Thanks.
Hello.
Hello.
So I can see how important the pain control, pain and symptom management is. If a person is improving with treatment, but has been on, say, a lot of opioids, high amounts over a period of time, I imagine that would be part of your role as well to help them to reduce that. And I guess part of me is wondering how difficult and how long it might take, maybe this isn't the right forum for this question, but how difficult is that if you don't require that anymore?
Mm-hmm. Yeah, that's a great question. It's certainly within the purview of this talk, so thank you for the question. I frequently have patients ask me, Dr. Murphy, when do we start thinking about tapering down the doses of this opioid, as an example, and working to get me off these medicines? And my honest answer is the same moment that I write the first prescription is the same moment that I'm thinking about how do we ultimately get off these medicines, or certainly get on lower doses of these medicines for the foreseeable future. I'll say that everybody is built differently, and we don't, one doesn't get on these medicines, and you mentioned being on higher doses, say of opioids as an example. One doesn't start on high doses of opioids. It's a thoughtful approach of starting with the lowest possible dose and, appropriately increasing the dose with time as circumstances dictate. So really it is a slow taper. It is a slow taper, recognizing that, we get used to these medicines from a drug and receptor standpoint in our bodies, right? So your body gets used to seeing it, and ultimately you will become dependent on it. What does dependence mean? Well, dependence means that there's an interaction between that drug and the receptor, and if I were to stop it cold turkey, so to speak, I could withdraw from it. Now, fortunately, withdrawing from opioids is considered non-fatal. I mean, certainly if there are other medical conditions going on and you're withdrawing from opioids, that can cause some issues, but it's very uncomfortable. It can be very uncomfortable to withdraw from opioids, but that's certainly within our purview, that slow taper, being in very close contact with the palliative care doctor who's prescribing those medicines. Did that answer your question?
Yes.
Yeah.
Thank you very much.
Thank you.
And I think the thing that always gets me is that I'm healthy and well now. I wasn't. And I feel like initially I just wanted to take care of myself, take care of my family. And when I was lucky, and a lot of it is luck for me in my case, to come into a world where I could help others, it was a way of lifting guilt for being healthy after a time of being sick, and just the most rewarding, important thing I've done besides raising my children. And so for that reason, I just hope I always remain healthy, and my answer is always yes. I'll help where I can. And with that, however, I can tell you there is never a day that I don't go by without thinking about having had kidney cancer and being reminded some way that I will never be other than NED, no evidence of disease, but I'm still considered on the paperwork a stage 4 kidney cancer patient with a long-run remission. And until it's okay to call me cured or call people like me cured, we've got a lot of work to do, and let's keep this going. So, but with that, I always look back, find what's typical in my situation these many years ago. I must say, first of all, 19 years ago, probably to this day, I was in a hospital getting treatment, which had followed almost 8 months of a misdiagnosis. I was, like so many kidney cancer patients, misdiagnosed, like a lot of women patients, dismissed as being menopausal or hysterical or slightly overweight or overstressed. My doctor did not really apparently think that a 6.6 hemoglobin was all that worrisome. Just go home and eat better was the basics, and I won't go into all the aggravating details. But I played a role in letting that long misdiagnosis go on. You may have done the same, thinking, oh, it's just my menopause, or just eating too much meat, or running around like a chicken with her head cut off. But I, in the rest of my life, was active, outspoken in a doctor's office. Nothing. He was the doctor, I was the patient. I sit silently and listen, and I got in deeper and deeper trouble lost 15 pounds in 8 months while eating better than I had in most of my life. Doctor finally did decide I was an alcoholic, needed to have a liver biopsy to prove it, never discussed this with me. And so I'm laying there in those first 25 seconds of getting an ultrasound that was to lead to a liver biopsy, and the technician turned the screen away. That's always another bad sign, when you're shut off from the information that the other party has. And I realized instantly, since I knew the liver was here and ultrasound was there on the right side, that something was wrong with my kidney. And at that moment, I call that my oh shit moment. It wasn't said so silently. But there I am, and a few hours later, a CT scan, lots of worried looks, again behind a glass screen, isolated, not informed, and no way even to know how to ask for that information. Every one of you who's been in this case has some aspect of that in their background. So I was, of all the parties, I'm the least prepared. I knew I had something wrong. Doctor finally called me about 8 p.m. that night, telling me what I already knew, that I had something on my kidney, and he would find somebody for me to talk to tomorrow. Well, that didn't seem soon enough at all, and I knew, of course, I was in trouble, and was just very lucky to be able to draw upon a name out of my kind of earlier life and my background being from a small town, I mean, this size small town in North Dakota, where when you got in trouble, you went to the Mayo Clinic. So I had this vague connection to the Mayo Clinic in Rochester, and finally, got through, and you can even go to the Mayo Clinic and knock on the door. I think they'd let you in. But from the Thursday of that first ultrasound, Tuesday morning, probably at like 6 o'clock, an overnight flight, I was there, and with an appointment and an itinerary of how to do this. And I, at that moment, realized there's another way to help a patient who's in the middle of a diagnosis. I found out then that I was not at that pea or peanut size mass that I assumed I would have had. Could not imagine anything bigger than that. To find out that I had a 10-centimeter tumor, basically the size of my kidney, that had been overlooked. My doctor said, "Didn't he even feel this thing?" And when a doctor talks to you like that, you know you're getting kind of a raw truth you maybe not ready for. I certainly wasn't. But we have a plan. And that's about the two messages, I knew I'd been misdiagnosed, poorly served, but there was a plan coming. And so with that, I did have surgery, removed this large tumor, but I'd also found out I had metastases throughout my lungs, top to bottom, no cutting away a bit of it, and clearly systemic disease. And this at a time in which there was no systemic medication except for high-dose interleukin. And, we all have to struggle with lots of decisions, but in my case, I had no choice. It was pretty sadly easy for me to make a decision to enter into the high-dose world, and just had to get through surgery, get well enough to be able to do that. But this has happily changed, but you are still, as a patient, left with that now what do I do situation, maybe with more choices, but after today, a reminder of the complexity of the choices you're asked to make, and at a time when you are probably the least prepared to do so of any other decision you've ever made. And so it's with that, then I given by our beloved Linda the task of trying to help, manage the complexities of a second or third opinion. I'm sure I didn't agree to attempt to do that per se, but to give you some, what I hope could be some helpful reminders of an approach. First of all, just as I've told my story as swiftly as I can and without tremendous lot of detail. I could tell a lot more, obviously, but that's what I think every patient needs to know how to do, to tell your story to yourself, to the neighbor lady, to the next doctor in a way that accurately reflects what's happened to you and where you are in that, I don't want to say journey because I hate that phrase. It's more like a slog through a swamp at midnight and you know there's alligators out there. That's how it feels. So, but you want to be able to say, I have this kind of cancer, not I have cancer, I have kidney cancer, I have clear cell, I have chromophobe, whatever it is. You might have to even dig it out and practice what you're going to say as you're moving to this next step. I was diagnosed 25 months ago after a long-term bleeding issue or pain in my back. You get that story correct and you do it so that you can do so with confidence. And if you're wrong, let's find out now before you go on to the next step. To do that, what I have found is helpful for me to keep things clear at a time, especially when it wasn't so clear, was to chart things. And I just explained to my seatmate, Gwen, that I am not the Excel lady, but I believe in paper and pencil, and I really charted out what had happened to me, what I had known, what I had not known, what information was given to me, what was not given to me. I know, for example, I would not have been misdiagnosed for so long had I had the wit to ask, if it's not this, what else could it be? I was told I had a tiny scabbed over stomach ulcer. This was to account for hemoglobin that's half of normal. That doesn't make sense to most people. And the nurses in the group would just practically have me sit down. But I did not know I could ask. I didn't know where to go get the information, and I didn't know that I had a right to that information, which seems stupid. It really is stupid. I didn't have a pathology report that said I had no ulcer. I didn't read that. I didn't know that the ER doctor who admitted me suggested that I see a hematologist. I wasn't given that information. So as desperately sick as I was, it took finally seeing information to have me realize that should have been mine at the outset. So that's why I want you to be sure, if you're going on to another treatment, another opinion, or facing a decision, should I continue, that you understand as best you can what's happened and what's happening with you right now. And so, if you make a timeline of some sort, if you make an Excel file, whatever works for you, to say, here's what's happened, here's my family history, here's what I'm prone to, whether it's laryngitis or I in my case, my mother had lupus, an autoimmune disease. I needed to know that I did not have a propensity for that before I could go into this immunotherapy. That let me go into it a little bit more quickly. However, another bump along the way, and you've all experienced it, or frankly is going to hit you, to be interested in a clinical trial and not know how that will affect your treatment or how a treatment might affect your inability to enter into a trial. I was told that since there was this one treatment, I could, however, before I enter that treatment, get into a clinical trial. My assumption, not disabused by the doctor, but my assumption was this was one trial, the one trial for kidney cancer. And if I didn't go into that trial then and there, before I went to the high-dose interleukin, that there were no other trials for me to go into. So my own ignorance propelled me to go into that trial. It didn't do me a bit of good, and it never went anywhere. It was a phase 2 trial. Another reminder to all of us that lots of trials do not really go anywhere. And then I went into the high-dose interleukin thinking this was my one and only and last chance. Happily, obviously I did well. No one can tell me yet why I did well. I just sort of attribute it to, being lucky or being generally healthy throughout my life, and yet I had this specter of my mother's autoimmune disease. Might well have been my immune disease as well, and would have made that impossible. So these are the kind of things you might have to, put on your slate of things to do before you make your next decision. Let's see. Do you have a rare kidney cancer? Is it hereditary, like Megan was asking? That's probably the first thing any parent asks. Did I pass this curse, this propensity, onto my children? I cannot tell you how long it was before I was told, and I think I feared to ask, could I have passed this on to my children? And to have that addressed and answered lifted my spirits. At least I haven't automatically damaged my children. I might orphan them. They might lose their mother unless I make this effort. But somehow to know that I had not made them, ill with what I had was some sort of relief. So here you are, ready to make another decision. You've decided perhaps, maybe, I will assume most people here are a little bit beyond that stage 1 experience with kidney cancer. And at this point, you may find you need to go on to another treatment. One has quit working. There's a lot of information you will have to ask. As we learned earlier on, there may be value to returning to a TKI, one of the targeted agents like Sutent, when there was, for a second time, a re-challenge, and when there was not much else to offer, that made good sense. Apparently, at this point where we have multiple immune agents, to return is probably not making sense. So what works in one experience of taking a disease may not at all be, taking a medicine, may not at all be the case for the next class of medicine. You have to understand that. And if your doctor, frankly, can't explain it to you, this is a reminder that you need to find a doctor who will be able to do just that. In any case, you need to be prepared to ask, as one of the other, the doctors mentioned, is where does this clinical trial information fit me? Where does information for a trial I might enter into, where do I fit in that? This is not an easy task, and it is where you have to do your best to understand what's available, and there are a lot of resources that can help you. Patients will be able to speak to you in patient terms, but we are not the real experts, obviously, but to help you interpret what your doctor has said to you or help you come up with a set of questions that will help you understand it. And there are resources. The Judy Nicholson Foundation has probably less than a year ago puts together more information about what do I ask my doctor. The Kidney Cancer Association does the same. There's others in the room who are part of SMART Patients, where patients help one another sort the information that's being thrown at them. Take advantage of all of those. And I think, I've got one more little note or two here. I think the thing that would be helpful to most is to understand that you need to teach yourself this, these things as you enter it, and to be comfortable enough so that you can go to your husband, wife, the children, your own friends and family and say, here's what I'm doing, here's why I'm doing it. And if you can't explain it well and comfortably, then you need more information, and you should be able to go to your doctors and get that information. And if not, then you're going to have to ask yourself, is this the right doctor? What other preparation can she and I do together so I'm ready for this next step? And it's a very open-ended period of time in your life where you have to decide, can I travel? Do I want to avoid starting a treatment until I get the kids, off to school in the fall? all these things come from you. And so you really do also have to say, where am I in this process? Where do I have the give of time and energy? What resources can I call upon? What realities do I have to deal with? And with a great deal of sympathy and encouragement and truly admiration for the wonderful changes that have occurred in this world of kidney cancer and research, you can do it. If you need help, you can reach out for the help. There's no shame in that. And everybody in this room and everybody they know leave you not in isolation, but with a community that you can surround yourself and to be part of, to help in this always difficult situation. That's it.
Thank you, Peggy. Family or friends and others who are going through this community and giving back, and we're all stronger because of it. It's people like Peggy and Glenn and others in this room that we're all better and stronger and better prepared to fight this disease and live a prolonged and quality life. So for that, I thank you, Peggy.
No, thank you. No, but I would also, just this is my little editorial comment, because I was so dumb when I started all this, I didn't even know that there was any other cancer besides that which I had. And finally it had a name, clear cell, and I realized there were more kidney cancers. I have been able to happily maneuver a really fabulous young woman who is now the kidney cancer research advocate in SWOG, which is one of those groups that puts on clinical trials. She is a rare kidney cancer survivor, alive and doing quite well thanks to a clinical trial that came out of the research that all these wonderful people put together. And so I think we will all see in the coming years an expansion of help for the rarer kidney cancers, and with that, those of us who don't fit all those rules in clear cell kidney cancer.
Thank you, Peggy.
Thank you.
And again, to the end, it's now my privilege to introduce somebody who I haven't known for a while, or for a long time, but he's clearly a force to be reckoned with, and that's Glenn Sykes. He's going to talk about clinical trials, and as you heard Dr. Hammer say, which was an epiphany to me, is they're not the last thing we should be looking at. They should be looked at as part of all the other options that we have at any time throughout this process. So Glenn, thanks for being here.
Thanks, everyone. Good afternoon. Thanks to the Judy Nicholson Kidney Cancer Foundation for inviting me to speak today. And from the start of my diagnosis, I have been a big believer in patient-to-patient education. I'm active in organizations like Smart Patients, you heard Peggy mention, also obviously the Judy Nicholson Kidney Cancer Foundation and Kidney Can. I've learned a lot from doctors over the years, but I learn an equal amount from patients, and I continue to believe that's a great way to navigate your kidney cancer. Okay, so here's a little bit about my cancer journey. I was diagnosed in December 2010 with renal cell carcinoma, clear cell. I was treated with a nephrectomy a few weeks after that. Unlike a lot of people, I was actually diagnosed correctly and was treated quickly as well, so my experience was lucky on that part. I had a radical nephrectomy on my left kidney. And then in June 2015, I heard the words that none of us want to hear, which is, your cancer has returned. And I still remember those first words, which we think we have cancer, and then those second words. I remember receiving a panic text from my oncologist saying, hey, we need to talk. So that was concerning. So I still have that original metastatic disease here in my lungs, but not from a lack of trying to get rid of it. You'll see a lot of my treatment plan. I've done a lot of things to get rid of my cancer. Some cases it's brought me stability, some cases it's actually gotten rid of it, but it hasn't gotten rid of all of it. Because I also heard the words in February 21, your cancer has spread to other parts of your body. So I, like Peggy, was a participant in high-dose interleukin-2, and I remember as I was going off to the hospital to get interleukin-2 in October 2015, and was scared and nervous and feeling pretty dark, Peggy reaching out to me and giving me a nice guiding hand as to what that would be like and things I should pack for the hospital and what that experience would be like. I've also received immunotherapy in the course of a trial, and I get to my history with trials in a minute. I re-challenged with immunotherapy. I know that's often a question. Can you re-challenge with things? I did do that in February 21. And we heard about HIF2 inhibitors, at least from Dr. Heimers earlier today, and I started that just in June of 2023, Belzutifan actually. I've also had local treatments, radiation on bone metastases. We heard about that today, on my spine and also a rib. I've had cryoablation on a adrenal met in December, and I've been lucky to have 4 cutaneous mets. So I've had most procedures on those as well. So it's quite a varied treatment landscape. My own experience with trials, since that is the topic for my talk today, looks like this. In 2011, shortly after getting my cancer diagnosis, I was marched over to the oncologist's office and presented a trial. I was traumatized. I was scared. It was terrible timing. So it was an adjuvant trial. I decided not to participate in that. Turned out to be a negative trial. As we heard, sometimes trials are negative. And it was terrible timing for me to be presented with that trial. In 2017, I joined a phase 3 trial, an immunotherapy trial here at Rush University Hospital with Dr. Kuzel, in fact, who you heard from earlier today. The treatment arm of that ended in July 2019. I continued to be in that study in the way of answering periodic survey questions. In 2022, I considered another trial. That was a trial that we heard a little bit about from Dr. Hannan. We didn't hear about the trial, but we heard about the drugs, radioimmunotherapy drugs. It was a trial, a phase 2 trial being run in New York City. I did think about it and decided after understanding it a little further that it really required too much of me. Personally, the costs were high, so I decided to pass on that. And I realized there was one other trial I participated in. Some trials are treatment trials, like the 3 I just spoke about, but I also participated in a trial that looked at time toxicity of patients coming to the hospital, how long they were waiting to see their doctor, how long they were waiting to get an infusion chair. Probably all these things seem really like real issues for you, so I was certainly glad that someone was actually looking at that as well. So just a little bit about you. I missed the very start of this presentation of today's conference, so I don't really know who's in the audience today. So I just had a few quick questions. So how many people are in the, let's work backwards. How many in the 10 years plus since diagnosis? Okay, good. Raise my hand as well. 5 to 10 years? Thanks. And then let's just say 0 to 5. All right, so we have some good newbies and oldies, I guess, in the audience. That's good to know. And how many people are currently in treatment? Quite a few of you, sort of what I'd expect. Thanks. And how many people know about clinical trials? Anyone in a clinical trial at the moment? Great, we heard about your experience. That's great. Well, it's good to know a little bit about you. So, this is, as I said, the topic's clinical trials. I don't have a vested interest in any particular trial, so you're hearing just my experiences based on my participation in trials, my consideration of trials, my experience as a patient. What I did to prepare today, I spoke to other patients, I spoke to my oncologist, made sure that she wasn't, she agreed at least with what I was saying, wasn't going to cause her to fall off her chair. I read other presentations on the topic. I read literature. I drew on as I said, my own experiences and my, actually it should be 4 years of advocacy work. So we've heard a lot about clinical trials, particularly as we heard from the doctors, without necessarily defining what a clinical trial is. So I'll give you a minute to read that definition on the right, which is from the National Cancer Institute. What is a clinical trial? Now, I know from my own experiences that as soon as you say you're considering a trial, your friends and family will immediately say, oh my gosh, how can you let them do this to you? You know, treat you like a lab rat, right? All kinds of risky things are going to happen to you. And really, that's simply not the case. I hope I can give you some idea that that isn't the case. Trials serve a really important role in treatment. Anyone who has received treatment has probably indirectly or directly benefited from patients that have gone through trials and the science behind trials as well. If you might be surprised, though, to learn that trials, given the really important role they have in the treatment landscape, that participation and awareness of trials, although this audience on the awareness side is high, is less than 10%. So less than 10% of patients are aware of trials and also participate in trials. Today's presentation isn't really going to take a deep dive as to the whys to that question. There are a number of answers to that question, including that not understanding trials, doctors not presenting trials as an option to their patients, heritage of trials, doing nasty things to patients, and patients being, of course, unwilling participants in that as well. But that's a topic for another presentation. So there may be some trials, for example, the phase 2 trial I considered was really a small number of patients. Most phase 3 trials, which are the most prevalent trials that you would be presented with, have hundreds of patients in them. They take the patients, they take doctors, researchers, specialists in statistics, protocol specialists, which are the people that look at the plan, patient education experts as well. All those people come together to make a trial work. So it takes money, it takes resources, so you need sponsors. Some of the sponsors of research include the National Cancer Institute, the Department of Defense. It turns out that veterans are more susceptible to kidney cancer than the general population, so they get involved in cancer research. And of course, pharmaceutical drug maker companies do as well. Once you get into the world of trials, you've already heard a little bit about that today, you get to hear the word phases. That's a phase 1 trial, that's a phase 2, phase 3. I put on the right what are the questions that each step of the trial will answer. Some things will never make it out of phase 1 on phase 2. Some trials will go through all the way from phase 1 to 4, but it's important if you're thinking about a trial to understand what kind of trial it is, what phase is it, and what is the question they're trying to answer. That's really informative information for you. So this slide and the next one after that are my attempt to answer the question, what makes a trial a good trial for you? I'm assuming that the trials that probably the patients in this room will be presented are all going to be NCI-approved trials. So we're not talking about quackery here, but really a legitimate trial. It doesn't mean the trial is right for you. So first and foremost, a trial needs to offer substantive benefits to you. It will offer benefits probably to your doctor in terms of building their career, the researchers and statisticians, but ultimately it has to offer you a benefit. It is thought, and I think we heard a little bit about this, I forget from which speaker, that sometimes patients can have unrealistic expectations for a trial. They'll hear the word trial, they'll think, great, this is the new thing that's going to cure me. And that isn't necessarily true. And one way to kind of filter your expectations is to ask your doctor for statistical information that can give you some sense, all right, where should I place my expectations for this trial? Certainly when it comes time for you meeting with your doctors, I hope all of you here practice shared decision-making with your doctors. That means candid discussions of pluses and minuses of something. Unless it's what you want, no doctor should dictate to you. We heard a little bit about that from Peggy. One thing that a doctor will need to help you understand is how they're going to help you stay in the trial, or how they're going to treat your side effects. And they need to look beyond the trial. What happens if the trial doesn't work for you, or the drugs being offered in the trial don't work for you? How are they going to, what could happen to you next? Is what you're doing now going to rule out something that happens in the future? And then a doctor needs to be able to explain in really easy to understand terms, not doctor terms, not scientist terms, what's the excitement about this trial? A potential cure, better quality of life, slowing disease growth. And this last point really is related to the previous two. Phase 3 trials compare a standard of care with something new to see if that new is better than the standard of care. Make sure that your doctor can, again, explain to you in easy to understand language why it's going to benefit you, and not some lofty goal of a patient population that you don't know that's going to exist in the future. They really need to come down to benefiting you. So trials are scientific exercises, of course, and they can often be talked about in scientific language. The principal document that you will be faced with if you're thinking about a trial is called an informed consent. That's where it's going to talk about what's happening to you, what's the goal of the trial. It's supposed to be written at an 8th grade level of English comprehension. And I see Peggy shaking her head. Some do, some parts do. I haven't read a consent yet that uniformly is written at that level, partly because it's not written by 8th graders and it's not reviewed by 8th graders. So if you have an 8th grader now, maybe you should put the consent in front of that person and see what they understand about it. But do take the time to read it again. Have family members or friends read it. Really take the time. I've always taken the time to read a consent and again. And by the way, you can sign a consent, agree to be in a trial, but basically every time you walk in to get treatment, you're giving your consent again. So you can withdraw your consent, you can get out of the trial completely, or you can stop treatment, stay in the trial, and continue to participate. You can use your tissue, for example, if you want to, but it is valuable, I think, to be in a trial. And if the treatment isn't working, you can certainly just stop the treatment. And let's talk about when you're presented with the trial. I'd recommend that's really important. I think about my experience in 2011 being marched down from the urologist's office, who I think thought he was doing me a favor, down to the oncologist's office, having just heard the word that I sure had cancer and be presented at a trial was not the right timing. So I think the timing can really negatively impact when what you hear from the doctors. So make sure the timing feels right. Trials ask a lot of you. Cancer care asks a lot of you. Take time to understand the cost, and I'm talking about financial costs, time costs, relationship costs. A lot of you have child care responsibilities, elder care responsibilities. Everyone's limited in some of resources, and understand the extra things that trial is going to ask of you. We heard about the concepts of financial toxicity, time toxicity. I'd throw out there relationship toxicity. So make sure you're really clear on what that trial is going to ask for. I mentioned I considered a trial just a few months ago, phase 2 trial. And it goes back to the informed consent. Although there was a study calendar in it, I had no way of understanding exactly what was being required of me. How many trips to New York would it take? What was the time between trips? It was written, I don't know what it was written in language-wise, but it wasn't written in a way that helped me make a good decision. So I took the time, put a spreadsheet together, saying, this is what I understand, this is it, by picking pieces of the trial out. Now, I did work with the study team to ask them to confirm that my understanding was correct, and they worked with me to help me understand that. And then that's what I decided. 28 trips to New York over 7 months was too many trips. And on top of that, there was radiation safety issues to deal with as well, in terms of how close I could be with people for a certain amount of time, which were just sort of broadly described as we will give you the safety guidelines in due time. So again, you can understand why at that time I didn't think it was the right trial for me. I had some other options. So some of you may be gamblers. You understand the sense of table stakes, what it takes to be in the game for you to even to be considering. So I feel like all the things I put on the slides before this one are all the table stakes. So before you even think about a trial, make sure it meets the table stakes. Now, if you think a trial seems worthwhile for you to go a little further at it, here's some benefits to trials that we often hear about. First of all, you get access to treatments that you might not get access to other than through the trial. So that's really helpful. And drugs are expensive. If you get the drug that's being tested, that can be a big benefit to you. My immunotherapy costs $46,000 is the list price. So those things are important. One thing that often patients who participate in trials talk about as a benefit, sometimes as a surprise, is the attention you receive. You suddenly move from regular patient to a trial patient. There are a lot of people that care about you. The research nurse particularly cares about you a lot. My research nurse here at Rush University Hospital, she was there to greet me when I came in. She tracked me throughout the day. She came and checked on me in the infusion chair. She made my next appointments, and people respond well to that. Your doctor, is also really interested in what's happening to you. They're always going to be interested in you, but it was an extra level of care that I wasn't expecting, and most people feel like it gives them a really warm feeling. A trial can often give you another option. We heard earlier today, I don't know your name, sir, but you talked about you always had thought trials were sort of the last option you did. And trials are something I think that you consider at every inflection point. In my particular case, it was my first inflection point, which is I had my kidney taken out. I was cancer-free at that point in time. What could I do? Another inflection point is my cancer had returned. What should I do? And then more recently, my cancer had spread to other areas, and what else could I do? So those were all inflection points, and I think it's worthwhile to think of those. And those weren't, I don't think they're my last inflection points, as far as I know, but I think those are important times to think about trials, and your doctors should be talking to you about trials. So here's a few resources. One common question might be, where do I find out about trials if I'm not hearing about them from my doctors? Is clinicaltrials.gov. But a lot of people feel like that's a really cumbersome database. There's over 2,000 kidney cancer trials listed on there. It's hard, it's dense. Other patients can help you get through that, maybe patients with more experience or a background in that. That's where patient communities, I think, really come into play. But ask your doctors, talk to other patients about trials. That's a good way to find out. A common question that I get from family and friends, and often associated with the trial world, is you're going to get a placebo, which is a fake drug. Unless there's a reason why you need to get a placebo, which is not that common, may be given when there isn't any other types of care, you're not going to be given a placebo. Take time to understand, one common question is, do I get reimbursed for the cost of a trial? Think about your standard of care. One kind of division is, what do you need to do just for, if you weren't in a trial? You probably have to get scans. You probably have to get lab tests. And generally all those standard of care things that happen to you are not going to be covered in the trial. Now, if you receive a drug that they're looking at in the trial, the non-standard of care option, that's going to be covered. If there's extra lab tests because of that, that's going to be covered. But you're generally not going to be compensated to be in the trial. Occasionally there will be some stipend for travel costs. Of the 4 trials, 3 treatment trials I looked at, one of them did have a travel stipend. It wasn't enough to cover all those trips to New York. That is, I just thought about some questions that you might have. And here's some more resources, smartpatients.com. Really, I have been a member of that and the precursor organization from the time of diagnosis. Has been great. We already know Judy Nicholson Kidney Cancer Foundation is a great resource. KCA, Kidney Cancer Association, KidneyCan. The International Kidney Cancer Coalition is a association of associations. They do a lot of good primary research. I encourage you to get to their website and read some of the information they put out there. If you get into a trial and decide that everything's perfect about it except it costs too much, first of all, identify that issue with your study team. They need to hear the issues that are keeping you from participating. But also there are organizations like Lazarix as well. The cancer.gov Tralaclos website also has some information about how you might be able to cover those costs. And I think, oops, that's it. There's my website. That there is right down the street, by the way. There's a swim race, charity swim. It's not really a race. I do every year called Swim Across America. This is taken just about a year ago down in Lake Michigan. So I encourage you to, if you ever have a swimming background or would like to have a swimming background, to participate in that. So that's it for me. I think I probably didn't help on the time front. I'm sorry.
Great. Thank you, Glenn, and thank you, Glenn and Sally, for participating in trials. We all owe you gratitude. I'm going to introduce the last speaker, who happens to be my nephrologist. So I would retitle this presentation, How to Take Care of Joel's Remaining Kidney. But I apologize to her in advance. I have a palliative care appointment, so I have to sneak out. But I think I heard most of your presentation at the Zoom call last week. But this is Anca Zegrian. She is my nephrologist. She's fantastic. And she's going to tell you how to take care of Joel's kidney. It's all about me, right? So thank you so much.
Well, good afternoon, everyone, and thank you for inviting me. And I was humbled to hear everybody's experiences around the room, and all the prior speakers have definitely taught me a lot today. I know it's late and it's been a long day for everyone. I'm hoping not to put anyone to sleep right now, but I'm going to try to go through this pretty quick. I'm free for questions at the end of the presentation. I'm happy to answer anything or any thing that comes to mind for at the end when I'm. So let's get going here. Does this work? Anyhow, why is it important to see a nephrologist as a cancer patient? Unfortunately, part of being on treatment and going through radiation and surgeries and CAT scans and so many things that you all have been through and are going through can put a lot of strain on even healthy kidneys, let alone when we have to work with one or part of a kidney sometimes. So the point of having your kidney function monitored closely is to make sure the medications you're given are dosed appropriately, and most importantly, that nothing that you're prescribed or nothing that you may obtain over the counter or recommendation from a friend or a supplement could be hurting the kidney that you have. Unfortunately, a lot of patients that have a diagnosis of renal cancer, renal cell carcinoma most specifically, and undergo a partial, meaning part of the kidney removal or an entire kidney removal, are at risk of losing kidney function just by that procedure itself. Even patients that have a normal kidney function prior to the procedure have about 1/3 chance of having an acute drop in the kidney function after a total nephrectomy, meaning after a whole kidney was removed. And then they have about 4 times higher chance of developing chronic kidney disease over the course of the next few years. From patients that have only a partial kidney removed, about 1/5 will also develop chronic kidney disease. So why is this happening? Why are we seeing chronic kidney disease so commonly associated with renal cancers? One of the main reasons is, unfortunately, some of the risk factors for renal cancers are also risk factors for chronic kidney disease. And those would be high blood pressure and, male sex puts you at higher risk, and, other common chronic conditions. So of having a prior episode of an acute kidney injury is also a major risk factor for developing chronic kidney disease later on in life. Unfortunately, some of the procedures and some of the medications prescribed could affect the kidney function and filtration, especially when cumulative doses are being given. And most importantly, losing that kidney mass. So by losing a kidney, we lose part of the filtering function of our kidneys. At birth, we're born with an excess number of filters in our kidneys. Unfortunately, with aging, some of that reserve gets lost. And then when you lose a kidney or part of a kidney, you immediately lose all those functioning little cells that cannot be replaced, but the remaining kidney is usually able to compensate and grow and get usually a little bit hyper functioning and able to pick up some of the slack, to say so. So oftentimes we see at about 6 to 12 months that creatinine level that initially after the nephrectomy may have jumped quite a bit come down slightly. Not in all cases, because most patients, unfortunately, that have renal cancers also have underlying chronic kidney disease that precedes their diagnosis of cancer. So why is this, again, why are we seeing all these changes? In part is, like I was saying before, that some of the patients would have this pre-existing chronic kidney disease, and this is evident on the biopsy. So ideally, as a nephrologist, I'm very interested when one of my patients undergoes through a partial or total nephrectomy, not only to get their pathology, their cancer diagnosis, but also the information that tells me more of how much reserve we have and how much kidney function this patient is going to have. And that is usually included in the report, and the surgical and pathology report, where they're gonna mention if there is any chronic damage to the rest of the kidney. So that is the very important piece of information that in nephrology will be able to tell the patient, you're gonna be fine, your remaining kidney is really healthy, and you're not gonna have a lot of chronic damage and a lot of problems down the line, versus if we get a biopsy result that shows that there's a lot of pre-existing scarring in that healthy part of the kidney, that is not that good of a sort of prognosis as far as chronic kidney disease goes. So the risk factors I mentioned, they're common for both conditions, and unfortunately male patients, older age, smoking, being overweight, and conditions as diabetes and hypertension are most commonly associated with the two. Just briefly going over, I know a lot of people get nervous when they hear about CKD stages, and especially, everybody thinks immediately of cancer, and in nephrology we use staging, but has nothing to do with any cancer diagnosis. So the stages of chronic kidney disease are mainly created for us nephrologists to be able to stratify the patients, to stratify the goals of care, and what we need to monitor for, what medications can be used or cannot be used. And you may have experienced yourself, there are certain medications that he was talking about clinical trials and reading the medications. Some of them may be contraindicated when your GFR drops below a certain level, or so on and so forth. So this classification, again, has nothing to do with the staging of the cancer. This is a pure classification of your remaining kidney function, and it is based on an equation that's very complex and includes your age, your sex, your creatinine level. So it is derived from any other markers that are measured in the blood work. So why, where should we look and where should be careful? So does everyone that had a nephrectomy need to be evaluated for chronic kidney disease? The answer is no. We know very well there are successful kidney donors, live kidney donors all over the world. As long as your body is healthy, as long as you have a good lifestyle and your body is in good shape, your remaining kidney is likely to be a healthy one, and you have a good chance, like we saw, only a certain percentage of patients that have a nephrectomy end up developing chronic kidney disease. So what patients need to be monitored carefully and screened for chronic kidney disease are the ones that have some pre-existing condition or they have some other associated risk factors that would predispose you to developing chronic kidney disease. Unfortunately, having just one kidney tends to accelerate the process of chronic kidney disease because, like I mentioned, when one kidney is removed, the remaining kidney sort of hyperfilters, works harder to make up for what was lost. So therefore, it's kind of an overdrive function, and unfortunately tends to burn out a little bit faster than when you would have both kidneys present. So what do I do other than taking care of his kidney? Trying to reverse what we can reverse. There are certain things, certain causes that we can address and we can prevent in kidney damage. We try to slow the progression of chronic kidney disease because unfortunately, like any chronic condition, it is a progressive disease. And then we have to monitor for different complications and address and again take care of anything that may come along the way. And lastly, when the time comes, we have to have the conversation about hemodialysis or some other form of renal replacement therapy. So what are the most common causes that are reversible, where we can help the kidney by small intervention? So one is most commonly seen as dehydration, and that comes from losing fluids and not being able to take enough in, and a lot of patients unfortunately experience this after chemotherapy sessions and after other episodes where infections can cause it, or any loss of fluids and not being able to keep up. So this is something that again you need to recognize quickly, and if you're not able to hydrate on your own at home, speak to your doctors right away, get to your oncologist or nephrologist office, make sure you get IV fluids as quickly as possible. Again, trying to prevent any episodes where your blood pressure may be dropping, where you may have very low blood flow to the kidneys. That would be very detrimental. So high blood pressure is hard on the kidney, but so is low blood pressure, especially if it is persistent for a longer period of time. And then again, identifying early any signs of infection and treating it promptly is important. And lastly, but probably one of the most important things, is trying to avoid any possible medications that may be hurting the kidney. Some are very commonly used, available over the counter. Everybody tends to, get an Advil or something from that class of medications as soon as they have a headache or a toothache or a backache. So unfortunately, these medications are very commonly used. They're available over the counter and sometimes even prescribed by certain specialties. So, these sort of pain medications are not ideal for patients with chronic kidney disease. And then some medications such as ACE inhibitors, which are a class of antihypertensive drugs, which are great medications in the right setting, but could be harmful to the kidney in the setting of dehydration or low blood pressure. So again, I've mentioned already the risk, sort of the non-steroidal anti-inflammatory. Recommendation is to avoid use when the GFR, so we're talking about going back to the stages. Patients with stage 3 chronic kidney disease should avoid the use, and patients with stage 4 or less, so stage 4 and 5, should not use non-steroidal anti-inflammatory. Another risk factors, and this is one of the sort of the big elephant in the room, to say so. Surveillance, CAT scans are oftentimes needed every 3 months, every 6 months, every year, depending on sort of the stage and the pathway and the sort of time from therapy initiation. We have to be mindful of contrast exposure. Unfortunately, we cannot avoid it completely at times, but the recommendation is to try to minimize the contrast load, meaning we have to try to do these studies only when they're absolutely needed, when a non-contrast study will not give us the answers that we're looking for. And unfortunately, the only thing that we have currently to try to protect that kidney from the damage of the contrast exposure would be hydration. So I always recommend my patients to hydrate orally about a day to 2 days prior a contrast study, and then have a discussion and have a protocol in place with the oncologist or whoever the ordering physician may be for the CAT scan, to have a plan for IV hydration. And this, 90% of the time, this tends to be successful, and patients go through these testing without any further damage. And it is a good idea to have your kidney function rechecked about 2 to 3 days after the contrast exposure. Now, there will be other medications that are recommended to be held prior to contrast administration, such as metformin and diuretics. Now, the biggest part, sort of where my job lays, is trying to slow down the progression of chronic kidney disease. And we don't have a lot of options, but it can be done. And with the help of a patient, it can be successful. It is sort of a teamwork. It cannot be accomplished just by the physician sort of recommending certain things. It is partly, and a lot of it is the work of the patient. So diet is very important, and I know there's been people here that spoke about different recommendations on that. So sort of proteins are needed, but not in excess. So avoiding any type of high protein foods or diets or supplements puts less strain on the remaining kidney. Smoking cessation is absolutely mandatory, and then treating other associated conditions such as metabolic acidosis oftentimes is seen in later stages of CKD, also helps to protect the remaining kidney. And of course, controlling the diabetes and controlling hypertension. So most guidelines for blood pressure control suggest a target blood pressure of 130/80, with some exceptions. Most important determination of sodium content would be a recommended dose of about 2,000 milligrams, which is 2 grams a day. It can be a little hard to achieve, because when you start reading labels and looking at everything, you notice that there's sodium in almost everything that we touch. The average consumption is about double that in our regular diet. So it is difficult to achieve, but it can be done. And then, choosing the right agents for blood pressure management is also important, depending on, again, other associated conditions such as presence of protein in the urine, or, depending on your GFR level and so on. Diuretics are oftentimes needed as well to help with balancing the fluid and the swelling and so on. Target glucose control for an A1C of less than 7, unless there are other limiting factors. And the new sort of kid on the block is this new class of drugs. I'm sure everybody that watches daytime TV has seen a lot of commercials for Farxiga these days. I have no financial association, but I know I don't watch a lot of TV, but every time I do, there's a commercial for Farxiga. So this is a class of drugs that has been there for many years in treating diabetes. And lately, the studies have shown tremendous benefits in patients with chronic kidney disease, slowing down the progression of chronic kidney disease, reducing protein levels in the urine, and also a good cardiovascular protection benefit. So it is, again, the data is coming every month. There's a new study published about it, and the data is very strong. And again, just to be clear, the latest sort of indication is even chronic kidney disease without diabetes. So that's how strong the data has come back to be from all the studies, that FDA approved this class of drugs to be used even if you are not a diabetic.
Sorry, I didn't catch at the beginning what class of drug it is.
They're called SGTL2. They're diabetic, they're anti-diabetic
Is
drugs.
that like metformin? Or
No, it is
like Ozempic and that stuff?
Farxiga.
Farxiga.
With an F. I can write it down for you. So these sort of have been around now for a couple years, particularly helpful, and I've had good experience. I was reluctant in the beginning, and patients were too, but I'm starting to see people come back now after 6-12 months of being on the medication, and the results are positive. So it is something to consider and discuss with your physician. Other things we need to watch for in patients with chronic kidney disease, and this is mostly for later advanced sort of stage 4 and stage 5, are bone and mineral abnormalities. A lot of people think of the kidney of just being sort of making the waste management of our bodies, but kidneys are the smartest organ, and I may be biased, but I truly believe so. They are involved in regulating many other functions in our body. One of them being your bone and mineral health by producing sort of activated vitamin D and regulating the phosphorus and the calcium excretion and balance in our body. So this is again something that falls under the list of things to watch for and discuss with your nephrologist, and making sure all these parameters are in the right sort of range. So again, this is sort of a summary of what the kidneys do and why are they so important, not only as a urine producer and filtering mechanism for our waste products that are generated by metabolism, but also by regulating the acid levels in our body, by regulating the calcium and phosphorus that are essential for normal function of our bones and muscles and our cardiovascular health, and regulating salt and water. They affect, or they can cause changes in blood pressure. Kidneys are involved in controlling your level of hemoglobin. Oftentimes, even patients without cancer that have lost a kidney are predisposed to having anemia, because the hormone that stimulates the bone marrow production of red blood cells is produced by the kidney. It's called epogen, and it is hormone that sort of dictates the bone marrow how much red blood cells to produce. And losing a kidney makes you lose that epogen production or some of it, and by that putting you at risk of having anemia. So oftentimes this is associated with chronic kidney disease. And in other conditions, like I mentioned, our bone health sort of can be affected by accelerating osteoporosis or bone loss if vitamin D levels and calcium and phosphorus are not treated. Most patients with chronic kidney disease will be predisposed to having high uric acid that can lead to gout. Even if your diet is perfect, and if you're trying to be as careful as you can be, unfortunately, loss of kidney function, loss of filtration function can lead to gout complications. I think this was my last sort of closing. Thank you again, and I want to wish you all good luck, and you're fighting a good fight. And I think it's so important to have the community you have and each other's support. As physicians, we can give a lot of advice, but I think when you hear it from somebody that walks in your shoes, it's totally different. And it's so nice to be there for each other, I think. So congratulations for sticking out to each other there and being a good friend. And all right.
The medication you were talking about, are you saying that's to be considered when a person's already having, kidney damage, or are you saying to prevent kidney damage?
So it is important to start it sooner rather than later. It is contraindicated when the GFR, so we were talking about those kidney functions, when the GFR drops below a certain level, it is not ideal to be started anymore. So typically the sooner you start it, the better it is. But yes, it is indicated in patients that have signs of chronic kidney disease. And that can mean a decrease in GFR, meaning the filtration fraction of the kidney may be lower than 60, which is considered decreased, or it could be just the presence of protein in the urine. So the first two stages of chronic kidney disease have a normal, still considered normal GFR, normal filtration function of the kidney. But if you have evidence of protein in the urine, you're automatically classified or can be classified as chronic kidney disease, and then that drug should be available and indicated. Sorry.
Hi. Could you respond at the mic, please?
Oh,
Couldn't hear
sure.
you.
Oh, I'm sorry. Yeah.
It may be similar to what Sherry, right?
Yes, Sherry.
I have less than one kidney because I've lost one, and then I had to have a ablation on the other. But my EGFR and my creatinine are still just at the cutoff. So it's
Sure.
still good.
Yeah.
But I have uric acid always in my test. Always have the uric acid. And I'm wondering about how that could be so off when the other tests are still in the normal range.
Sure, yeah.
And it doesn't seem to matter what I do. We can't get the uric acid to change at all. If there's any tricks.
So uric acid, unfortunately, it tends to be elevated in most patients with chronic kidney disease. Some patients more than others, because there could be a genetic abnormality in the enzyme that helps you metabolize uric acid. So I see a lot of patients that have almost normal kidney function sometimes, and they still are battling high uric acid. So not sure if your family history supports that, but oftentimes if it is something that sort of runs in the family, it is likely a metabolic problem that you're encountering, and it's not entirely because of the decrease of your kidney function. That doesn't help for sure, but some patients do have a more difficult time controlling that with just diet and hydration and sort of trying to do the right things.
So, is that something that I could be tested for to find out if I have that metabolic?
Yes, yeah. There are enzymatic tests, sure, yes.
Sorry?
Yes. There are tests for it. They're not very commonly used because it would not really help us change what our management though.
Mm-hmm.
So we usually recommend just trying to treat it with medications. So, we try to get that uric acid below goal, which is less than 6.
Okay, thank you.
We have a question. Hi, thank you for your lovely speech, very informative. My husband has been, it's 24 years since his nephrectomy, and it's 6 years on a TKI. So we're now on a really, everything's been manageable, but the new one that he's on, Levantinib, Lenvima, is causing blood pressure issues that are just so expansive over the others. I did a lot of research and I came up with the fact that the few studies I could find on PubMed seem to favor ARBs over ACE medications.
Yeah.
So his doctor changed him to an ARB. He also takes a channel blocker and a beta blocker. I just recently started some diuretics, which of course we've always avoided with one kidney that's been holding down the fort for all these years. Is there anything that you found treating patients who are on TKIs that may be of benefit that we still can't really get advantage of?
TKIs are sort of very unpredictable.
This one is the most damaging to the kidney.
And I've seen a slew of reactions, from different types of vasculitis to different types of skin reactions to I've seen a lot of different reactions. Unfortunately, everybody's immune system responds differently to this type of drug.
One time his side effects are basically non-existent, other than this insanity with blood pressure.
Yeah. So I think there is no one drug that would sort of fit all or be able to get this under control. Unfortunately, it would just have to be, trying different regimens, different sort of.
Have you noticed any difference with an ARB versus an ACE with this? Is there any validity to that?
Some patients do respond better to ARBs.
And also with amlodipine, there's another drug that starts with a F or a P, and supposedly you're getting 30-point differences in your blood pressure. That one works better. Have you had any experience with that? They're similar.
They are. Nifedipine is probably what you're saying. Yes.
Have you had any experience with that working better than amlodipine?
It can.
It can.
It can.
I will mention it.
But I think the essential piece here is adding that diuretic, and I know you said you were worried about it.
Well, because of the fact that he hasn't had it with this drug yet, but I anticipate it may come, because after 6 years of TKIs, we sort of know he hasn't had any diarrhea, which when you get diarrhea, it's almost a diuretic of its own.
Yes. So you have to be careful avoiding, dehydration. Diuretics can be started and stopped. But fortunately they're short-acting drugs or intermediate-acting drugs, so they will be out of his system pretty quickly. Therefore, if anything occurs of such GI symptoms or GI effects, stopping the diuretic right away should not sort of.
He also has no adrenal glands, which adds to the problem. So we've lowered his we take hydrocortisone and
fludrocortisone.
We've lowered the fludrocortisone.
So those should help too, reducing the dose.
Is there anything you've ever added besides an ACE or an ARB, a channel blocker, a beta blocker, and hydralazine, and what else? Am I missing something?
Yeah, there's up to 7, so you're at number 5.
Well,
Let's hope you don't need to get to 7, but.
Is there a 7? His GFR is dropping, his creatinine, which I was so proud of, was perfect. That's taken a plunge. Protein in the urine is going up, and the blood pressure is really not in any way controllable right now.
Yes.
Do you ever add another component there?
If needed, yes.
Should I ask what family that would be in?
It would be an alpha blocker, like a clonidine.
Okay, I've mentioned that.
Yeah.
Okay. Have you found, when you go with a clonidine or clonidine, have you found better success with a patch versus a pill?
It's a patient preference usually.
It is. Well, thank you so much.
Absolutely, no problem.
Anybody else have a question?
Thank you. Thank you.
All right, thank you.
Okay, thank you all for coming, and a special thank you to our speakers. I know the day is done, but your fight will still continue and has just begun for many of you. I hope you were given inspiration and information that will be helpful to you, and hope you made some good connections today. The video will be on our website in a couple of months, but we have many other videos from past symposiums posted there. And I think you have our website, and we also have Facebook support groups that I encourage you to sign up for. We also have what we call kidney cancer conversations that are live speakers on Facebook. We also have them on as a video on our website, so please go there for more information. And we have links and other great things for you. I do know our day has taken longer than anticipated. If anybody wants to stay and go to the breakout rooms, we will be there for you, but I understand if you just need to go on home because it has been a long day for all of us. So again, thank you, and safe travels home. Oh, please, if you got a survey, please fill that out. We have some more survey blank ones on our table if you didn't receive one. That will help us for future symposiums on subject matters, etc. And your ideas are always welcome. You're welcome to email us with future ideas or what you'd like to hear about. So safe travels home, and thank you so much.